Good morning, everyone, and welcome to Paediatric Emergencies 2024. I'm just going to share my intro screen, and then we'll get started. 2 seconds. Hopefully everyone can see that. Are you seeing the presentation okay there, Chris? Yeah, perfect. Grand. So welcome to Paediatric Emergencies 2024. My name is Ben McNaughten. I'm a consultant paediatrician based in the Royal Belfast Hospital for Sick Children. And I'm delighted to open this conference today. The theme for this year is waiting for the retrieval team. This is now the 6th time we've run this course and the 5th version of it that has been online. One of the benefits of being online is that we're able to open this up to people from across the world, and it's been great looking through the feedback over the years of where people are joining from, where people are accessing the content from, and we're absolutely delighted to welcome you today wherever you're joining us from. From those who have attended before, you'll notice that the format is very similar. This is the program for today. It is available on the Paediatric Emergencies website, so if you're keen to check it out at any stage, please go there to access it. As you'll see, we have lots of great talks on how to manage seriously unwell children who might need a more intensive care or high dependency care. We have lots of great speakers, and you'll recognise that a lot of the names from previous courses. We'd like to mention, I give a special mention though to Gyula Tövisházi, who is joining us from Hungary. Gyula is a paediatric anaesthetist, but is also medical director for a paediatric transport service in Budapest in Hungary. So Gyula, it's lovely to have you along, and thank you very much for joining us. So we really look forward to hearing from you later.
Thank you, guys. It's great to be here.
Thank you. As you'll be aware from previous, we are encouraging this to be interactive. The speaker's been given half an hour for each talk, with an aim to talk for about 20-25 minutes, with allowing 5 or 10 minutes for questions at the end. We want those questions to come from you, because that you'll be asking the questions that matter to you. So as the speaker is talking, we encourage you to put questions into the YouTube chat. To do that, you will need to sign into YouTube, but it's worth doing that at the start of the day to allow you to interact with us. Please put them in as the speakers are talking, because as the questions come in, there's a team of us working in the background to look at the questions, pull out the ones that we think will generate the most discussion and learning, and pick those out to discuss at the end. If you wait until the speakers finish, we'll probably have already chosen questions. So do interact as we go along. Throughout the day, we will be using Slido. This will allow you to interact. Many of the speakers have integrated Slido into their talks to encourage audience participation. We'll also be using it to vote on abstracts, presentations at the end of the day. This is the QR code, so for the Paediatric Emergencies Slido. So please do take note of that, log in and do join us and interact with us throughout the course of today. This QR code will be available at other stages throughout the day. The conference is registered RCPCH and for CPD. It is important you get your certificate for feedback to show your attendance. To do that, though, we do need you to provide feedback, and certificates will be released on completion of feedback. Please do give us honest feedback, good, and that maybe more constructive criticism as well. That's okay. We do listen to the feedback each year. We take it on board, and we adjust accordingly. Again, this QR code will take you to the Paediatric Emergencies feedback form. So at the end of the day, do fill this in. Let us know what you thought, what worked well, what we could do better, and on completion of that, you'll get your certificate through. Just want to mention our sponsors in particular, and two have donated prizes actually for the abstract presentations. That is Northern Hospital Supplies Limited and Technopath. This is a free conference, and we are very grateful to sponsors who have supported us, but also to them for providing prizes at the end of the day. I'd also just like to mention Helping Hand. Helping Hand is charity to the Royal Belfast Hospital for Sick Children. They've been very good to us over the years in putting on a lot of these courses, particularly in the early days as we're getting things started and providing support and equipment. This conference is free and it's designed to be that way. It's one of the reasons we run it on YouTube. However, we would encourage you, if you've enjoyed it and you have learned something from it, please do feel, we do encourage you to consider even leaving a small donation to Helping Hand, which is our hospital charity, as a way of saying thanks. Doesn't matter, it doesn't need to be a big donation, but if everybody who joined in even left a small donation, that would mean the world to the charity. So please do consider that. Again, there's the QR code, which will take you to the Just Giving page. So something to leave with you and to have a think about it. And we'd be delighted if to see some donations towards Helping Hand as a result of this. That's all I have to say by way of intro. I'm hoping that today is good. It's enjoyable. There's lots of learning, lots of discussion. We want it to be interactive, so do take part. Please stay with us throughout the day, and I really hope you enjoy it. That's all I have to say. So without further ado, I'm going to hand over to Dr. Tudor Oman to give the first talk of the day, which is on Coma. Dr. Tudor Oman is a consultant paediatrician based in the emergency department in the Royal Belfast Hospital for Sick Children. So I'll hand over to Tudor now. Thanks, Tudor.
Morning all, just let me get set up here and share my screen, and then we'll get going here. Okay, so hopefully you can see my screen now. So as Ben has said, I'm Tudor Oman. I'm one of the Paediatric Emergency Medicine consultants in the Royal Belfast Hospital for Sick Children. And I have been given the task of talking to you about the initial management of Coma. Now, there's a bit of overlap through the day. There's going to be a talk about traumatic brain injury at a later date. So my initial presentation is going to be about the assessment of a child coming in with a markedly decreased level of consciousness. I do have a warning, is that I've been playing around with AI imaging, and so a lot of the images that you'll see generated here have been artificially generated, and I thought after a while just sharing the weirdness with you was the way to go. So Coma. Initially, let's look at what consciousness is. So consciousness is a combination of arousal, which is wakefulness or alertness, and awareness. Arousal being the physiological state of wakefulness, and alertness. And this denotes your consciousness in combination with the content of consciousness, such as attention, language, memory, visual, spatial skills, and these together create the capacity of awareness. Awareness is that subjective experience that you get on interacting with environmental stimuli. You can be awake, so you can have your arousal and not have awareness, and not necessarily the other way around. We have a look at the anatomical structures that are involved. We have arousal being a midbrain or a ascending reticular activation system bundle of nerves that interact with mainly the thalamus and hypothalamus, and then the cortex to some degree as well. Awareness is a more loosely connected bunch of nerve fibers that are in the cortexes and the subcortical structures. Knowing this, to me, all it does is it gives us an idea of, well, if this is where these nerve bundles are, then we can figure out, well, what actually causes a decreased level of consciousness. So because you've got the midbrain affected, you can have problems in the midbrain or in the brainstem are going to cause a decreased level of consciousness. We're going to have anything that affects the cerebral cortexes bilaterally is going to cause a reduced level of consciousness as well. And that's inadequate blood supply, such as in stroke, or inadequate substrate, such as in hypoglycemia, trauma, toxins, poisons, or intoxication can also cause a reduced level of consciousness as they affect the entire cerebral cortex bilaterally. Unilateral lesions can also be involved as long as they have pressure effect or mass effect causing damage on the opposite side. So as in this image here, you can see a mass causing midline shift and tonsillar herniation. So this is going to cause a decreased level of consciousness, but a unilateral lesion by itself in general doesn't. Loss of consciousness, as we all know, is a continuum. There's different ways of describing it. One that has come up in the literature quite a lot is delirium, confusion, or disorientation, which has some reduction in arousal, but you can process external stimuli, but not necessarily correctly. Lethargy is more moving on to a mild decrease in arousal, but you're still able to respond to verbal and tactile stimuli. Obtundation, decreased arousal, but the response to verbal and tactile stimuli is there, but it may not be appropriate. And then there's stupor and leading on to coma, which is the most profound state of diminished consciousness and awareness. Now that might sound familiar because when we have a look at how we actually do it in our clinical practice, we use the GCS scale, Glasgow Coma Scale, and this is a guide to assessing someone's level of consciousness through eye movements, opening, best verbal response, and best motor response, with the most profound level of decreased level of consciousness being 3 rather than 0, as I was once handed over by somebody that this child had a GCS of 0. So 3 is the lowest that you can get. This gives us a way of monitoring a child while we're managing them as well. So repeated Glasgow Coma Scales monitors the level of consciousness as we manage the patient, treat them, or if they continue to deteriorate, gives us warning. It doesn't give us any diagnostic clues, but it can give some prognostic factors in certain conditions. In the ED, sometimes we use the AVPU score, alert, responds to voice, responds to pain, or is unresponsive. It's very crude, but gives us an immediate idea of where we are at. A score of P or U gives us a GCS of less than 8. And this is important because when you have a GCS of less than or equal to 8, you have potentially lost your protective airway reflexes, and you need to start to consider whether airway protection is needed. For everybody, a decreased level of consciousness is less than 15. And that is our starting point. So we've talked about the structural of decreased level of consciousness and what might cause it, but in real terms, what are we talking about? Traumatic causes are the most common worldwide, and that can be intentional or accidental. Non-traumatic leading cause is infection. That could be meningitis, encephalitis, abscesses, malaria. You could have metabolic, such as MCAD, which you may get hypoglycemia, or other metabolic conditions in which there are substrates that are floating around that are toxic. Seizures, one of the most common emergency we see in our emergency department, can have profound loss of consciousness as well. Then intracranial causes, hemorrhage or mass lesions, toxins, hypoxic ischemic injury from either prolonged cardiopulmonary resuscitation, drowning, and that actually has the worst prognosis out of them all. And then hypertension leading to hypertensive encephalitis, encephalopathy, which has a good prognosis as long as you manage it well. So there's a number of different causes, and we're going to look at some of those. So the incidence is about 30.8 per 100,000 children under 16 years. Non-traumatic and traumatic are similar numbers, but because non-traumatic is a larger group by itself, it's the most common, higher in the first year of life. Infection most common non-traumatic, and non-traumatic and non-accidental causes are more frequent in younger children. I thought this was an interesting figure, is that 2/3 of infants had non-specific cause identified for their decreased level of consciousness. So coma is a medical emergency. You've got to remember that coma is a symptom rather than a diagnosis. We have a child who has some sort of problem working at them that has reduced their level of consciousness, and we need to identify that. And while we are identifying it, we need to try and make this patient as stable as possible to prevent ongoing damage or secondary brain damage to this patient while we investigate, while we identify the cause. So our aims are to minimize neurological damage, to look for the cause and initiate treatment in a prompt manner. The outcome can be quite vast, so you can recover with appropriate treatment, or some of the causes can just resolve with time, once removed from a noxious stimulus, for example. They could die, or they could progress to having a more deep state of unconsciousness, such as persistent vegetative states or minimally conscious state. So what I've based this talk about is there's a few guidelines out there talking about how you approach a child with unconsciousness or coma. And I want to talk about the structured approach to these children to try and ensure that while you are investigating this child, you keep this person safe, and giving you time to identify the cause. It has to be said that there are a number of aspects to this. Is you've got your primary assessment, your A, B, C, D, E, F, G approach, and that's because I'm a simple A&E doctor. And so A, airway, breathing, circulation, disability, and don't ever forget glucose. But you've also got your observations, you've got your history from the parents that you might get just little bits of, or a rapid assessment on your initial review of the child. And all of these give you little bits of information. And I'd say it's very rarely that we don't get a clue as to what may be going on with this child. It's not just a child lying there with normal observations, no indication of what's gone on. There are things that we can start to consider that would help us go down a diagnostic process. And if not, there's process that we can move on. History is important, and although it's not part of your A, B, C, D initially, just wanted to touch base. So if a child has a known chronic condition, such as a metabolic condition, a seizure condition, a liver problem, these can all give you clues as to maybe what has gone on with this child. The speed of onset can give you clues, such as a sudden onset may indicate an intracranial bleed, seizure, or toxin ingestion, or slow onset may indicate something like a metabolic condition in which there has been gradual buildup of a substrate or drop in the substrate, leading to this coma. Space-occupying lesions that are slowly expanding, infection, headaches, vomiting, fever, altering levels of consciousness, change in personality over the time. All of these give you clues and can be sought out in quite a quick format, having a list in your head as to what you may ask the parents. Are there drugs available in the house? Has the child a history of self-harm or drug ingestion? Are there infant deaths in the family or young deaths in the family? And then inconsistency or concerning history from the parents. These all need to be taken into consideration as you approach this child. And the importance I'm saying is that you have you have all of these aspects, and they don't happen individually. You don't always just do your A, B, C, D, and then ask the questions and then do some treatments. These all happen simultaneously. So airway, we always approach the airway first. And what I'd say is that you don't know what's happened to this patient. This could have been a shaken child. It could have been a traumatic injury. You don't know. It could have, if it was a dive into a pool. So I should have probably given you the history. 6-year-old boy brought in unconscious by the parents, was previously well, no past medical history, no drug history, found unconscious in bed in the morning, as didn't turn up for breakfast. And that's all the history that we have. So we're going to consider C-spine. Do we need to protect the C-spine? Are there injuries that we don't know are existent? So if you have high suspicion of non-accidental injury or some other form of trauma, or there's trauma in the history, then maybe C-spine precautions might be good. I've talked about GCS being less than 9 before and the need for airway protection. So if I told you that this, I've added in GCS at the top here because the airway person often does a quick assessment of conscious level when they're assessing the airway. Is the child responding? Are they responding to pain or not? And if they're not responding to pain, that's a quick assessment saying this GCS is very low. Maybe we need to do some airway protection. Okay, I'm going to talk to you about ventilation and the need for the benefits of that in breathing. So airway assessment is essential. At this point, you should also be getting some observations on, and most of the guidelines would state that there should be a minimum data set of your respiratory rate, your saturations, heart rate, blood pressure, conscious level, and temperature taken every hour. In the ED, we have constant monitoring on in an unconscious patient, but are aware that these children may be unconscious or in coma for prolonged periods of time, and hourly observations is the bare minimum that should be going on. So in our child here, we're looking at their effective breathing. This is an unconscious patient who is not responding to pain. So the first thing you really want to do is assess whether there are signs of life, or whether this child is actually not in cardiopulmonary arrest. So that needs to take place first. Looking at the effort effectiveness and efficacy of that breathing pattern. If they are breathing, you're going to decide, well, what kind of breathing are they doing? I've got a respiratory rate of 45 breaths per minute for this child. So that's fast for this age group. So why are they breathing fast? Tachypnea can be seen with pain, hypoxia, metabolic acidosis, pontine injuries. If their breathing was slow and irregular, you might be thinking of periodic respirations. Some of the books would say diabetic ketoacidosis, although often I see a child with diabetic ketoacidosis with an increased respiratory rate as they try to blow off their excess acidosis. But deep sighing respirations is classic for that. Metabolic acidosis, as I've said, and then sedatives and intoxication can cause hypoventilation as well. So what I'm saying is there's different clues as to what potential causes are based on the respiratory rate, based on the observation, that we are seeing as we move through the assessment. And these all give us clues towards the end diagnosis. Ventilation I had mentioned. So if you have an unconscious child with an unprotected airway, you're wanting to protect that airway from possible inhalation of foreign body vomit, blood, or anything else, so that it doesn't worsen their respiratory function. Ventilation in unconscious children and ones with potential brain injury have a lot of different benefits to it. Ventilating protects the airway. It allows you to control the level of carbon dioxide within the blood, keeping it within normal levels, 4 to 4.5. This allows maximal cerebral perfusion and prevents secondary brain injury. Hypo or hyperventilation can result in worsening brain injury, secondary brain injury, due to poor cerebral perfusion. And it allows you to also take away the increased work that the heart is doing to maintain normostasis. So it removes some of the metabolic work that the body needs to do and reduces the oxygen requirement that the body has. So ventilation can also then provide an opportunity for putting lines in, doing procedures such as LPs, going to MRI scanners or CT scanners for your further investigations in a safe, planned manner. So in an unconscious child where you're struggling to know what's going on, who's got a markedly reduced level of consciousness, intubation and controlling of that ventilation is a good way of safely proceeding down a number of different investigations. However, you need to complete your ABCD and do a full assessment of their neurology before you paralyze them. So we're getting set up for that in this child now. So our circulation, so in that respiratory, again, I've said that the saturations are normal and the airway, the air sounds are in the chest are clear. There's no added sounds. So this is a child who is unconscious and has good air entry, but is breathing fast. So I'm thinking more along down the lines of a metabolic abnormality or some form of acidosis building up or other structural abnormality. Moving on to circulation, as again I said, we need our heart rate, our blood pressure. We need to do a full set of observations. Tachycardia in this child, 160 beats per minute. This can occur with fever, pain, hypovolemia, cardiomyopathy, arrhythmias, as well as status epilepticus, which is on the list as to what might be going wrong with this child. Bradycardia can be a pre-terminal sign. Is there hypoxia present, leading to bradycardia and then eventually cardiopulmonary arrest? Or is there raised intracranial pressure in which the blood pressure is rising, the heart rate is dropping, and then there's becoming irregular respirations or fast respiration. And that's called Cushing's triad, which we're going to talk briefly about as we go through this. So in this circumstance, we don't think so because the blood pressure is low. So we are dealing with a child with a tachycardia and a low blood pressure for some reason, which brings in the concerns regarding sepsis, hypovolemia due to cardiac causes, arrhythmias, etc., poisoning. Low blood pressure can be a result, low blood pressure can result in worsening brain injury as well. So in children with unconsciousness with an unknown cause, you're wanting to maintain their blood pressure within normal limits. And you're going to give fluid boluses to these children to maintain a normal blood pressure for their age. If it is due to trauma and it's loss of blood, then you should be replacing that fluid with blood. If it is if it is sepsis, then you're going to replace it with fluids, and you're going to move on to inotropes quite quickly if you're concerned about raised intracranial pressure and fluid overloading them. And that's where you're going to get your PICU consultants in to try and manage the inotropic supports and ongoing fluid management for a difficult patient. So if there's intracranial concerns, be cautious with the fluid boluses. Hypertension can be due to a number of different things as well: pain, agitation, certain toxidromes such as your sympathomimetics and stimulants, and then raised intracranial pressure leading to your Cushing's triad as well. Investigations you're going to send off at the same time. You're going to send off your blood gas. This is going to give you an idea of whether they're acidotic, what their CO2 and O2 levels are. Are they retaining? Is this metabolic? Is it respiratory? What their lactate is and what their glucose is. And glucose should never be forgotten. And guidelines would say that you should have a glucose done immediately on arrival of an unconscious child, or at least within the first 15 minutes. And this can give you a lot of information in children. High metabolic rates leads to them burning off their sugar significantly. Prolonged starvation doesn't necessarily get managed so well in the younger children. So there's a number of reasons why children who are unwell with high temperatures or just trauma to their body, stress, have low sugars, let alone the metabolic conditions. You're going to check your electrolytes. your liver function, make sure there's no hepatic encephalopathy going on, full blood picture for your white cells, your blood culture for your infections, ammonia for some of the metabolic conditions that can cause coma, and a urine dipstick for infection, but then also importantly for toxicology to ensure that drugs of abuse haven't been taken in this circumstance. So, as I've said, you need to have glucose within 15 minutes of arrival when you're assessing, and this comes into assessing of disability as it's a common cause for children to have a decreased level of consciousness. We're going to assess our GCS and we're going to then monitor that along with our observations for any signs of improvement or deterioration. We're going to look at our fundoscopy, looking for papilledema. Pupillary responses can give us clues as to what's going on in the brain and where the lesion may be, or what potential toxins may be involved. Reflexes, motor responses, meningism, stiff neck, for example, need to be considered as a quick assessment of their neurological disability as you go through this. If their blood sugar is low, you're going to immediately give a bolus of dextrose to bring that up and then recheck that blood sugar within 15 minutes. In the UK, we're currently giving 3 mils per kilogram of 10% dextrose, but that has changed over the years numerous times, from 2 to 5 to 2 now to 3. So whatever your local policy is, you're going to give a bolus of dextrose. You're going to consider neuroprotective measures, which I said we're going to discuss later on. The neuroprotective measures include a 30-degree head-up tilt to allow for reduced drainage of blood from the head so the blood isn't pooling, like in this kid with his head flopped down. We're going to sedate him, give him some pain relief, stop him moving, reduce his metabolic demand. We're going to make him normotensive, normothermic, normoglycemic, normocarbia, and correct electrolytes and pain relief, and give him pain relief. There are some other factors, such as if you have a cervical collar on him, you may want to loosen that to allow for SVC drainage. I had mentioned Cushing's triad before, the triad of bradycardia, abnormal breathing, and hypertension. If you are seeing this and you have impending herniation, you want to treat this aggressively. Hypertonic saline is the choice that we have in our hospital. We do have mannitol, but we're more used to hypertonic saline, and giving a bolus of this as soon as you are concerned regarding the possibility of raised intracranial pressure. The other treatment is to hyperventilate them for a period of time. Normally, hyperventilation can cause worsening of secondary brain injury, but it is a lifesaver in a child who has evidence of potential herniation. So it needs to be considered at that point. Looking at the eyes, we have a number of different responses that we can get. We can get anoscoria, unilateral dilated pupil, which suggests brainstem insults or a supratentorial lesion that is causing compression of the oculomotor nerve or the nucleus within the brainstem. You can get bilateral dilated pupils. Are they fixed? If that is the case, then this could be seen within midbrain injuries, but can also be seen with some sympathomimetics and anticholinergics as well. So just check what they've had prior to making a judgment as to whether they're fixed and dilated. Irregular pupils could be seen in trauma, conjugate gaze deviation and frontal lobe lesions, and small pinpoint pupils could be a pontine injury, or could be metabolic disorders or certain intoxications. There's cerebit and decorticate posturing. It comes into your GCS, but can also give indications as to where the lesions are. This is when you give a painful stimulus, the child will perform these postures. What I would say is I see this quite commonly following a prolonged seizure, which often resolves quite quickly afterwards. But if you see these, you have to wonder whether there is something else going on. So decerebral posturing includes the extension and internal rotation of the arms and legs. Decerebral posturing implies brainstem involvement. and is the worst prognosis. The corticate, considered not so severe, but you get flexion of the elbows and wrists, and this can imply potential injury to the cervical spine tract or cerebral hemispheres. Moving on to exposure, it's important to do temperature. We're talking about a potential cause of infection, which is most likely in children. And in high temperature, you can have that due to infection, but you've got to remember it can also be due to inflammatory processes, as well as prolonged status epilepticus, neuroleptic malignant syndrome, hyperthyroidism, and also anticholinergic poisoning. If at all, even with a normal temperature, you are concerned that sepsis is a potential for this child, and I can tell you now that if I had an unconscious child with an unknown cause that I was struggling to find a diagnosis for, I'd be doing empirical antibiotic coverage until I knew otherwise. So if you're in doubt, start antibiotics. Hypothermia can also be due to infection, but is more likely to be environmental. So if you have a trauma that's been lying out for a while, or a drowned patient, or you have hypothyroidism or drug ingestion, those are more likely to cause hypothermia. Severe hypothermia may be contributing to a reduced level of consciousness, and so consider that and warm the patients back up to normothermic. Exposure is vital in children. Without exposure, you're going to miss the rashes such as petechiae, purpura. You're going to miss the cherry red spots of carbon monoxide poisoning. You are going to miss the signs of abuse or injury. And although we don't like to think about it, we have to in pediatrics. It is part of our job to assess this child, check that the history is consistent, that there are no concerns regarding a non-accidental injury. And I cannot tell you how many times I've been resuscitating an unconscious child only for the parent to tell me something, and that makes me go, oh, I need to consider non-accidental injury. And unfortunately, too many times it is actually the case. So exposure is very important. Any child who is unable to communicate with you when you're assessing them, you need to have a look at their body to ensure that you're not missing anything. Further investigations are obviously neuroimaging. CT modality is the first choice initially because you can get it quickly. It doesn't take as long as an MRI. And when you've got an unstable patient, you're still trying to stabilize. CT is what you can choose. It also allows for repeated imaging over time. MRI gives you more specific structural information and more prognostic information, but takes a little bit more planning. ECG is vital. This could be an arrhythmia. It could have been a seizure, but you're looking for structure, you're looking for rhythm on this. Lumbar puncture is key, but you need to be careful with lumbar puncture in an unconscious child. So if there are signs of raised intracranial pressure, do not do a LP. If the GCS is less than 8 and or deteriorating, or there's focal neurological signs, or the GCS is less than 12 after a seizure lasting more than 10 minutes, you do not do an LP. If the CT or MRI suggests CSF pathway obstruction, you do not do an LP. And if there's clinical evidence of circulatory shock or meningococcal disease, you don't do an LP at the time. Okay. EEG can be helpful, as I've said. So with the, you're thinking, could this be subclinical seizure activity? And if you are thinking that this is subclinical seizure activity, you're going to treat it. And I should have covered that in D. Is that seizure is a likely cause as well. And if they're subclinical and you don't have EEG available, you're going to potentially try a dose of lorazepam and maybe even some Keppra to try and reduce that. In your neuroprotection of significant traumatic brain injury, anti-epileptics are also considered. So consider seizures, and if in doubt, treat for them as well. Our patient has increased respiratory rate despite clear chest. He has tachycardic, he's hypotensive, he has a metabolic acidosis with normal electrolytes and glucose with a carboxyhemoglobin of 32. His GCS of 5 with responsive and equal pupils. He has a normal temperature. He has bruising over his shins and erythema over his knuckles and fingers. This is a patient who I tried to make sound like the parents had an inaccurate history, and NAI must be considered and sepsis must be considered for this child. For this child has carbon monoxide poisoning. He has signs of cherry red spot with his knuckles and his fingers being red. The bruises over his shins is normal for a 6-year-old. And everything else is relatively normal except for the hypertension, tachycardia, increased respiratory rate from the metabolic acidosis. All right. So that was just an example. Carbon monoxide poisoning is actually one of the hardest to diagnose unless you have immediate access to carboxyhemoglobin, and it can be very vague in the history. So when you're looking at your gas, look at all components on your gas rather than just presuming you need to know the acid-base disturbance, and that's it. Okay. In summary, because I'm over my time already, first lecture of the day and I'm over my time. Summary, coma is a symptom of underlying problem. It is not the diagnosis. It's a medical emergency and you need to follow a structured approach, A, B, C, D, E, F, G, which is don't ever forget glucose at the end there. You need to take in the observations, initiate emergency management to stabilize the patient while you take further history and do further investigations to identify the cause. Make the patient safe, continue to manage them while you come up with a diagnosis. And keep an open mind. Do not get your mind set on one thing. If I'd made that more obvious about an uncertain history, people would have been going down the NAI route. But this is a case of carbon monoxide poisoning, and if you kept your mind closed, you may not have noticed or seen it. So keep an open mind at all times, but consider all aspects of the potential diagnosis. So I'm going to open up the floor to questions. The code on the screen there you need to put into the feedback form to give feedback on this talk. What I would suggest if you're here for the day is just to keep a record of all the codes and put them all in at the same time you do your final feedback form, and that means you can just do it once and get credit for all of the course, all of the talks that you've been to.
Thanks very much, Tudor. Really important talk for anybody who's on the front line receiving children in the emergency department. And one of the big challenges that in that state, it can be very undifferentiated. So you need to keep an open mind, think of all the differentials. We do have time for a couple of quick questions. The first, one of the questions came through in the chat, either to yourself, Tudor, or any of the panel, is that in what situation would you consider doing an ammonia level?
Sorry, just trying to find my Zoom talk here. So the RCPCH guidelines for reduced level of consciousness in a child includes ammonia as part of their routine bloods. So if you have an unconscious child who doesn't have a source, you are unsure as to what's going on, I think it's reasonable to do an ammonia level on them. The difficulty is whether your labs can process it in time and you can take it in a way that the result is interpretable. But I think if you have an undiagnosed child in coma, it's reasonable to do an ammonia level.
Okay, thanks, Tudor. And the second question is really around sedation, and I suppose a question around, is there any particular sort of sedation or agents that you would prefer to use for neuroprotection in these sorts of scenarios?
So I think neuroprotection is going to be discussed later on, but I'll leave this up to the ICU and transport guys. This is the Paediatric Emergencies talk, so I'm assuming there's ketamine and rocuronium involved in there somewhere. So.
Yeah, I think from an intubation point of view, most of us are using ketamine. Will be covered later on because it preserves your cerebral perfusion pressure. Everything else will drop that. And the worries about ketamine increasing intracranial pressure aren't really founded. In terms of sedating these patients, that was part of the question, I think, in the chat. We're not going to sedate a patient who's partially conscious. You're going to lose your neuro exam, you're going to lose your airway. So in these kids that are slightly unconscious, it's all or nothing. As you suggest, it's going to be an anesthetic, secure the airway. The downside of that is you lose your neuro exam. And then once we've got them intubated from in terms of neuroprotection, first line, we just use our standard sedation, be whatever that is, morphine or fentanyl with midazolam or whatever you're going to use. But there's nothing particularly special that we use once they're asleep.
What I would agree with Chris. What I would add is that increasingly, especially after the Eclipse study and concept, we've been loading these patients with 40 per kilo of Keppra because it's bound to be safe, quick to give, with equal efficacy to phenytoin. So once you've paralyzed and tubed these patients, you have no means really, especially if you're moving them, of knowing whether they're fitting or not until they get to an ICU where they can neuro monitoring and CFM or EEG monitoring. And even that within the UK is inconsistently done. So you don't know if they're fitting under that paralysis or not. So best play it safe and preload them with long-acting anticonvulsants such as Keppra, which is safe and doesn't cause arrhythmias like phenytoin would, and then start them on, if you're planning to keep them intubated for a few days, keep them on a maintenance dose of anticonvulsant on top of that. And that's important for neuroprotection.
Perfect. Thanks, Chris Costas. And Tudor, thanks again for that talk. You will need to give us a lesson on how to generate these AI images. That's something we could learn from you. So thank you. Really encouraged to see people putting questions in the chat so early on. Sometimes it does take a bit of time for people to warm up. So please do keep doing that because it really helps us address your questions, your queries as we go through. I'm going to now move on to the second talk of the day, which is from Dr. Chris Flannigan. He is a paediatric intensivist in the Royal Belfast Hospital for Sick Children. And he's going to talk to us today about how to use vasoactive drugs. So Chris, over to you.
Thanks, Ben. Let me just get my screen up. So hopefully you can see that okay and hear me okay?
Perfect, yeah.
Yep, spot on. So you are going to want to get signed into Slido for my talk. You can see the QR code in the top right of the screen, so make sure you do that at this stage. So I'm going to talk to you about vasoactive drugs, and before everybody switches off and says that's not something I use, it's not going to be the fine-tuning of vasoactive drugs in the ICU that I'm going to be talking about. It's using them in the initial resuscitation and stabilization of the critically ill child before the retrieval team come out. So hopefully this is going to be something that's going to be relevant to most of you, because whether you like it or not, there is going to be situations where you are going to have to start these drugs. Let me just get my slides moving. So as I mentioned, I'm going to do this with a series of cases, and I'm going to be asking you guys to vote about what you think is the right option for each of these cases. So we're starting off with a 1-year-old girl. She's got group A strep, and she's currently got septic shock and being prepared for intubation. Her airway's patent, she's saturating nicely on 100% oxygen, a bit tachypneic at 55 breaths per minute, and she doesn't have the most pretty gas. pH is 7.12, and we've got a mixed respiratory and metabolic acidosis. And the gas is quite alarming. We've got a lactate as high as 11.1. We can see the reason for that when we come on to assess her cardiovascular system. Heart rate's all the way up at 195, cap refill is 6 seconds, and she's markedly hypotensive with a MAP of only 42. She's already had 40 mils per kilo of fluid resuscitation. She's only responsive to pain, and she's got a temperature of 39.2. So I want you to go over to Slido and vote for which of these options you think we should go with. So we're happy enough. We don't need to give her any more drugs at the moment. We can just go with fluid. We can put her on an adrenaline infusion, a milrinone infusion, a noradrenaline infusion, or use push dose adrenaline. And I'll give you a little bit of time to get your answers in. Okay, so I think most of you are going for the adrenaline infusion. So I'm going to come back to this question. I will go through a little bit more. So when I'm faced with a patient like this, there's a few things I'm going to ask myself. The first is, do I need to do anything with this patient's preload? So do I need to fill them with more fluid? Do I need to do something with their function? So do I need to improve the cardiac function? And do I need to do something with their afterload? So that's the vasculature. Most commonly, do we need to squeeze that a little bit? Or sometimes do we actually need to dilate that to improve flow to the organs? And you might be wondering which of these complex methods we're going to need to use to decide what we need to do with this patient. Well, you'll be pleased to hear the answer is, at least initially, none of them. Because we're going to start off, this patient is crashing, and there has to be a standard set of care that somebody can initialize without the specialist skills to do invasive monitoring, ultrasound, or different things like that. So we're going to manage this patient initially as per our APLS guidelines. So in terms of the preload, the safest thing to do is assume this patient is empty with their type of shock and fill them full of fluid. and you're going to stop when there's signs of fluid overload. So the guidelines would say you're going to give 40 mils per kilo of fluid. If they're still shocked, you're going to give another 20. This child's circulating volume is going to be 80 mils per kilo. So by giving them 3/4 of the circulating volume over a pretty quick amount of time, you can safely assume that you have filled this circulation up. In terms of the function, yes, it would be great to pop the echo probe on, and some of us may do that initially if we are there and we do have the skills to do that, but you don't need to. What you're going to do is assume this child has some myocardial dysfunction, and the vasoactive drugs that you're going to use are going to have to support the heart. In terms of afterload, again, you're going to go with the most common thing here, and that is to assume that you are going to have to squeeze the afterload a little bit and pick a drug and section of fluids that do all of that. The most important thing with this child is actually to stabilize them for intubation, because you're about to give this child an induction agent, which is highly likely to make them decompensate and arrest. And even if you resuscitate them absolutely perfectly, they are still likely to decompensate when you give them that induction agent. In terms of what we use for vasoactive drugs, I think all the guidelines are fairly clear. Adrenaline is our first-line drug. We moved over from dopamine a number of years ago, although the evidence for doing so is actually quite weak. But that is what the recommendations are. Adrenaline tends to be the first-line drug that we go for. So let's take a look at adrenaline. Now, if somebody's to put this slide up in a talk I was looking at, I would immediately switch off. It's got lots of receptors, doses, half-life. Don't do this. All the stuff on this slide is really, really important. It's going to help you when you have one of these patients, and it's certainly going to help you for the next lot of cases that we're going to come on to. So bear with me for a couple of minutes while we go through it. So adrenaline works on your adrenergic receptors. We've got alpha and beta receptors. The alpha receptors are the ones that squeeze the vasculature and increase your systemic vascular resistance. The beta 1 receptors are the ones that increase your heart rate and increase your ventricular contractility, whereas your beta 2 receptors, they will actually cause a little bit of peripheral vasodilatation. Although in all but very low doses of adrenaline, we're not going to see this because the alpha effects are stronger and they'll cause the vasoconstriction. And don't forget, due to its beta 2 receptor effects, adrenaline will cause bronchodilation. So we do have a difficult to manage asthmatic. Putting them on an adrenaline infusion for that is actually quite helpful. In terms of the dosing range, it will vary depending on the regime you look at, but it's somewhere between 0.01 and 1.5 mics per kilo per minute. In the lower doses, the beta effects are going to predominate. So you're going to increase your heart rate, increase your inotropy, and cause potentially a little bit of vasodilatation or do nothing to your afterload at those lower doses. By the time you're getting up to about 0.1 mics per kilo per minute, you're starting to get the alpha effects predominating, which are going to cause your vasoconstriction. You're still going to have those beta effects, and they will increase as the dose goes up, but this is the dose you're going to want to start for our patient with septic shock, and that's what the guidelines recommend. And the reason for that is because this is the dose that you're starting to get a squeeze in the afterload, which is what the majority of these patients are going to need initially. In terms of adrenaline, it works very quickly when you start it. It has a very short half-life, around about 2 to 3 minutes. So you need to have a really secure line, because if you lose your line, you're going to lose the effects really quickly. And if you're changing it from one line to the other, you can't simply take it off and move it over, because even that short duration where the patient isn't getting the adrenaline could cause the blood pressure to plummet. You're going to need to double pump it over. In terms of the special effects, we've already mentioned asthma is one place where it might be particularly useful, and anaphylaxis is another situation where you're going to find adrenaline particularly useful. Situations I don't really like using adrenaline, particularly high doses as a depressor. I'm not a big fan of it in older children. The reason for that, I find it causes quite a marked lactic acidosis, and that lactic acidosis is not due to an oxygen delivery problem. So adrenaline causes breakdown of glycogen, which makes pyruvate, which makes lactate. And older children just seem to have this more often. And the problem is in septic shock, we're using our lactate clearance as a marker that our patient is getting better. So if actually we're treating our patient and their lactate goes up, the first thing you think is that treatment actually working? And you might falsely move away from a treatment that's working because your lactate is increasing. So I don't mind using it in older patients as an initial drug to get them resuscitated. But later on, I won't be happy leaving them on high-dose adrenaline as a suppressor because I think it can cloud the picture. So how do we give adrenaline? So we're going to give it, one method is by infusion, and this can go centrally or peripherally. You've got the methods up on the screen that I use to make it up. It will vary a bit from region to region. So centrally, 0.3 milligrams per kilogram and 50 mils. You run it at 1 mil an hour, and that gives you your 0.1 mics per kilo per minute. To make it up peripherally, it's 1 milligram of adrenaline, 50 mils of saline, 0.3 times the patient's weight. So for a 3 kilo child, 0.9 mils an hour, a 10 kilo child, 3 mils an hour, and that gives you your normal starting dose of 0.1 mics per kilo per minute. The biggest thing when starting adrenaline is to factor in your dead space. So you can see here this cannula and connector, the total dead space is 0.4 mils. If we were to start a peripheral adrenaline infusion on a 3 kilo child, it would actually take 27 minutes to get through the 0.4 mils of dead space, which is really alarming. So if you were starting this thinking you're treating your patient and you haven't factored the dead space in, you're not for almost half an hour in a small baby. So you need to know the dead space of the connectors that you're using in your department. You can just put a syringe with saline onto it, flush it through with a 1 mil syringe and see how long it takes to come out the end. And then you save that number away. So the next time you're starting a critical drug on your patient, you can bolus that volume through the dead space and the drug is going to reach the patient without any delay. Another way to do adrenaline, and it was one of the options, was push dose adrenaline. So to do this, you take 1 mil of your rest dose adrenaline, 1 in 10,000, and dilute it by a factor of 10 by adding 9 mils of saline to it. So that's going to make you adrenaline 1 in 100,000 or 10 mics per mil. In terms of dosing, it's the same volume that you would give a child in a cardiac arrest, so 0.1 mils per kilo. But because you've already diluted it by a factor of 10, you're given a tenth of the dose that you would in a cardiac arrest. Another important thing to remember, if I had an adult who was I needed to give this to, I would give them 1 to 2 mils at a time. So for anybody who's 20 kilos and above, you tend to cap out at a max of 2 mils at a time, and that works fairly well. So let's go back to our patient and see what we need to do with them. So in terms of, we've already decided adrenaline is the treatment of choice. We're going to give them some more fluid, fill the circulation up. And in terms of the regime for adrenaline, we can either give them an adrenaline infusion starting at 0.1 mics per kilo per minute, or we can give them some push dose adrenaline. And when I'm trying to decide between the two, the question I ask myself is, do I have time to make up this adrenaline infusion to get it connected up to the patient through the dead space and then titrate it to effect without the patient arresting? If the answer is yes, then I'll go with the adrenaline infusion because it gives you smoother control of your blood pressure. With the push dose adrenaline, you get big swings where it goes up and then you have to watch very closely and it'll fall away again and you need to give another bolus. So adrenaline infusion would be the preferred choice if you have time. If you don't, I would go with push dose adrenaline. So I would look at this patient and I would see that they have a lactate of 11. They're only responsive to pain and they are hypotensive, which we know is a peri-arrest sign. And I would say it's not safe to prepare an adrenaline infusion. The time it takes is too long. I would give them a push dose adrenaline. I would monitor them closely and repeat that as we need to, get them up on an adrenaline infusion, and then titrate that to effect. Even if we did have time to get the adrenaline infusion up in this patient and we were getting them ready for intubation, I would still expect them to decompensate on intubation. And I would have push dose adrenaline prepared as well, because that's highly likely to happen. Okay, let's go on to case number 2. So this time we've got a 12-year-old with acute lymphoblastic leukemia and neutropenic sepsis. So their airway is currently patent. They are a little bit tachypneic, 21 breaths per minute, but they are parexic at over 40, so that's not a big surprise. They're saturating at 100% in air. They've had a gas done, which shows an elevated lactate of 4.5. And because this has come from a central line, we've also got central venous oxygenation saturations. They are low at 52%. If you're not familiar with these, generally if your blood goes at 100% saturated, when you sample it from a central line, there can be allowed up to 30% extraction of oxygen. So your sat should be at least 70% saturated. If it's more than this, it would point out that you have a problem getting oxygen to your tissues. And the common reason in septic shock is there's just poor perfusion to those tissues. So it's an early warning sign that this patient might not be perfusing their organs particularly well. We can see the reason for this when we come onto the cardiovascular system. We are hypotensive with a MAP of only 48. But when we look at the blood pressure, the thing that I'm noticing is the diastolic is quite low compared to the systolic. Normally it would be about half the systolic. So we've got a widened pulse pressure and we've got other signs of warm shock here with flash cap refill time, bounding pulses and warm peripheries. So we've already given 40 mils per kilo of fluid resuscitation. And then we need to decide what we're going to do next. So I'll put the options up on the screen. So if you want to go over to Slido and vote, and the options are exactly the same as what I gave you the last time. Okay, so I think most of you are going for noradrenaline here. So when we look at this patient, we have to decide what we want to do with their circulation. So as I've mentioned, the most alarming thing here is that our circulation is too dilated and we want to squeeze that down. In terms of filling, the other thing, our circulation is a bit empty, but the reason for that is it's because it's too dilated. We could, of course, fill that dilated space with more fluid and that would temporize things, doesn't solve the underlying problem, and that fluid is going to leak out into the tissues and cause more problems later on. So the ideal way is actually to squeeze things down rather than putting more fluid in. In terms of cardiac function, we may or may not need to augment this child's function, but we have time here. This is not a crashing child. And as I've mentioned, older children, I'm not a big fan of using adrenaline unless I have to. Crashing child, no problem. This kid isn't crashing, so we do have other options. They're not going to appreciate you making their heart beat much faster than what it's doing and giving them palpitations, putting their blood glucose up and actually potentially causing that lactate to rise further. So my preferred choice for this child would be, I would agree with you, I would go with a noradrenaline infusion. And particularly as we've got the central line there, it would be fairly simple to put up. I would then put the echo probe on and see what's happening with the heart function. If it was impaired, we could add in some low dose adrenaline. But even if I didn't have the ability to put the echo probe on, we could look for lactate clearance, improvement in blood pressure as signs that things are improving on the noradrenaline. And if they weren't, and we didn't have the ability to do an echo, then we could start some low dose adrenaline to cover for potential myocardial dysfunction. So let's take a look at noradrenaline. So again, it works on the adrenergic receptors, alpha and beta receptors, but it has more of a predominance for the alpha receptors. So it is going to give you more vasoconstriction per dose than what adrenaline will do, and less beta effects. So it doesn't have beta 2 receptor effects, but it does have beta 1, which will increase your heart rate and ventricular contractility. I'm not a big believer that it has an awful lot of beta 1 effect. Generally, when I started, I find that the heart rate actually slows rather than it increases as a reflex due to the vasoconstriction that you get. And I wouldn't be relying on it to improve ventricular function in a child that I know the function significantly impaired. And there is other mechanisms by raising the blood pressure where the function will improve. It's going to improve preload by squeezing the venous circulation. And also by improving blood pressure, it improves your coronary perfusion pressure, which should improve your ventricular contractility as well. Dosing is very similar to adrenaline, 0.02 to 1 mics per kilo per minute. Again, we're starting at about 0.1 mics per kilo per minute. Similar onset and a half-life around about 2.5 minutes. So again, you have to be careful when you're moving it from one line to the other, and you need a secure line. Okay, moving on to case number 3. This time we've got an 8-year-old who has had an out-of-hospital cardiac arrest lasting 20 minutes. You've just got ROSC in the emergency department. Your patient is intubated. They're being ventilated at 20 breaths per minute and saturating nicely on 100% oxygen. Gas isn't great, but it is improving from the one that you've got during the arrest. Perfusion, 4 seconds, but again, improving minute by minute. And you've got a blood pressure with a MAP of 70. During the cardiac arrest, you've given 40 mils per kilo of fluid resuscitation and 5 doses of adrenaline, 10 mics per kilo per dose, given every 4 minutes or every other cycle. Pupils are unresponsive, pupils are sluggish, conscious levels unresponsive, and the patient's a little cool at 35.8. So again, what treatment do you want to do? We've got the options: no vasoactive drugs, adrenaline infusion, milrinone infusion, noradrenaline infusion of 2 different doses. Okay, so I think adrenaline infusion is winning just about with no vasoactive drugs as the second option. So before we come on to our goals, I think the first thing you have to realize with this patient is they are on the equivalent of a massive dose of an adrenaline infusion, even though they're not connected up to a pump. During the cardiac arrest, they've been getting 10 mics per kilo every 4 minutes, which equates to 2.5 mics per kilo per minute over the last 20 minutes. Remember I told you the dose for septic shock, we're going to start at 0.1 mics per kilo per minute. So for the last 20 minutes, this child has had an absolutely whopping dose of adrenaline. they've had 25 times the dose of adrenaline that you would give to a child with septic shock for 20 minutes. Now, I have told you the half-life of adrenaline is quite short, but with that amount of adrenaline in the system, it is going to be gradually decreasing down. But when you do your first assessment in this patient after you've got ROSC, they are on the equivalent of a massive dose of adrenaline, and that's what you have to factor in. My goal with this patient is to prevent them from re-arresting. And there's two things you can do. You can gamble that this patient is going to be safe to let that adrenaline wear off, and we'll see what happens. I think this is a terrible idea. And actually, this is if you've seen patients, you've got ROSC and they've arrested again 20, 30 minutes later, this is probably the reason why. You got ROSC, everything looked okay because they were on a massive dose of adrenaline. You let that wear off, and then they weren't okay. And the reason they might not be okay is after a long cardiac arrest, you're highly likely to get some myocardial stunning. So that is where you get significantly impaired cardiac function. It can occur immediately after arrest or up to 7-8 hours later, and it lasts somewhere between about 24 and 72 hours. So my patient is likely to get this. I'm not happy at all to see what happens. The patient may be in the CT scanner on the way up when the adrenaline wears off. They might be in the ICU but not have your invasive lines in yet. And I think the safest thing to do is put them on the adrenaline infusion. I normally start about 0.1 mics per kilo per minute and titrate it to effect. And it's only when they're in an ICU with their invasive lines, when we put the echo probe on, that we'll even consider weaning that off. In terms of neuroprotection, this patient has had a long arrest. Their brain is likely to swell up, and we're going to be wanting to target higher than normal blood pressures. So another reason why you're going to need some vasoactive drug support. Okay, case number 4. So this time we've got a 3-year-old with an isolated traumatic brain injury. There is some bleeding in the brain that the neurosurgeons need to evacuate urgently, and they've advised you to transfer this child without delay to the tertiary centre, straight to theatre, where they're waiting for this child. They're currently intubated. They have got been ventilated along at 25 breaths per minute and saturated nicely in 100% oxygen. Gas is good. The CO2 is at the low end of normal, just where we want it. In terms of the cardiovascular system, they are a little bit bradycardic at 75, but we've got an appropriate blood pressure per age, and they have a 20 mils per kilo of fluid resuscitation. They're unresponsive. They've got a below and right pupil, and they're normothermic. So again, go over to Slido and vote for which of the treatments you think we should go for. So no vasoactive drugs, adrenaline, milrinone, noradrenaline, or vasopressin. Okay, so it's fairly similar to the last time, a race between no vasoactive drugs and adrenaline infusion, but with no vasoactive drugs seems to be the winner. So my goals for this patient, number one goal that takes precedence over everything else is getting this child as quickly as possible into the hands of the neurosurgeon. So anything that is going to delay that is not going to be good and not going to be in this child's best interest. So in terms of putting central lines in, arterial lines in, anything that's going to delay the transfer is not something that we're going to be doing. In terms of starting them on a drug for blood pressure, we do actually want to raise this child's blood pressure. It is normal for age, but we actually want it to be slightly higher than normal. There's significant mass effect in the brain, and we're not going to be perfusing the brain particularly well. We do have age-related targets, and if we look up this child's age, we're going to want a cerebral perfusion pressure around about 50 millimeters of mercury. We don't know the child's ICP, but we can assume it's elevated, probably at least 20. So we're going to want our MAP to be at least 70. The other thing you can do is you can just target the higher percentile for this child's age, and that will give you a similar number of a MAP of about 70. So we are going to want to raise this child's blood pressure. Now, in terms of doing it, we could do it with fluid. Not the best approach because we're unlikely to get it up above normal without significantly overloading this patient. And in terms of doing that, that's not going to be great for their head. It's going to increase the risk of cerebral edema. So we do need to use drugs. The two drugs we can use are adrenaline and noradrenaline, and both of those can be given peripherally. The acceptance that noradrenaline can be given peripherally is probably lower. I've only used it a handful of times in my career, and certainly adrenaline is something that most people are familiar with. And it would be the drug I would recommend for this situation, mostly from a human factors point of view. I would worry if I advised the District General Hospital to start this patient on peripheral noradrenaline. The anaesthetist might not be happy to do that. They might decide they're going to put a central line in to give that noradrenaline that PIC are asking for, and that will delay this child's transfer. At the very least, it's going to cause a bit of confusion, a bit of discussion, maybe another phone call back. Are you sure you want me to do this? And that's not going to be the best thing for this child. If I say start them on a peripheral adrenaline infusion, the District General Hospitals are pretty happy with that. They do it on a regular basis for septic patients. They'll do that and the child will be out the door very quickly. And that is purely from a human factors point of view, this is what I would recommend. Had this child been in my ICU with a central line in, I would be starting them on noradrenaline. And the reason is I don't want to do anything to their function. All I want to do is squeeze their afterload and raise their blood pressure to perfuse their potentially tight brain. Okay, last case then. So this time we've got a 5-day-old baby with suspected duct-dependent congenital heart disease. We haven't had an echo done, so we're not sure of the exact lesion. Our patient has started having apnea since we've put them on prostaglandin, and they're being intubated for transfer to the tertiary centre. So their airway is currently patent. They are breathing at 75 per minute, so a bit tachypneic with quite frequent apneas in between. They're saturating at 79% and 30% oxygen, and that has been reduced down from 100% on PIC's advice, and it hasn't made any difference to the saturations. In terms of our gas, it's not great. Our lactate is elevated at 6.1. We're a bit tacky at 180, cap refill of 3 seconds. And in terms of blood pressure, we've got a MAP of 45. We've already had 30 mils per kilo of fluid resuscitation. We've got dinoprostin running at 20 nanograms per kilo per minute, and PIC have advised increasing that up to 50, given the elevated lactate and concerns that this duct is closed or closing. We're only responsive to voice and where our temperature is normal. So go over to Slido again and vote for the option you think we should go for. We've got very similar options to the last time. No vasoactive drugs, adrenaline infusion, Milner infusion, or push dose adrenaline. And we've got 2 different doses of the adrenaline infusion. Okay, so no vasoactive drug seems to be the most common. Milner is coming up as a close second, so I will touch on that at the end because I think that might be potentially quite a dangerous choice for this particular patient. So what are our goals for intubating this patient? The biggest thing is stability. This child has likely duct-dependent congenital heart disease, so their myocardial function might be impaired related to the condition that they have, which we don't know exactly what it is. They're not in the best state though. Their duct is closed or closing, and their lactate is elevated. So for any child like that, intubating them and giving them an induction agent, they may not tolerate it well. So we are very definitely going to want to support their myocardial function during this intubation. So no drugs wouldn't be the best approach. In terms of their preload, they've already had 30 mils per kilo of fluid. They've got an adequate blood pressure. We probably don't want to put any more fluid in. In terms of the afterload, we've got a MAP of 45 in a newborn baby, which is perfectly adequate, so we don't need to squeeze that anymore. Really, all I want to do with this patient is support their heart during that period of going off to sleep. You might argue, actually, the blood pressure is okay. Shall we not just see what happens, and if they deteriorate, give them push dose adrenaline? The downside of push dose adrenaline is it's a massive dose of adrenaline. You're giving 1 mic per kilo, which is 10 minutes of a standard sepsis dose adrenaline infusion given instantly. And what that is going to do, we've looked at the receptors and what it does, it's going to cause massive afterload increase. So the heart is going to suddenly have to eject against a massive increase in resistance. And if the heart function is impaired, the baby may well not enjoy that. So if this patient was crashing in front of me, of course, I would have no problem giving that push dose adrenaline. This is a great way to keep the child alive. It's going to massively improve their function and increase their heart rate and prevent them potentially from arresting. But it wouldn't be my preferred way of supporting the heart. I would much rather do that with an adrenaline infusion that's in before we give the induction agent. So we've got inotropy in before we start, because in general, prevention is better than cure. And then we'll have options to gently turn that infusion up should we need to, rather than giving a big slug of push dose adrenaline, which we're going to reserve for that severe emergency that doesn't respond to increasing the adrenaline infusion. Now, milrinone was mentioned as a choice. The problem with milrinone is it's got quite a slow onset. So you're going to start it, it's going to take a very long time before it actually works. If you look in the BNF, now nobody's ever going to do this. It mentions giving a loading dose because it takes so long before it works. If you give a loading dose, the blood pressure will absolutely bottom out, and nobody ever does it, despite if you look in the BNF, though it does recommend it. The other problem with milrinone in this particular situation is it has a long half-life. It's about 45 minutes. So if you give this drug and it drops the blood pressure, you're stuck with it. It's not going to go. You can stop it, you can disconnect it, you can dangle the infusion in the air, but this drug is still going to be in this child's circulation for a very long time. So milrinone might be something safer to add in at a later stage, but for the initial resuscitation and covering the intubation of this child, one, is not going to work because it takes too long to act, and two, when it does act, it's going to act for a very long time. You don't have invasive lines in. It's not going to be the right drug for this particular patient. Okay, so summing up, what I think are my key learning points with vasoactive drugs. In terms of look at your patient, decide what you want to do. What do you want to do to their preload? What do you want to do to their function? And what do you want to do to their afterload? And pick a drug or collection of drugs to achieve all those effects. Remember, your patient's empty. The drugs aren't going to work, so you may have to fill them up. In most situations, you're trying to return preload function and afterload to normal. When I was a registrar, I could not understand why we put patients on vasopressors. What they do is they squeeze the afterload down, so it limits the blood flow to the organs. It makes the heart eject against more resistance. And by doing that, the heart has to work harder, use more oxygen. I could not understand why we did this. The reason is you're not actually trying to do this. You're only going to use a vasopressor for a circulation that's too dilated. You're going to squeeze it back to normal, but you're going to stop here. You're not going to keep going where you squeeze it down further and limit flow to the organs. In terms of the function, you're going to take a heart that's not beating effectively and make it beat effectively, but you're not going to keep going till that heart is tachycardic and hyperdynamic. So you're just going to titrate the drugs to effect. And in terms of filling, it goes without say that you're going to fill the patient to euvolemia, and you're not going to keep going until they're overloaded. Remember that doing too much can actually do more harm. So if you actually squeeze too hard, you're limiting the flow to the tissue. So don't just keep turning the drugs up if things aren't getting better. Go back and assess your patient and decide what you need to do to each of those systems. If you have squeezed too hard, don't just add in something to dilate the system. Think about, can you actually reduce something first of all? So if you're on a pressor, reduce the pressure down first before adding in a vasodilator. The difficulty comes if you're on a drug that is providing inotropy and vasoconstriction, and that's why I'm a big believer in using different agents. So I'll start adrenaline, use it up to high dose for the initial resuscitation, but when the patient gets to the ICU, I'll start them on some noradrenaline, and I'll wean that adrenaline back to an inotropic dose. I'll keep my pressors and my inotropic drugs separately, and that just allows me finer control. In terms of other things, don't forget about your calcium. All these drugs need calcium to work. They work by increasing intracellular calcium. So your ionized calcium on your blood gas is less than 1. Give some calcium and you'll find your drugs suddenly start working. And if you're on 2 or more of these agents and they're not working, this is the time we think about adding in some low-dose hydrocortisone for relative adrenal insufficiency. So I'll put the feedback code up for this particular talk. So you're going to need to enter this in when you're doing your feedback to get your certificate for this talk. And if there's any questions, I'll take them now.
Thanks very much, Chris. As you say, it's always there's a tendency to switch off when people start talking about pharmacology, but particularly with these types of agents, it's really important to understand them because they have a direct guidance on what you're choosing in each particular kind of scenario, and also then an understanding that allows you to assess response better. So there's a couple of questions come through in chat. I think we have a minute or two just for questions. So the first was around the choice. What guides your choice of adrenaline or noradrenaline during shock? Is it the presence of warm or cold shock, or does one focus more on blood pressure, normal versus hypotensive?
Yeah, so I think the first case is the perfect example, and it depends who started. The guidelines are all written for somebody who doesn't have the expertise to pick a drug that's going to cover the most likely problem. And the most likely problem is you're going to have vasodilatation, with potentially some myocardial dysfunction. And that's where adrenaline is a great starting drug, because it covers those bases until you have somebody there who can do that accurate assessment and find out what you need to do. Access is another potential thing, and as I mentioned, the human factors. So there's a lot that goes on. We've got our guidance that are saying most people would start with adrenaline, and that's the safest thing to do. I think certainly there's times I'll put the echo probe on and look at the function, and the function's actually good. I don't need adrenaline for this patient. I'll put them on a pressor if I just need to raise the blood pressure. So it's asking yourself that question, what do I want to do? And if you don't have the knowledge, the expertise to make that decision, the guidelines have done that for you. And by following those and starting adrenaline, that's probably the safest thing to do.
Perfect. Thanks, Chris. And one other question before we move on. So this is around the scenario of warm shock. If you're worried about fluid overload, do you need to give the full 40 mils per kilo of fluid?
Oh, sorry, Ben, the smoke alarm's gone off. My knife must have burnt the toast. Smoke alarm's gone off in the background. I can't hear a word you're saying.
Grant, but you know what? We'll maybe leave it there, Chris, and any other questions
I'll
for you.
I'll go sort the smoke alarm out.
Grant. Okay, perfect, thanks. Okay, that wasn't planned. I should have mentioned to start with no fire alarms planned or anything like that. So
that's
off.
a way to dodge questions, though, isn't it?
Exactly, yeah. No, I wish I thought of that in previous years. We'll get them back at the break. We'll move on then to our next speaker is Dr. Gyula Tövisházi. So Gyula is, for those who weren't here at the start, we're delighted to have him with us today. He's a pediatric anaesthetist based in Budapest in Hungary, and is medical director for transport service in Hungary. He can probably tell us a little bit more about that. But we're really delighted to have him on board today. He's going to talk to us about intubation. So Gyula, over to you, and thanks again for joining us today. Really, really delighted to have you.
Thank you, Ben. Thank you very much. It's really a privilege to be here because I've been listening to Paediatric Emergencies in the last few years, and I also attended the intubation course in Belfast last year. So I would really encourage everyone to do that because it was an exciting course. So this talk is about intubation in general, and more precisely a case of a difficult airway. And we are going to start with some introduction to let you know where I come from and what we do at this pediatric transport team. Then I'm going to go over this case with your help with Slido, and then maybe we can take home some learning points as well. So as an introduction, we in Budapest, we work really closely with the National Ambulance Service, responsible for all the coverage of pre-hospital care in Hungary. But as you see in the pictures, we try to be as pediatric friendly as possible. And also we are a very specialized service, having 4 units being specialized for the sickest babies and children. 3 of our units are equipped with advanced life support equipment led by doctors who are coming from either an anesthetic or a pediatrician or an emergency care background, but having additional knowledge of pediatric ICUs and transports. And we are supported by a wonderful team of paramedics and drivers who are really experts in their field. So in terms of cases, what we do is partly, we also do pre-hospital care, so a normal first response care. And there we have a very similar caseload of as a pediatric A&E department would. So we have lots of respiratory cases, especially in this time of the year. We care for lots of babies and children with neuro-related illnesses like status epilepticus. And we cover also quite a few cases, trauma cases ranging from minor burns or scalds, ranging to even polytrauma. Our other role as a retrieval team is the secondary, so to say, inter-hospital transport. And we not only transfer kids between hospitals, but also stabilize them on scene in case it's needed. In terms of equipment, what we have is everything that the National Ambulance Service kit standardly allows us to have. And in addition, we also carry mobile ultrasound device on scene, blood gas device as well. As you will later see, we also have video laryngoscopes. We use quite a lot the MRI compatible ventilator, and we have some additional syringe drivers because in pediatric ICU transfers, we need lots of them. We also want to make sure that every piece of equipment is there, and we check them every morning. On the picture, you see two of my colleagues cross-checking the equipment, making sure it's ready, making sure they are up to date with what they found and where in the ambulance. So let's turn to the case discussion, and I'm really curious about what you have as a feedback, and also what the panel is going to ask or add. This case was done not by me, but my colleagues about 1.5 years ago. This baby is 4.5 months old at that time. She's diagnosed with Down syndrome, weighing about 4.5 kilograms. She is currently at the DGH diagnosed with bronchiolitis, which was later proved to be RSV positive. And she developed actually worsening respiratory failure, not really responding to conservative management. So they tried oxygen, they tried nasal suctioning, some bronchodilators as well because of wheezing, some steroids. None of them seemed to work really. An important side note is that this baby already have attended an ICU and spent 3 days on a ventilator, intubated, because of influenza B-induced respiratory failure. And afterwards, after extubation, she also had a period of non-invasive support, like high-flow nasal oxygen. Ever since discharge to home, parents noted a quite noisy breathing. So that's an important point as well. And in the next slide, I would really like you to imagine this child and vote on the Slido what you would do. But before, I have to tell you some more about the circumstances. So this DGH is about 100 kilometers away from Budapest, about 70 minutes on road. And our team consisted of this night, the team consists of 4 people. Normally, it's only 3, but in addition to the consultant, who is a really experienced colleague of mine, he's a pediatric cardiac anesthetist having more than 25 years of experience. In addition to him, there was also a trainee who is an anesthetist and just finished the induction training necessary to join our team. And there was a critical care paramedic and another one who drove them there. There was an assessment done on scene, so we are already at the DGH now. The child has an audible stridor. She has tachypnea, increased work of breathing, and clearly showing signs of getting exhausted. Sets between 92 and 94% on 100% oxygen. Capillary blood gas was done and showed PCO2 of about 9.5 kilopascals. Circulation was stable with normal blood pressure, a bit of tachycardia, but well perfused, although pale and mottled. She was somnolent, a bit reduced GCS, but no other neurological abnormalities. And now we have the Slido slide, and I'm really curious about what you would vote for. So what would be your next action at this point? Would you repeat steroids and start some inhaled adrenaline or racemic adrenaline? Would you commence non-invasive ventilatory support like an HNFC, so high-flow nasal oxygen? Would you decide to intubate using IV drugs, so just perform an RSI at this stage? Or would you transport this baby to the local operating theater for an inhalational induction in case that's a safer option. What do you think? We wait for a few seconds for people being able to join and vote. And actually, the most popular answer seems to be repeating steroids and starting inhaling racemic adrenaline. And actually, that was exactly the same thing that they did. There was an obvious airway and breathing problem, and it seemed that the situation it's very bad. But they trialed the baby with a further bolus of IV steroids. They also started some inhaled racemic adrenaline and waited for about 10 or 15 minutes. But since there was no improvement at all, actually the stridor got even worse. A decision was made by the retrieval team and the local pediatrician together to intubate prior to transport. This intubation there on the ward with the equipment of the ambulance team. So after standardized preparation with checklists and verbalizing the different plans, they proceeded with ketamine and rocuronum. The bag mask ventilation, which they already started at that point before administering the drug, was quite difficult. So the child needed a two-handed grip, as you see on the picture. She also needed quite high pressures, but a visible chest rise was seen, and also an ETCO trace was visible. As you see, there's a capnograph attached already to the mask as well. Then, after 1 or 2 minutes, video laryngoscopy was performed, and I hope this video is going to start. As you see, there was a very clear and nice view of the vocal cords, so that was a grade 1 view, and it was all right, except that the 3.5 uncuffed tube wouldn't go down between the vocal cords. As you see, there is some fiddling with the tube, some rotation of the tube, but this was an unsuccessful attempt. They bagged the child again. The sets were dropping a bit, but then came up after above 90%. And here you see a second, or I think maybe the third attempt. They try to downsize the tube, assuming there's a stenosis infraglottic, so the subglottic area. They also tried a bougie, as you see on the video, but they weren't successful this time as well. Every time they back the patient, sets after some drop, the sets came up above 90%. And by this time, as this was already third or the fourth attempt, the spontaneous breathing started to come back as the paralytics started to wear off. So my next question, and this is a really exciting one, I think, would be, what would you do at this point? So would you give a further attempt with a 2.5 ETT, which is maybe reinforced with a stilet? Would you insert an LMA and support spontaneous breathing? Or would you declare a can't intubate, can't oxygenate scenario and perform cannula crike? Would you perform a surgical crike maybe, or would you perform surgical tracheostomy? So these are the different options, and actually these were the same options they also discussed there on scene. It was a really tough decision to make, but and they also called there's a so-called telephone on-call consultant, which is an opportunity for such cases. So there's a doctor responsible for taking these calls in the Hungarian system, and that's a safe thing to do, I think, because they are on a separate location. They are not at all involved in the case, so they are really clear-headed without any anxiousness of the scene. And this consultant actually suggested reparalyzing the child again and performing cannula cricothyroidotomy. But what they actually did was the same that you voted, most of you voted, was that they inserted an LMA, and throughout the whole journey, they assisted the spontaneous ventilation, and they didn't push any paralytics anymore, but administered some sedation to tolerate this LMA. As you see on this code summary picture, particularly on the right side, so the oxygenation was quite good, maintainable. It was actually got even better, and at the time, by the time of the handover, it reached 100%. But at the same time, I'm sure you noticed that the carbon dioxide, so the EtCO2 values, which are measured in millimeters of mercury, reached 100, which corresponds to about 13 kilopascals. So it was an extreme hypercapnia, but at the same time, a stable blood pressure and a stable oxygenation. So what they did was they obviously pre-alerted the receiving institution, who then waited for them, scrubbed in the operating theater, in the ENT, with an ENT surgeon on board, to perform an urgent surgical tracheostomy. And this was done quite uneventfully in the operating theater. The patient stabilized, obviously a period of extreme hypercarbia, but then stabilized, was able to suction, and was able to be ventilated later on. And on the next day, rigid bronchoscopy was performed from above, so to see what was the reason of this intubation problem. And what you see in this video is probably as shocking as for us. So there is actually subglottic stenosis almost 100%. So there's actually no hole at all which the tube could have gone down. This was one day after the event, but it was really shocking to see, and obviously it's a really rare case and a really extreme case, but there are some learning points to take home maybe. I think it's really important to always to have a standardized preparation and equipment tried out, also to use a checklist, and very from the human factor standpoint, it's really important to verbalize all the potential problems and all the plans should things go wrong, and always having a backup plan is a really important thing as a transport team. We also wanted to find out what the literature says behind the front of neck access in an infant of such size, and there are lots of good resources on the net. For example, the DAS guidelines it's a really nice flow chart, except for this as it's indicated at the top. This is only for children aged between 1 year and 8 years. So that was not really much help for us. So we looked for other sources and found this very nice guidelines from the joint guidelines from ESAIC and BJA. This was published last year, and it's about the airway management in neonates and infants particularly. It does have some several really important information about difficult airways, supraglottic airways, and human factors in these circumstances. It does have also a really important statement. So surgical and percutaneous needle cric is not suitable in neonate and infant because of the anatomical differences. And surgical tracheotomy should be performed whenever necessary. So in a can't intubate, can't oxygenate scenario, but how this tracheostomy should be performed precisely, exactly, the evidence is unfortunately not there and lacking. There's another also very important article, a review article from Pediatric Anesthesia, which states that actually it's not so extremely rare events. So below the age of 1 year, the rate of difficult airway is between 1 or 2%, which is, I think, quite a high number. And this article also contains a really important chart, which actually states that that below the age of 8 years, in such extreme cases, so where a surgical airway is needed, an EFO, not the emergency front of neck access, is needed, a surgical tracheostomy with scalpel and bougie should be performed. And after 8 years, you can choose between a surgical or a percutaneous one, but definitely such a small infant, in case it was needed, would have benefited from a surgical intervention. Although I have to say, it's really an extremely rare event, and it must have been a really tough decision to make. And I also have to add that I completely agree with my team what they chose. I think that was the safest option, because even this really experienced colleagues of mine with more than 25 years of experience, they never had to perform a surgical airway in such a small child so far. So it would have led to disaster as well. So I think it was the safest option to do. There are some other home resources, partly one from Chris from last year, which covers very important aspects of surgical airway in a neonate and a small child. There's also a few other talks, like the one from Sydney, from Cliff Reed. But in the last few years, it seems to clear out what we should do in such an extreme circumstances. What we have created so far is a so-called RSI kit dump, which is a single-use, quite large paper having all the slots for the different equipment, and the aim is really to avoid any confusion, not to forget anything, and to have a clear structure of thinking about what the order and what the standard concentration of the different drugs, what the place of the different equipment should be in case of an airway management, so an RSI case. And what we also have is a table, so that the provider there doesn't have to do any difficult calculations on scene, but they can read out what the specific age suggests, what doses, what sizes are there. Obviously, you can also use on an iPhone app or other kinds of electronic help as well. And what we usually do in the recent few months is a regular airway simulation training, and we will also include from now on such scenarios where a surgical airway in an infant is needed, and we really have to build a structure for that, so that it's well rehearsed, very simple, and in case of such an extremely rare event, we are prepared for that as well. So I would like to thank you for the opportunity. Thank you for your attention. This is the feedback code for my talk, and I would also like to thank the who attended this extremely difficult case, which I think they managed very appropriately. In case you have any questions, please feel free to put it in the YouTube chat or send me an email. Thank you very much.
Thank you very much, Gyula. Really, as I say, great to have you with us. Great talking intubation, and thanks also for sharing a little bit about your service. It's always good to hear about how other regions and other places do things, because there's always something we can learn from each other. Just a couple quick questions. I think the first thing, this is clearly a very challenging and probably quite scary case for a lot of people involved. And you mentioned the importance of sort of having an independent consultant at hand. And I think that's a clear. It is really important to have that clear head and try to maintain an awareness of the situation unfolding around you, rather than getting task fixated on sort of getting the child intubated and maybe losing sight of the bigger picture.
Yeah, absolutely.
I suppose one more questions, just out of interest for the case, particularly not so much about intubation, was a question of whether was the stenosis, to the subglottic stenosis, was this because the child had been previously ventilated, or was this a congenital malformation?
No, it was probably because of the previous ventilation. There was also a history that the child self-extubated herself, and maybe that meant something that the tube could have moved a bit too much, and so it was definitely not a congenital one, because the first intubation attempt was uneventful and the normal size tube would go in. So probably it was unfortunately a subglottic stenosis due to so a post-intubation stenosis, I think.
Okay.
And the child actually later had to undergo some laryngotracheal reconstruction as well.
Yeah, and I suppose that's what linking in then with ENT. There was a question around the benefits of maybe having an ENT consultant present for difficult intubations.
Yeah, I think that really depends on the system you work in or the places. Actually, we don't always have this luxury, but in this case, the receiving hospital, there was an ENT surgeon present, so that was a quite lucky situation to have. But as an anesthetist or as a emergency transport team, it's really an extremely rare event, I think. So I'm not sure that it's an easy one for any of my colleagues.
No. Well, listen, thanks again, Gyula. I really appreciate that. Thanks for joining us today. And in the interest of time, we're going to move on to our next talk. So thank you. Our next speaker today is Dr. Seana Molloy. Dr. Molloy is a paediatric intensivist in the Royal Belfast Hospital for Sick Children, and she's going to be talking to us today about status epilepticus. So over to you, Seana.
Apologies, have myself muted and off. How are you, everybody? As Ben said, thanks Ben for the intro. My name's Seana Molloy. I work alongside Chris in PICU in Belfast, the Royal Belfast Hospital for Sick Children, and also a member of the retrieval team in Northern Ireland. So today I'm going to talk to you about status epilepticus, which I'm sure everyone's pretty familiar with. Really chat about what's new and what's happening next. So I'm going to introduce a case. So this is a true to life case. So it's a 3-year-old little girl, 14 kilos, background of juvenile idiopathic arthritis and non-verbal autism. No real issues other than that in the background, full term at birth, received all immunizations. This little girl presented with her first seizure to ED via the ambulance with a right-sided focal seizure. She had already received 1 dose of buccal midazolam via Northern Ireland Ambulance Service, and on presentation was still actively seizing. So I'm going to try and introduce a bit of Slido here as well. So if you just want to scan the code and just tell me, what would your first thoughts be in terms of what would you do first with this child? Would you take a full history from the parents? Would you get IV access? Or would you assess their airway and breathing and make sure everything's good? Got an 111% there. So 2 minutes just to answer that. Yeah, so I think the resounding overall topic there is that you would assess their A and B and make sure the kid's adequately breathing. So continuing on, the seizure did terminate after 37 minutes. She had 2 doses of benzos and was loaded with Keppra. PICU were informed at that time and the retrieval service were kept up to date. They chatted it through. Because of the atypical nature of this and the new seizure, there was a decision that a CT brain was probably the best clinical pathway for next. But the child is only 3, so they thought it'd be better to still take good images to intubate the child. So the child was RSI'd, fentanyl, propofol, and rocuronium, and all was very straightforward, grade 1 airway. The scan was normal. The bloods were all normal. She was covered for any CNS infection with ceftriaxone and acyclovir. After the scan, again, there was further discussions with the regional PICU. PICU advised at that time that perhaps it might be worthwhile, if the scan's normal, that we lighten up the sedation, perform an LP, and then if the child was neurologically appropriate, and then advised to wake and potentially extubate. Sagamodex was administered by the anaesthetic team, but when the child was assessed by the local pediatrician, it's found to have an abnormal neuro exam, and they weren't really happy to extubate. So the child was put on sedation, morphine and midazolam, and was accepted by PICU. So the initial call was at about 4:15 in the afternoon, and the child was accepted at about 5:05 following this abnormal neurological assessment. There wasn't, unfortunately, an ambulance available till 7, and this ran into the changeover with the nighttime transport nurse. The local team were updated, the child was stable, they were okay to wait. So the retrieval team departed at about 8:20 and arrived at 9:20. So when they went to, child was still in theatre, there was a full team around paediatrics and anaesthetics. The handover was received and parents were updated, and whenever the child was being packaged and transferred onto the trolley, she spontaneously moved her hand up towards the ET tube and attempted to pull it. Moved all 4 limbs and attempted to sit up. So what would your thoughts be now if you were in that theatre? Would you think, oh God, I need to bolus propofol, sedate this child, crank up the sedation, this child needs to move to the PICU? Or would you think to yourself, that's pretty neurologically appropriate. Maybe it's better off for this child to stay in the local hospital and think about extubation. Give you 2 minutes for that. So very heavily on the appropriate neurological actions, maybe we should think about extubation. So keep this in mind, and we'll chat about that towards the end of the talk. So basically today I'm just going to, our learning objectives mainly are what is paediatric status epilepticus, very familiar probably to us all. What's changed really in the clinical management of status over the last couple of years, and we're stable. What's next, or what's new? What new evidence is out there? So status really can be defined as a critical medical emergency. Its definitions have changed throughout the years. Initial seizure greater than 5 minutes, or repeated seizures, or clustering as we call them, without recovery of GCS in between. The incidence is around 17 to 23 per 100,000 kids per year. And unfortunately, although it is quite common with a common scenario in all our hospitals, there is still significant morbidity and mortality associated with status epilepticus. And unfortunately, as the seizure progresses, the chances of the drugs working decreases, and you run into issues with neurological sequelae. And the mortality is still 2 to 7%. This is not an exhaustive list of common causes of status. You have your known and your unknown. This ranges from structural, tumors, head injuries, mentioned before in Tudor's talk, infectious, meningoencephalitis, cerebral malaria, which we don't really see too much of around here, tuberculosis, metabolic issues. Is there electrolyte imbalances? What's your sodium? What's your sugars? Is there any issues with encephalopathy? Are you an organ failure? Think about your liver function. Metabolic disorders. Has this child got a known metabolic disorder? Is it very young? Is this a new presentation? Toxicity. Is this child a known epileptic? Do you need to think about your anti-seizure meds withdrawal? Is there any history of alcoholism or drugs, which would be more in the adult population, but as you know, it's becoming more common in our pediatric population in our adolescents. Inflammatory causes, genetic, Dravet's, Angelman's, Rett's, and febrile convulsions, which we're probably all very common with, quite common between 6 months and 6 years of age. And of course, you have your unknown reasons. So you need to think about this list really whenever you're thinking about what investigations to consider. So your baseline bloods, think about your bronch profile, your calcium, your magnesium. A simple gas can tell you your glucose. If it's less than 3 millimoles, treat. 2 mils per kilo, 10% dextrose. Think about your Is there a background here of, is the child febrile? Do you need to do a blood culture? Do you need to think about normothermia? Is it a febrile convulsion? Is there any evidence of toxicology? Have you taken a good history? You know, is there anything in the background that would suggest poisoning? Is this child very young? Do you need to think about your ammonia? Is this a metabolic condition? Think about MCAD, your plasma amino acids, your inorganic acids. Is this child a known, does this child have a known seizure diagnosis? Non-compliance is a very common cause of these breakthrough seizures. So you need to take your drug levels for your anti-seizure medication. We're always quite eager to do a lumbar puncture in these kids because, you know, you're worrying about your CNS infections, etc. But remember, you shouldn't immediately LP a child after a seizure because there's always risk of raised ICP and potential coning and death, as you know. And a normal CT does not rule out raised ICP, and that's why your neurological examination is so important. Whenever you're, even after intubation, you need to do a neurological investigation before you stick a needle in that child's back. And then your EEG is probably down the line. So brain imaging, we're always quite proactive with asking our DGHs to perform a CT of the brain. But when should you consider brain imaging? So in a lot of the cases, whenever the child isn't a known, does not have a known epileptic process going on, we would really advise for a CT brain. If it's a new prolonged seizure, atypical or focal, if you've any signs of raised ICP, sunsetting, anything abnormal in the background history in terms of your neurological examination, anything in terms of that would be suggestive of a spaced occupying lesion like a tumor, stroke. Does this child have a blocked VP shunt? Do you need to talk to your neurosurgeons? Do you need to get a time critical transfer? If there's any history, yes, you have febrile convulsions, which there would be your child would have a temperature, but is there any evidence of a CNS infection and neuroimage with suspected meningoencephalitis? And of course, as Tudor alluded to earlier, always think about your non-accidental injury and your trauma. And of course, if you don't have a clue what's going on, you'd like to see what's happening in the brain. So this is the newish guideline. This was published in 2022, and it's a medical algorithm now for status epilepticus. It's in 4 steps, and I think we can all agree it's a much faster paced guideline. And of course, sometimes we just can't keep up with the actual steps. The emphasis really with this guideline is whilst completing each step, you must reassess the patient from an A, B, C, D, E perspective, considering all the reversible causes and preempting and preparing for your next step. Now, you've probably all seen this and been very familiar with it, so I'm not going to labour it, but I'm just going to talk about the differences between it and the previous guideline. So in terms of steps 1 and 2, there is a shorter 5-minute interval between your benzo doses. Now, your benzodiazepine drugs of choice would be your buccal midazolam, your rectal diazepam, and your IV lorazepam, pending if you have IV access. Now, these are used because they are licensed for kids, they're good onset of action, fairly easy to use, and your first dose is fairly well tolerated and can be given by a trained carer or in a pre-hospital setting by a paramedic. There is evidence to say that if this first dose is given within the 20 minutes of the seizure, you have a 70 to 86% chance of that seizure terminating. Unfortunately, as your time increases with your interval between your second dose, that actually reduces to about 17%. And obviously, you have your side effect also of benzos that it does cause significant respiratory depression and can cause hypotension. So although the first dose really is tolerated, whenever you're given the second dose, it's probably recommended that this is given by someone who has somewhat some airway expertise, because you can cause respiratory depression with the symptoms of benzodiazepine. Step 3, the second line drug is Keppra. So as Costas alluded to earlier, the concept and Eclipse trial showed that Keppra was of similar efficacy to phenytoin, phosphenotoin. Also similar efficacy to your phenobarb and sodium valproate. The reason it's used is that it's a lot nicer drug profile. It's a cleaner drug. It can be given over 5 minutes. It doesn't have any issues with hemodynamics. Your hemodynamics are not affected. You don't need to be monitored. And as with sodium valproate, there is issues with teratogenicity. And although we don't really think about that in children, you know, there's no contraindications to giving Keppra to a child who potentially could be pregnant at childbearing age. Also, the fact that there's no contraindications, whereas you need to think, if this child has a diagnosis of epilepsy, are they already on phenytoin? Whereas you wouldn't give phenytoin, you would give phenobarb, so you can give your Keppra freely. That's all within probably the first 20-25 minutes, so it's fairly fast paced. Step 4 really then, if the team are ready, as I said, you're prepping for your next stage. At this stage, which is probably about 30 minutes in, if the team are ready, you're going to progress to an RSI to break this cycle of seizures. As I said, time is neurological sequelae, so you want to stop this seizure before any neurological problems can occur. Now, as we know, you know, it might be okay in a PICU who are quite familiar with intubating children, but you know that time passes pretty quickly. And you know, if you are ready, proceed with an RSA. And the induction drugs of choice usually would be ketamine if there's any hemodynamic instability, and propofol is probably what most anaesthetists are most familiar with, rather than thiopental. Your muscle relaxant of choice, I would say, would be rocuronium. It's got good drug profile, minimal side effects, good onset of action, 1 to 2 minutes, and lasts about 20 to 25 minutes. So if you're thinking about waking this child up for neurological assessments, it's a good drug to use. As I said, this happens pretty quickly. So if the team aren't ready, then you would proceed to your phenytoin or your phenobarbital if the child's already on phenytoin. And that's given over roughly 20 minutes. So you're buying yourself another 20 minutes. There isn't really evidence to say which is going to work the best here, continuing the drugs or the RSI, but it's something to think about. And then if your child's still seizing after this infusion's finished, then you proceed to your RSI. So to pull the tube or not to pull the tube, that is the question. And I know that in the national guidelines would be to say that all children would be transferred, you know, informed by the retrieval, you would inform the retrieval team and transferred to PICU. But this really isn't what's happening throughout the UK. And I can't say that in Northern Ireland because the majority of patients are transferred to PICU. And with that, I know this is a fairly controversial issue within Northern Ireland, but having worked having done my transport in England, worked with Costas, this would be a fairly normal, would I say, happening, that they would consider extubation if specific criteria were fulfilled. So I'm not here to be slated for whether or not this should not happen in Northern Ireland, but I want to just present new evidence that has came forward. So this is a paper that was published in March 2024 in the Archives of Disease for kids. It is a new piece of research which shows really what the baseline clinical characteristics of these kids are, predictors of successful extubation at the referring hospitals, and the short-term outcomes of kids intubated for status epilepticus. Really, it's from 10 paediatric retrieval areas throughout the UK, and it's telling us what is happening and what's the difference from the national guidelines. So there was 1,600 roughly referrals for status and about and 1,136 were intubated. Of this 1,136, 396 were extubated locally. Of these 396, 19 were re-intubated at the referring hospital. Of these, 7 were re-intubated because of recurrence of seizures. 7 were re-intubated because of reduced GCS, respiratory depression, and 1 for laryngospasm. So you could argue that these potentially were avoidable re-intubations, and then were unknown in 4 cases. The factors associated with not extubating the child were set out as infectious or metabolic cause, CT changes on the CT, any preceding encephalopathy, the sedative associated with midazolam, child will wake up, and the use of secondary anti-epileptic drugs. So the research from this showed that regions with the highest rates of local extubations have guidelines with detailed and agreed criteria, and there are regularly audited outcomes. So there's guidelines to say which children should be considered for extubation and which children should absolutely not be considered for extubation. And these are just a few that I've found on the internet, from NUTS, where I did my training, from CATS in London, and South Thames Retrieval Services, and they can be found if you just Google them. Interestingly, the PICUs with the highest rates, the PICUs within the regions with the highest rates of local extubations received the highest proportion of patients who remained intubated for greater than 6 and 24 hours. So that would indicate that there was an ability to successfully identify patients who you could extubate earlier. Conversely, the PICUs in the regions with lower rates of local extubations had the greater proportion of these patients who were intubated for less than 6 hours. So perhaps they were the patients, there was a large proportion of patients there that could be extubated locally. As a lot of the time we know in PICU, usually extubate them after a lumbar puncture if we feel that their neurological examination is appropriate and there's no red flags to say that they need to be intubated. There is criteria in all these guidelines of what children you should consider for extubation. And as you see, this is the guideline from the South Thames. There's 10 points here. Kid was intubated for low GCS or hypoventilation, their seizures controlled, no new findings on CT. You can read them. We have sent out a survey among Northern Ireland, and interestingly, one of the main things that came from that was that there was a lot of anxiety about where these children were going to be looked after and recovered, essentially. You know, there is, as we know, our resources, we don't have great resources, we have minimal staff. You know, who's going to look after these children while they've recovered after being intubation? So that adequate clinical support available post-extubation is a big area that we need to focus on in Northern Ireland if we're going to move forward. With these guidelines also, there is clinical assessment that needs to be fulfilled in terms of your respiratory, your cardiovascular, and your CNS. So there is a lot to think about in terms of what children can potentially be extubated, but it is happening in parts of the UK, and it is something we can think about. So in terms of our case, the retrieval consultant made the decision to extubate the child regardless of onward transfer. So they potentially were going to take the child with them, even if the child did not have a tube. Put on the bagging circuit, was breathing spontaneously and opened her eyes to voice. Sedation was stopped. The neurological examination, as you can see, was very appropriate. They didn't do a lumbar puncture at that stage. They gave a small dose of propofol just to facilitate preparation for extubation and for a safe extubation, and the child was successfully extubated. The retrieval consultant was present throughout, So give the local DGH a bit of confidence of, you know, if things headed southwards. And chatted to the paediatric consultant about whether or not this child could remain within the local DGH to save the transport and the family anxiety of transferring to a paediatric intensive care unit. And the parents did confirm that the child was back to neurological baseline, and the retrieval team departed after 30 minutes. The child had no further seizures during that admission. MRI was normal, and there was an EEG performed, which was suggestive of focal epileptic process. But considering that there was no further seizures, the child was discharged with routine follow-up. So, in summary, the guideline for status epilepticus, it's a newish guideline, which we should all make ourselves more familiar with if we're not already, from 2022. And I think we can all agree it's a much faster paced guideline, and you stumble upon your RSI quite quickly. Pre-hospital benzos are encouraged and endorsed. You know, the faster you get that first dose of benzos in, the higher chance that the seizure will terminate with less chance of neurological sequelae. There is new evidence out there to suggest that extubating locally follow RSI for status epilepticus is safe. Now, I know there is no current guideline for Northern Ireland. We have sent out surveys, and we're looking at all the responses in terms of just our local practice. And it's nothing that's going to happen overnight in Northern Ireland, but there is a guideline in the pipeline. And there is a potential for introduction at some stage in the future, perhaps introduction initially whilst a member of our retrieval team are present. These are just some of my references, and thank you for listening, and just happy to take any questions. And that is the code for feedback and my email if anybody has any pressing questions they want to ask me. Sorry, I've spelled, there's 2 T's, Belfast Trust. Apologies.
Thanks, Seana. We'll let you away with that one. Thanks very much for that presentation. I know there's been a lot of discussion at these conferences in the past, and actually I think it was 2022, we had a debate, Gail, who's here today, and Ben, I think, around pros and cons of extubating locally. So that's available on the Paediatric Emergencies YouTube channel if anyone wants to go back and watch it, bearing in mind, I guess, that Seana has presented new evidence which has been published since then. We're not going to talk too much about that because I know we've done that a lot. We could be here all day discussing it. There was a couple of questions. I know Gail's been keeping an eye on Slido, and there was a few questions came through that. So maybe hand over to Gail just to ask those few questions, if that's okay, Gail.
Yes, thanks, Ben, and thanks, Seana, for the presentation. Just one question then, but it's more neonatal focused, so I don't know how you'll take it, but just a question about a 0-day-old baby who had continuous sort of status found on CFM, and the baby was put on anticonvulsants and ramped up the midazolam, and they transferred the baby, but it was a question about cooling.
Well, I'm not a, is that my smoke alarm? I'm not a neonatologist, to be honest with you, and we don't routinely cool patients in pediatric ICU. You know, the trials have shown that normothermia in terms of any sort of brain injury is as far as we would go. So I probably am not the best equipped to answer about cooling. Now, I have got some background in neonatal, and I don't know, does anybody else have any strong neonatal knowledge that causes?
Is that term child that the question refers to, like a few days old?
It was
0-day-old.
Oh, sorry, I thought I said premature.
A day old.
Yeah, day-old term baby with HIE, and was being cooled for that and investigated with CFM, noted to have a 2-hour history of continuous seizure activity and remained in status despite increases in the anticonvulsants, and they increased the midazolam, and they were transferred to NICU, and they're just asking.
Okay, so there's fixed criteria for cooling neonates, and I mean it depends on the details of the specific case, but what evidence we have about efficacy of cooling in children for neuroprotection the only population where it does work is the newborns. And if it's 1 day old, this baby's a newborn. So I would, I would argue that, especially if it's going to NICU where they're used to doing that, then that's the right thing to do. Now, there's limitations if it's coming to PICU because we don't routinely cool anymore. We target normothermia. So we aggressively avoid the child becoming febrile because that's strongly linked to much worse outcomes. But if the child's going to NICU and it's 1 day old, then the cooling sounds to be appropriate in this context, and they would be able to provide it. But on PICUs, it's no longer routine. We don't keep our skill set up with doing it, and therefore it's not the best idea, is the answer. So it depends where the baby's going and how old it is. But I wouldn't do this. If this baby was a week old, then we wouldn't cool it. Wouldn't meet the criteria because it's way past sort of the having just been born, if that makes sense.
Thanks, Costas. And just 2 other questions, maybe just a quick response, Sean, if you don't mind, or any of the rest of the panel. So question 2, should the child have been intubated earlier if fitting, along with the new APLS guidelines rather than facilitation for imaging?
So in this case that I talked about,
I believe
so yeah, so in terms of they had 2 doses of benzos and a dose of Keppra, and I know it says 37 minutes that the seizure stopped, but as I said, by the time these peripheral hospitals who are not used to drawing up maybe pediatric doses, that probably was following through the guidelines. So strictly speaking, if you're going to follow the guidelines to the T, yes, but the child had 2 doses of benzos and Keppra, and as I said, the further that you that the seizure continues, the less chance that the seizure is going to stop. Even with RSI, essentially, and there isn't strict evidence by continuing drugs or RSI. So I'd say that this hospital did pretty well and followed the guidelines.
This question just about propofol. So if midazolam is associated with the transfer and the patient isn't extubated, then is there any suggestion to use propofol for initial maintenance of sedation?
Yeah. So that would be our practice in children who are hemodynamically stable. If they would come to ourselves, we would usually, if it was myself, I would actually change the child onto a propofol infusion for the transfer to facilitate, me assessing them from a neurological point of view when they get to PICU, and then, propofol has a fast offset. So, it would lead to faster extubation conditions. So yes, definitely. But as you know, you have to be very careful with propofol, and if there's any hemodynamic compromise, you need to think about that.
That's great. And I think we're about out of time. Maybe you could respond to the questions in the text, Seana. There's another few. Okay. Thank you. Back to Ben.
Thanks, Gail, Seana. We're going to go coffee now and meet again at 11, but maybe just before, Chris, do you mind? We were in the middle of asking you a question when the smoke alarm went.
Yeah, there's no alarm in the background now, so I can't.
Are you happy if we ask you that? Because you're not getting away that easily.
No, I'm quite happy. I quite like the question, so I was quite annoyed I missed them. And just to point out, my wife didn't burn the toast, I got told, so we're not quite sure why the smoke alarm went off, but it's not her fault.
It sounds like she's told you have to say that now.
Yeah, you're dead, Chris.
So yeah, I suppose it was a question around in the setting of sort of warm shock and concern about fluid overload. The question was really, do you have to give the full sort of 40 mils per kilo of fluids before you think about starting inotropic support?
Definitely not. The guidelines are there, as I've mentioned, for somebody with limited experience, and they're going to be less confident with starting vasoactive drugs. If you have the skills and expertise there to perform an assessment on your patient, you can definitely deviate away from those. I would sort of caution against people deviating away who are less experienced. They're there for safety. But if you have the expertise to perform a more detailed hemodynamic assessment, then definitely I'm not going to fill that patient up with 60 mils per kilo of fluid, when they're massively vasodilated. I'm going to start vasoactive drugs sooner, squeeze the space down, because ultimately that's going to be better for that patient. So I think you have to adapt to the patient in front of you and how sick they are. If this is a crashing patient, they're going to get their full amount of fluid because that's the safe thing to do.
Perfect. Thanks, Chris. Look, I'd like to take this opportunity to thank everybody who's spoken so far and to all the panel for engaging. It's been a really good opening to the conference today. Thank you to everybody who's joined. We're hoping you're enjoying it. I hope there's lots of learning. We are going to take a short break and we'll come back at 11 o'clock to start our next session. There's going to be a talk from Dr. Peter Donnelly on the management of the sick cardiac baby. So 11 o'clock, we'll get back on time. We're about 10 minutes behind, but we can make that up with a coffee break. So go take a break and join us again at 11 and we'll see you there. Hello everyone and welcome back to Paediatric Emergencies 2024. We hope you enjoyed this morning's session. Had a chance to get some tea, coffee, refreshments and ready to go again for another session. We've got some great talks lined up. Before we go to those though, there's a couple of housekeeping things just want to mention. So questions, it's great, we're getting lots of questions through. We are getting some through the YouTube chat and Slido. It's much easier for us to monitor if they all come through on the one sort of format. So if we can use YouTube chat to post the questions, that would be great. It means it's much easier for us to keep an eye on things and also with less chance of missing your question if it's good, you know, what we think a good question which generates some discussion. So please try to use YouTube chat instead of Slido for the questions. We've also been getting a few comments in the chat around feedback and the feedback codes. So before we go into the first talk, I'm going to hand over to Tudor, who's just going to give you a very quick demonstration of what sort of the feedback looks like and how to do it. So I'm going to just hand over to Tudor, hopefully to provide some clarity with regards to that. Tudor.
Okay, so hopefully you can hear me. Ben, can you hear me?
Yep, got you, perfect.
Okay. So the feedback form is designed so that you can jump in and out of the Paediatric Emergencies Conference as you see fit, watch the courses that you need, and even watch videos later on and still get CPD points. So the first part of it is just putting in your details so that you can get some a certificate with your name on it. The demographics, you fill in once and only once. So if you're coming back multiple times, please don't fill it in multiple times. When you get down to the talk section, there's talk codes listed here. I've got one here. So I'm just going to paste that in and you can see the intubation talk feedback then populates down below. Now, all you have to do is put that code in, either a comma or a space, a comma or a space, and then put in another code. You can put as many codes in for as many talks as you want, and then that will populate on your certificate to say these are the videos that you've taken part in. Okay, so that's how you do it. Then you go through the different feedback, and at the end, submit that, and you'll get your certificate emailed to you. Okay, so please you don't need to come up every time a talk is finished and get a certificate. You can do it all at the end, or even at a later date, as long as you have those codes. All right, thank you.
Thanks, Tudor. Hopefully that provides some clarity around the feedback provision. We're going to move on to the next first talk of this session then. It's going to be given by Dr. Peter Donnelly. Peter is a consultant pediatric intensivist based in Glasgow, and he's going to be talking about the management of the sick cardiac baby. So Peter, hand over to you. Thanks.
Just let me know if you can hear me and see my slides. That's okay.
I can hear you. The slides look like they're loading. Can't quite see them yet, but yeah, that's you now. Perfect.
Awesome, thanks. So yeah, my name is Peter. I'm a pediatric intensivist in Glasgow, which is a mixed cardiac ICU and general ICU. So I've been asked to talk a little bit about pediatric cardiac patients, focusing on babies particularly. So from my point of view, these patients can be pretty scary. But they're the fun patients, in my opinion. I love cardiac ICU. That's where I work, where I do. And for a lot of people, this is how you might feel or react when you hear that there is a cardiac baby coming into resus or to the emergency department, or who's become unstable on the wards. Sometimes you know they're a cardiac patient, sometimes you don't, and that's always quite challenging. And I would say that, you know, even though I work in a cardiac center with cardiologists and physiologists, cardiac surgeons, ECMO teams, it can still be pretty nerve-wracking. And if you don't have that backup, you don't have those capabilities, it can be even more stressful and difficult. So hopefully we'll go through a little bit of information that may or may not prove useful. It is impossible to cover congenital heart disease emergency physiology in 30 minutes, let alone sort of 30 hours, to be honest. But we'll touch through some key concepts. So if I were to say to you that you get a standby call, there's a baby coming into resus, and let's just say that they are, 1 week, 2 weeks, 3 weeks, 4 weeks old, somewhere in and around that remit, and they're presenting as a neonatal collapse, and they are apneic, and their airway is currently being maintained, and they're being bag mask ventilated. You know that they're acidemic, their pH is 6.8, their CO2 is 6, so they're being effectively bag mask ventilated, really. But their lactate is markedly elevated at 8, and their blood sugar is low at 2. Now, I know this is a cardiac talk, which is going to make this really super biased, but I just thought the first question I'd want to put to you guys is, what do you think the likely diagnosis is? I'll give you, say, 30 seconds to think about that. Anybody see any results there? Because they're not coming up on my screen.
No, we're not seeing them from our end here, Peter, unless they're in the app.
Yeah, I don't think it's your PowerPoint seems to be linked to the app here. I activated the poll in Slido directly, and sepsis is coming up as the most likely thing, with cardiac defect second, metabolic third, abuse fourth, and something else as fifth.
Awesome. I'll get you to feed that back to me each time then, Chris, if that's okay, because I'm not seeing it, unless I can see it on the app, but I'll see what I can see.
Okay.
Awesome. Okay, so I deliberately gave you those options because in my head, scams is the things that I think about whenever a child presents as a neonatal collapse. And it is important to have a framework in your mind as to what this might be. Now, you guys are absolutely right. By far and away, sepsis is the most common of all of these presentations. But it doesn't mean that it's not something else, right? So you have to have some sort of way of thinking through the differentials. A patient who is septic, yeah, they might present apneic, they might present cold, mottled, shut down, with apneas if they're in the neonatal phase of their life, with low blood sugar. That is absolutely how they might present, but it could equally be a cardiac lesion of numerous different etiologies. Unfortunately, yes, non-accidental injuries can present like this as well, as can metabolic disorders, inborn errors of metabolism, or something else. Every now and again, you get some sort of weird bowel condition, or there might be a congenital defect that has not been picked up at birth. And we've seen diaphragmatic hernias being picked up relatively late sometimes. So you have to keep a broad open mind as to what might be going on. Either way, the approach to management is, in my opinion, ABC 5P. Now, most talks will go through an ABC approach to management, so I'm not going to go through that in huge amounts of detail. For me, there are a few considerations if you've got a cardiac patient, but as I say, you may not know that it's a cardiac patient in your resus. And 5P refers to a way to approach management of neonatal collapse, and it does exist in some nationally available guidelines. So it's worth thinking about how you would step through that. There's no doubt in this case, the baby's apneic already, so the airway has to be your first port of call in terms of actions, and we'll get to that in a second. But before I tell you what my 5Ps are, I'm just going to put the question out there about, does anyone have any thoughts about what 5Ps may or may not stand for? You might know, you might not know, and that's absolutely fine. But I just want you to have a think about things that it might be. I'm happy to learn from you guys. It might be that by the end of this talk, we've got 10 Ps, and that's absolutely fine. But I'm just going to put that out there. Again, I'll just give you 30 seconds to have a thought about that.
Peter, I take it you're not allowed to say panic as one of the Ps?
I mean, you can panic. Panic's perfectly reasonable. It means you're recognizing that you should be worried. So I'm okay with that. The question is what you do when you panic. Okay, so I can see some of those answers coming through. So we've got Prostin. People know this is a cardiac talk, so awesome. Pulses, penicillin, pallor, panic is there, yep, perfusion, pre-postductal sats. So all of these things are absolutely, important. Prepare is a good one. People impressors, pulses, pupils, yeah, okay, awesome. I'm going to come to these in a wee second. But the first thing I would say, and it's just a stock image to show an absolute natural disaster, which in this circumstance, in this picture, is already happening. But for me, when you've got a cardiac baby in your resus who's already apneic, or any cardiac patient, they might be in your ICU or they might be on the wards. If you're setting up to intubate a patient who is this unwell, you have to expect that it's all going to go badly wrong. Not out of being totally negative, but just being realistic that this patient's physiology is pretty extreme sometimes. And a neonate is the same position. They may not be a cardiac neonate, but they still are fairly precarious. So I challenge everybody in these circumstances to think about how they might want to act and how they might want to plan for the impending disaster that you presume is going to happen. You hope that it doesn't, but it might. In my unit, we have got patients not infrequently with cardiomyopathy, and it may be that we have to intubate these patients. And in our unit, we will do that with a full ECMO team standing, scrubbed, prepared behind us, that if it all goes wrong, we have got the option of cannulating this patient in an emergency scenario onto ECMO. So even in a experienced cardiac center, we have a full preparation procedure to step through, recognizing that not everybody's going to have those capabilities. So I've showed this on a slide, not because I expect you to read through it all, but this is a version of our intubation checklist that we use for our cardiac patients, but we actually use it for all of our patients. And there is a few key things just that I will point out on this checklist. If you don't have a checklist like this, I would encourage you all to create one. There's plenty available online in terms of having a look through the options and creating something that you think is useful and relevant to your place of work. If you already are working in a cardiac unit, it might be that this child, or even not a cardiac unit actually, you might recognize that this child has been intubated before. If you've got electronic records, it's not too slow a process to find out what the previous grade of intubation was, particularly if it's recent. Yes, in some scenarios you can optimize their condition in terms of making sure they're fasted, etc. But in an emergency scenario, you just have to get on with it. And that's one of the key messages here. If you've got an apneic patient who's acidemic, and they might have congenital heart disease, it's okay to panic, but you do need to act, and that's really crucial. Now, there's always chat about passing NG tubes and aspirating them and trying to optimize conditions. If you've got a baby who is flat and not doing much, then that's largely okay. If you've got a cardiac patient who is not flat, who's actually agitated, who's got a heart rate of 220, who's on the very edge of their physiology, the last thing I want to do is then tip them over the edge by upsetting them and shoving something up their nose. So I'll absolutely be prepared to insert an NG tube. I'll have it measured and I'll have it lubricated, but I wouldn't do it until they're lightly sedated. From an oxygenation point of view, you inevitably will hear people worrying about how much oxygen and what saturation should a cardiac patient have. And I get that. I absolutely understand that. There are some cardiac lesions that you require a balanced circulation. And to put that into simple terms, what that means is that they have blood. If you think about it, they have blood in a common ventricle, for example, and that blood can either go to their pulmonary circulation or their systemic circulation. It gets to choose. And you have to manipulate their physiology to direct a proportion of that to the lungs and a proportion of that around the body. And if you are in that scenario, largely we would be aiming for saturations between 75 and 85%. But in many scenarios, like a resus scenario, you don't actually know that. So the important thing is to get on and support the left ventricle. And the best way to do that is to secure an airway and improve, their hemodynamics that way. Positioning stuff I'm not going to go through. And I don't think I need to go through equipment with you because that's an entirely separate talk. For me, the team section on this slide is absolutely crucial. You need to think about who your team leader is and who your first and second intubators are, just should the procedure be difficult. Where I work, if I'm the team leader, the next person who, whoever's the most experienced at intubation should be your intubator. Now, if they struggle, we might change roles depending on who we have available. And you need to have an airway assistant. You need to have somebody on drugs. You need to have somebody recording times. You may or may not need somebody to be free to activate ECMO callouts. From a CPR point of view, I will always have 2 people allocated to do chest compressions. They will always be asked to stand at a set side of the bed, in my opinion, and they will be asked to alternate chest compressions every 2 minutes religiously. Every time they hear a 2-minute call, they must swap. And if I feel either of them are getting tired or the chest compressions are ineffective, I will swap them out early. And as a leader, you have to be able to stand back and acknowledge that, but be absolutely prepared for that to happen. I have had that happen before, and we've been very grateful that we've been as prepared as that. So always anticipate that things will go wrong. From a medications point of view, I'm not going to go through all of these medications. Obviously, use medications that you A, are happy with, but B, are the right choice for your patient, recognizing that if this is a cardiac patient, their cardiac output is inevitably going to be reduced. Therefore, the drugs will take a lot longer to work than you might expect, and you should be really slow and cautious to minimize the detrimental effects of these agents. So for me, in my unit, we would regularly use fentanyl, ketamine, and rocuronium to put people off to sleep. And the doses that we would normally use are 2 mics per kilo of fentanyl, 2 milligrams per kilogram of ketamine, and 1 per kilo of rocuronium. So for a cardiac patient, I might just use a 0.5 to 1 mic per kilo of fentanyl and wait a good 3 minutes for that to take effect. And if I can, I will be really slow in putting these patients off to sleep, keeping a really close eye on their hemodynamics. Yes, Chris talked really nicely earlier about adrenaline and push dose adrenaline and adrenaline infusions. That, for me, in my opinion, that will depend partly on where you are and what access you have available. And I certainly wouldn't wait trying to put in central lines or trying to put in, if the IOs are failing, then I will go to push dose adrenaline rather than worry about adrenaline infusions at that point in time, because sometimes you just need to get on and act, but people will have their own opinion on that, and that's okay. The 5 Ps that we talked about earlier, they are triggers to make you think about that differential diagnosis and how you might think about it. And I agree with all of the ones already mentioned that aren't on this slide in terms of people and preparation. Those are crucial Ps too. Penicillin is about thinking about what antibiotic you might want to give this patient to cover sepsis. For the vast majority, they might use a cephalosporin, and that's fine. Prostin, a non-negotiable if this child might have duct-dependent congenital heart disease, you need to start them on Prostin. Phenylbutyrate is useful if you think they've got an inborn error of metabolism, and it is important to send an ammonia off on these collapsed neonates. If that's elevated, they need to go to a centre that will be able to provide hemofiltration, preferably a centre that can provide hemofiltration plus have a metabolic team available. From a protection point of view, if you think that there's a chance of a non-accidental injury, this child needs to be kept in a safe environment, and you do need to think about what other children might be at home and make sure that they are safe too. POCUS refers to point of care ultrasound. Again, I mentioned previously undiagnosed diaphragmatic hernias. So this can be really useful to try and ascertain what the diagnosis might be when you're still not sure. And the 6th one that I would add is PICU. It's really important that you look for sources of advice and support in these scenarios. And the reason I showed the intubation checklist that we had is that I think it's really important to be aware where you can find sources of information, guidelines, help, support, and your PICU and your local retrieval team is crucial to that process. So for this patient, hopefully you'll be able to see my mouse on the screen. You may not, but this patient, if you follow the blood flow in the heart, because congenital heart disease is all about the plumbing, right? It's all about plumbing, volume, flow, and pressure. And you can argue whether flow or pressure is more important. That will be debated till the end of time. But for this patient, blood going into the right ventricle will come out into the pulmonary trunk. It then has options. It can go right or left into the branch pulmonary arteries, or in this case, it can go across the patent duct and down the aorta. So that duct is crucial to supply blood flow into the descending aorta. That, in this circumstance, is the role of the duct. If you see the blood that would be coming into the left ventricle, it goes out the aorta, but it only goes so far because there's an interruption in that aortic arch. So for this patient, if this duct was to close, there is now no longer any way for blood to get down the descending aorta. So therefore they will become acidemic and they will become mottled and become increasingly unwell and present similar to how this case presented. So there are other left-sided obstructive lesions that might present very similar to this, such as critical aortic stenosis or a coarctation. So it's about thinking what it might be. The other trap not to fall into is that in this circumstance that I'm describing, the duct is essential for systemic circulation. You can be in a scenario where the duct is crucial for pulmonary circulation. Okay, so it's not always as straightforward as some people might think. Again, the crux of this talk is where can you find sources of support? Obviously, I'm not going through this entire slide, but South Thames Retrieval Service, Seana mentioned them earlier, and I used to work there. And they have fantastic resources in terms of their guidelines that are freely available online. And what I love about them is that they're really quite concise. So their neonatal collapse guideline is, I think, maybe 2, maybe stretched to 3 pages now, but it's super easy to follow, you know. And if you follow this from the top, and it guides you in terms of initial resuscitation, early intubation and ventilation, IV access, giving fluids, giving antibiotics. Very quickly, it prompts you to consider a duct-dependent cardiac lesion, and it moves you over to the grey boxes on the right side of this page. So it immediately starts the thought process, because what you don't want to do is miss something that you could effectively treat, right? Now, I recognise that this is a little bit blurry because it's just zoomed in from the previous page, but there are sometimes clues that this might be a duct-dependent lesion, such as cyanosis not responding to oxygen. So you might be able to give as much oxygen as you can into the lungs, but if you don't have blood flow into the pulmonary arteries, you're not going to be on a winner. If the problem's getting blood to the systemic circulation, you might have difficult to feel or absent femoral pulses. You might notice differences in forelimb blood pressures, saturations. There may or may not be heart murmurs, an enlarged heart. Bottom line for me is there's a really low threshold to start prostin. I know that some district general hospitals, this makes them nervous, and I understand that. And they'll sometimes start it at 5, and then, you know, they'll say, oh, should we increase it to 10? Should we, what do you think? Get it in. You know, this patient in this presentation is already apneic. There is no point, and I hear this all the time, I'm worried about putting them on high-dose prostin in case they become apneic. They're already apneic. Get it in and treat the patient. And you can't delay these things. So I would be straight in with 20, and I have a very low threshold to crank it on up to 50 to 100. You do need to recognise that there are consequences to every medication that you use, but you also have to recognise that if you don't treat the patient adequately, the complication of that is much more significant. Don't delay the transfer, so that's why you have to have early engagement with your transport team and your intensive care, and have a low threshold for intubation. If the SATs are low, if they're apneic, if they're acidemic, or if they're on high-dose prostin, most of us would make sure the kid was intubated so they don't have ongoing or recurring issues with apneas in the back of an ambulance. Now, I don't think necessarily for most of the specific diagnoses you need to get into your head about that and stress too much. There are some signs that might direct you towards the specific lesion, and they do exist within the same guideline. The one in blue I would mention, an obstructed total anomalous pulmonary venous drainage, is a terrible one to get, because there is nothing that you can do that will make this patient better. Okay, what the definitive action that is needed for a child with obstructed TAPVD is surgery, and you can't do that where you are if you're in a district general hospital. And it's another reason for early involvement with your cardiology or your cardiac ICU to recognise that this might be the diagnosis, and you need to get this patient to a definitive centre as early as possible. It's not unusual for these patients to be brought in a transport trolley with saturations of 20, 30 and terribly high lactates, and we'll stick a probe on them whilst they're still in the transport trolley, say, yes, it's TAPVD, go straight to theatre. They don't even stop in ICU. They just need to get to where they need to get to, and that can be pretty scary. To briefly mention another case, sometimes people will say, oh, it's not too bad because the mum and dad have given you this letter, and so therefore you know the diagnosis. Now, if it's 3 in the morning, you're not a cardiologist or a cardiac intensivist, and somebody says this patient's got double outlet right ventricle, transposition of the great arteries, a ventricular septal defect and pulmonary stenosis, you might think, oh my God, what on earth is that? And that's quite reasonable, to be quite honest. So that is really challenging, right? This is what that looks like. And the parents tell you, oh, he's had a previous shunt inserted and he's been unwell for, you know, a week and a half, diarrhea and vomiting. It was sort of settled, then it got worse again. And the heart rate's 190 and SATs are only 50, and you can't hear any murmurs. Now, if I go through this diagram of the heart, the blood's going into the right atrium, goes into the right ventricle, but they've got a big VSD, right? So to keep things really simple, because I'm a very simple-minded person, functionally there's this one big single ventricle type scenario here because of the size of the VSD. And the blood can go out either the aorta or it can go out into the pulmonary arteries. Yes, they're malpositioned, but it can go out either of them, except this patient's got pulmonary stenosis. And if it's a severe pulmonary stenosis, that will mean that they do not get adequate blood flow going to their lungs. So there has to be another way to facilitate that blood flow. Therefore, this patient has had a BT shunt. And if you remember a BT shunt, most circumstances that will come off the right brachiocephalic artery into the right pulmonary artery. Like all shunts, it will have a very loud, obvious, long, continuous murmur. So if this child is not saturating and you can't hear a murmur, that suggests there's no blood flow going down that shunt. So it's blocked, or it's shunt, or it's kinked, or it's twisted. Something is wrong with that. So again, I'll say to you, what are you going to do about that? Where can you find sources of help and support? Another reason to sim this type of scenario. This would be a more rare scenario because that usually, if there's problems with a BTT shunt, that usually happens in the first sort of 24, 48 hours post-operatively. So I'd be more likely to see this in my cardiac ICU than I think you would be. But I think you do need to be aware of the concept. This diagram on the left-hand side shows where the shunt exists. And you can imagine if that's blocked, that there is no longer adequate blood flow getting into the PAs. Again, I'm sharing a Glasgow guideline with you because I think it is quite useful. And you can find this freely available. Do a Google search. Go to section 3 here if you think they've got a blocked BT shunt. In this scenario, what you want to do is to try and make it easy for the blood to get to the lungs, right? Now, it might be that this BTT shunt is only partially occluded or partially twisted, and there is some blood flow that can get down it into the pulmonary arteries. So how do you encourage that? First thing, obviously, is call for help. If you are able to, call in the relevant people. This child needs definitive surgical intervention on their shunt. You work through your resuscitation ABC as before, but you have to initiate treatment and not delay things. So simple things are ventilate the patient, make sure that you're giving them oxygen as required, make sure that you do what you can to reduce their pulmonary vascular resistance. You want to encourage blood to flow into their pulmonary arteries. So keep them sedated, keep them muscle relaxed. Other things that will help that is keeping their CO2 normal to low, make sure their oxygen levels are high and give them a bolus of magnesium. Now, if you can, it's useful to also try and drive blood flow down the partially occluded shunt into the pulmonary arteries, and you can do that by using pressors. And I know Chris has already talked about pressors. There are some examples here of pressors that you might want to consider using, plus an adrenaline infusion. Most units will have their own limited experience of which they like to use, and you have to work through that as a team. Fundamentally, try and anticoagulate this patient, try and unblock the shunt. So we would recommend giving a bolus of heparin, which can be repeated as a half dose after 15 minutes, and start a heparin infusion. If the patient's still really young, you might find that they have the remnants of a ductus arteriosus, and if you start prostatin, that might give you another avenue to augment your pulmonary blood flow. So it's another consideration to have. But you really, fundamentally, for this patient, need to have your team involved, team activated, ready to go, ready to do what needs to be done. So I just wondered if people would mind sharing from the two cases that we briefly touched on what your take-home points might be from this before I share mine. Hopefully it's not still panic, but it might still be panic. Okay, so there's things coming through like being prepared, Proston, structured approach, 5 Ps, work in a cardiac centre. Everyone is welcome to come and work in a cardiac centre. They're phenomenal, but I'm very biased. Checklists and momentum. Yeah, I agree with all of those things, to be honest. For me, it's consider the cardiac diagnosis in the first place and don't forget about it. Prepare for instability, and people talk about that in terms of the teamwork and preparation. I think that is really crucial because this can all go badly wrong. Discuss these patients early and use resources. I think genuinely, if you're not in a cardiac centre, you do need to think about simulation and running through these variations of these scenarios as a team as to how you would do it. Where would you access support? What guidelines might be available to you in your region? And who would you call and how do you get hold of them out of hours, and what's the quickest way and what's the correct phone numbers to use? There have been circumstances where I've seen people try to phone the wrong number quite a number of times, and that delays things quite significantly. And then to consider definitive care and location for these patients. And I'll finish there.
Thanks very much, Peter. Really enjoyable talk. As you say, source of fear, I guess, at least this patient group for a lot of people who are working, particularly outside of cardiac centres. So it's always good to recap. We've had a couple of questions come through, some from the faculty actually today as well. So the first one I'm going to go with is, in what situation would you consider excessive oxygenation dangerous?
Excessive oxygenation, that's excessive. What's excessive? If you have a balanced circulation, right, and you are trying to create a circumstance where there is enough blood flow both to your pulmonary arteries in your lungs and enough to your body, you need to therefore balance that, right? So if you have a patient that requires that scenario and you're happy to accept SAT 75 to 85, if you are giving them pulmonary overcirculation and their SATs are sitting at 100%, there will be inadequate systemic blood flow, right? Your lactate will rise. Your lactate, instead of getting better, will get higher and higher. You will become more acidemic from a metabolic point of view. Your end organ function will start to deteriorate. Now, some of those things take a longer time to see. You'll have a drop in your mixed venous saturations. You might have a drop in your near infrared spectroscopy, for example. So it is a common thing for people to worry about over-oxygenation in these patients, but you have to balance it in terms of the patient you see in front of you. If you have a patient who you're bagging on 100% oxygen, or you're ventilating on 100% oxygen and their SATs are 100, you genuinely need to ask yourself, do they need to be 100? And you need to start bringing down that FiO2 and seeing what is the right number for that patient. If that child has SATs of 100, but they're mottled and they're cold and their lactate's rising, then you're not on the right line, they're on the right path. If you start to bring the saturations down to even 90 towards the high 80s and their lactate's improving, they're starting to get warmer and they functionally look better. So it is a judgment call based on the patient in front of your eyes, unless you know the diagnosis. Now, sometimes you speak to the cardiologist, or you'll ring the tertiary cardiologist and they'll say, this patient has got this, therefore aim for SATs of this. And that's another reason to get these phone calls happening early, because they inevitably will have more access to information than you do. And sometimes district generals will phone us and say, this patient's got a cardiac diagnosis, can you check the most recent echo for us so we actually know what's going on? So it's equipping yourself with the information whilst managing the patient that you see.
Thanks, Peter. There's also a question around, for a basic POCUSer, which probably isn't the word, so for someone with basic point of care ultrasound scans skills, and you talk about TAPVD, what would be the kind of clues that you might see on point of care ultrasound echo?
You're cutting out for me, Ben, or cutting out for other people? Cutting out for you as well, Steve?
Yes, it's cutting out.
I think his question was, if you can do basic POCUS, what would you pick up from your exam for TAPVD?
Okay. I mean, from a POCUS
point
point
again, can you hear me now?
Yeah, it's okay. I've got the question. Thanks, Ben. From a POCUS point of view, I wouldn't be relying on anything being sensitive or specific enough to pick up a diagnosis of TAPVD. That's my personal opinion on it. You know, people, you obviously have your classic chest X-ray appearances, right? If you were to ask me, would I say to somebody in district general if they phoned me and I've seen the X-ray and I've heard the story and nothing they're doing is making this patient get better, will I say, okay, go and get the ultrasound, find somebody who's trained in POCUS, go and take 10, 15 minutes to stick the ultrasound on and see what? Absolutely not. I wouldn't do that, because it's not, if you're worried about it, then move the patient to where they need to be. There are some circumstances where I have felt like, I'm not a cardiac diagnosis, where I have felt people have stayed and played with POCUS somewhat unnecessarily, because it's a new fancy skill and everyone like thinks it's a sexy thing and all the rest of it. That's fine. I'm basic. I'm always a basic thinker. I barely use my own phone, let alone using ultrasound, unless it actually is going to add something to the actual question. So from a TAPVD point of view, I think the important thing is not to delay. Don't play with ultrasound if it's not going to actually add to what you're doing. And I personally don't think it would in that circumstance.
Perfect. Thanks, Peter. Sorry, I'm not sure what happened to the internet connection there. Stephen, what you had a question about shunts? I don't know. Do you want to ask that before we move on to the next talk?
It's essentially, so how can you tell the shunt has suddenly started to open or function again after your heparin? Do you just get a sudden return to baseline physiology? Is it a slow process, or what's your experience?
Genuine real life experience. The shunt's blocked. The shunt's blocked. There's very little you can do to get open. That's the reality. But if you can get any increment in your SATs, then take it. So this will buy you time to definitive action. If your shunt is partially blocked or partially kinked, the kid's going for a shunt revision, probably for an upsizing of their shunt, or the shunt will get taken down and it'll change to a central shunt or a lax shunt or something like that. So the clinical sign you'll see if you've got improvement will be an improvement in your saturations. But it's variable what you'll be able to achieve, and it won't be definitive, but it will certainly buy you time to get the kid what they need.
Thanks, Peter. Appreciate that, and thanks again for the talk. In the interest of time, we're maybe going to move on to the next talk. So we've got Dr. Damien Gates joining us now. Damien is a paediatric intensivist in the Royal Belfast Hospital.
I think we're losing Ben again.
Yeah, I think we've lost Ben. So Damien's a paediatric intensivist. He works in Belfast with myself in the ICU, and he also works for the transport team. And I remember you're talking about bronchiolitis, aren't you, Damien?
That's correct, yeah.
All right, so we'll hand over to you now then.
Okay. So could you just let me know that this is showing up okay? And you can hear me?
Yeah, we can see and hear you okay.
Right. So yes, thanks for the introduction. Thanks very much for letting me speak today. So I'm going to do a talk about bronchiolitis. Might be quite a lot of information on the slides, but I'm hoping if people find it useful, you'll be able to refer back in future on the YouTube channel. I'm going to try and keep it fairly practical as well. So certainly in Belfast, we were starting to see a lot of bronchiolitis again at this time of the year, and I was up all night on a couple of nights ago picking one up, bringing them to our intensive care unit, and we're seeing them quite frequently now. So may well be that this is the most common presentation that people are dealing with as paediatric emergency and anaesthetic teams currently. So a bit of background, bronchiolitis is an acute viral lower respiratory tract infection, and by definition, it affects children under 2 years old, most commonly caused by respiratory syncytial virus, or RSV, and it is the leading cause for hospital admission in children in the UK under 1. In fact, 2 to 3% of all children are hospitalized with bronchiolitis. And the seasonal peak traditionally has been October to April in the Northern Hemisphere, but over the last few years, probably subsequent to COVID lockdowns, we've seen a bit of a variation in the seasonality of RSV, and we're seeing it even in the summer over the last few years. Most of the cases will be mild and self-limiting, and a small minority of those will require admission to PICU, those that end up in hospital, and then an even smaller amount will require mechanical ventilation. And in well-resourced settings, the mortality rate is very low, but it is significantly increased in infants who have pre-existing conditions as cardiac, respiratory, or neuromuscular conditions that make them more vulnerable. And there is a significant mortality burden globally in areas that have less healthcare resources. In terms of presentation, I'm thinking most people here will be familiar with this, but it is a clinical diagnosis. So starts usually with nasal congestion, sneezing, cough, possibly fever, reduced feeding as a consequence usually of the nasal congestion. And then it progresses further over the next sort of 48 to 72 hours into increased respiratory effort, potentially with grunting, head bobbing. On examination, you might hear wheeze and crackles and focally reduced air entry in some parts of the chest. And also you'll see an elevated respiratory rate, possibly elevated heart rate. Hypoxemia, if you check the SATs, and certainly in children that are hospitalized. And apnea, which is especially a feature of the disease in children who are under 2 months of age or who are preterm. And often in those particular age groups, apnea may be your first presentation. You might not have any other symptoms. The first thing that happens might be that the baby stops breathing. This is just a little kind of summary of the signs, symptoms, pathophysiology, and kind of a duration of symptoms, what you expect to see. So you can see this kind of peak between sort of 3 to 6 days, where very much you have this minute-to-minute variability in symptoms. So you have a baby who might work hard intermittently, who might suddenly work a lot harder and then might sort themselves out if they cough or they're repositioned. You might find that if you listen to the chest, you'll hear focal crackles and focal reduced air entry 1 minute, and then if you listen 5 minutes later, that part might be clear, but you might hear some reduced air entry elsewhere. You might hear intermittent wheeze. So very much a very dynamic respiratory status that they have in this period, where there's lots of mucus. And you can see down at the bottom, this histological photograph, you can see the nice open normal bronchiole, and then what happens in bronchiolitis is that it gets all swollen. The wall of the bronchioles get very swollen, and then you get all this crud basically in the airway, in the small airways, that plugs it all up. That's caused by the sloughing of the epithelial cells as the virus has kind of infected them and caused them all to kind of fall apart and get drop into the lower airways. And this is obviously what causes the cough and the obstruction. Investigations for bronchiolitis, there are actually no definitively indicated investigations. So you can monitor patients with bronchiolitis using pulse oximetry and with your clinical assessment, i.e. how do they look, what's their heart rate doing, what's their respiratory rate doing. There's nothing really otherwise that sort of is really necessary to guide your management other than in some particular circumstances. So respiratory PCR tests we use to identify the pathogens, and that helps with cohorting these patients in different parts of the hospital. Other things you might want to consider, so if you've got an infant who's under 8 weeks old and has fever, you probably should consider a septic screen, even if you have a kind of a feeling that this is bronchiolitis. And also, if you suspect that your differential might include pertussis, i.e. if there's really prolonged coughing spells that are associated with desaturation and apnea and vomiting, you might want to consider a full blood count to look for lymphocytosis, as well as your nasopharyngeal swab for pertussis and your respiratory PCR strip. Blood gases and chest x-rays are actually not routinely indicated, but you should think about them when you've got a patient who has severe disease, or you think there might be a complication, or also where there might be an alternative diagnosis that you suspect. Because if you're seeing 100 bronchiolitis every day, there will be the occasional patient who has something else, and that might lead you to look further. On the right there, you see an x-ray, which is fairly typical of a progressed bronchiolitis. So you get this right upper lobe collapse and then lots of fluffy changes everywhere else. But often, actually, there's not really any changes, not really anything significant in the chest x-rays, even if there are significant findings in auscultation. In terms of management, it's important to, this is always emphasized, I suppose, when we're talking about bronchiolitis, but there is no effective therapy for bronchiolitis. There are a big long list of things that don't work and that are not recommended. That includes bronchodilators of any form, caffeine, antibiotics, adrenaline or hypertonic saline nebs, corticosteroids, regular nasopharyngeal suctioning, and sevoflurane. Just additionally in the small print there, however, If you have a baby who's over, or child who's over 6 months old and has a predominant wheeze pattern when you're listening to them, and they have, they have an atopic history, say with allergies, eczema, hay fever, things like that, you can try there's nothing wrong with trying bronchodilators, but do stop them if it doesn't help, because if you give lots of bronchodilators to small children, it actually ends up making them work harder. And if it's not helping with wheeze, if it's not helping with bronchospasm, then it's not worth doing. What does help? Well, the best available treatment we have for bronchiolitis is simply time and patience, which we don't, I suppose, as medical professionals, we don't do very well. We don't have a lot of time and we don't have a lot of patience. And also certainly parents don't have a lot of patience either when this is going on. They want you to fix their child. But ultimately, supportive care is the absolute mainstay of management here. So give oxygen if your SATs are below 90%. Try nursing on their front, prone, just turning them around and moving them around. That helps move things around in the chest, might make them more comfortable. But emphasize to the parents that you're only nursing prone with monitoring attached, and it's not safe to do this in the household. They can be done in a safe area if you're talking about small infants. Support their fluid status, but do reduce their intake to 50 to 70% of their calculated maintenance, because these children do have a tendency to hold on to fluid. Provide nutritional support, so nasogastric feeding, whether that's continuous or small volume comfort feeds. Suction the airways as required, so don't do it as routine, but you may have to suction the nose if they get into difficulties and they need a bit of help getting some secretions out of the nose or out of the upper airways. Most of all, minimal handling, so just stop annoying the babies. And that might include the parents. So sometimes the parents will want to nurse these children, want to be all over them because they're worried about them. But sometimes you just need to say to them, hands off everyone, put them in the incubator and just leave them alone. And you have to watch and wait. We frequently in ICU get calls from DGHs worrying that these children may get worse, they might tire. And that's obviously a possibility. But the vast majority of these babies usually get better in time. They do usually get better. If you watch and wait, they kind of sort themselves out. You leave them alone, they mostly sort themselves out. Caveat by saying, escalate sooner in vulnerable infants. Those infants I mentioned that have cardiac and respiratory problems and neuromuscular issues. So what if they do get worse? So how do you tell? So babies with bronchiolitis might show signs that they're getting tired, as people say, or respiratory exhaustion. Again, another thing just to think about here is be wary of those children with neuromuscular disorders. So things like SMA and spinal muscular atrophy, they may not be able to show signs of increased work of breathing or increase their respiratory rate. So think about increasing heart rate and respiratory rate. If those are both going up, that might be a child who's struggling more. Worsening hypoxemia, so if you're struggling to keep your SATs over 60%, or sorry, if you're struggling to keep your SATs over 90% with 60% oxygen, that's a sign that you probably need to escalate. If you've got increasing work of breathing, if you've got more frequent and severe apneas, so small pauses of breathing in small babies especially, may be a feature and not necessarily a reason to go to ICU or escalate care. You might just need to give them a bit of a nudge now and again or a bit of a poke. But if these are becoming more severe, more frequent, if they're associated with profound desaturation of bradycardia, that's probably an indication to intervene or increase their support. Things that I would look for that show that maybe things are really going on a downward spiral would be grunting, which is auto peep that the baby's generating, trying to keep the small airways open, pallor, lethargy, and a slowing respiratory rate in this setting, because that might be a sign that they're not able to keep up anymore. And if you see these things happening, that would probably be an indication to increase your respiratory support. And we usually do this sequentially now, high flow to CPAP to invasive ventilation. And I would say if you see a baby who's really struggling like this, you maybe should consider antibiotics at this point in case there's a superimposed bacterial infection. So the support that we use is fairly well established now. So high flow is usually the first step. It's useful because a lot of pediatric wards will do this. I think most pediatric wards will do this. It's easy to apply and it's very easy to use. Delivers humidified supplemental oxygen via specialized nasal cannula. And generally we would say to initiate at 2 liters per kilo per minute. And evidence now is very well established that it's associated with improving symptoms, so greater comfort for the patient, reducing the length of hospital stay and length of oxygen therapy, and reducing the need for escalation of care versus standard oxygen therapy. But the most important part here is that there is no increase in adverse events. So even if you think high flow maybe doesn't work as well as we all say, it doesn't actually make anything any worse. It will make the baby more comfortable, so it's potentially worth doing just for that. How does it work? Probably delivers a small amount of PEEP, 2 to 4 centimeters of water, helps to wash out the anatomic dead space. If you've got a baby who's breathing really quickly and has airway obstruction, they're going to be rebreathing a lot of those gases. So it helps wash those out with oxygen. and it humidifies, so it's better comfort at greater flow rates. CPAP, so that's the next step up. Usually that delivers PEEP, keeps those smaller airways open, and reduces the work of breathing for the baby. This is usually considered HDU level care, and pediatric wards may not do this. When I worked in Scotland, there were some wards who had HDU settings who would initiate CPAP for small babies, and that was very useful. It is simple to use, but some interfaces can be tricky to attach. However, it can be delivered using the nasopharyngeal airway. It is less comfortable than high flow for babies, but it gives more respiratory support. And for those smaller apneic babies, it also gives them some nuisance value, i.e. it stops them from stopping their breathing. And you usually start at a PEEP of 5 to 6 centimeters of water. So in terms of mechanical ventilation and intubation, indicated if your escalation through respiratory support isn't working. So you've got worsening respiratory failure despite all the steps you're taking to escalate. You've got persistent apneas or significant apneas that require intervention, i.e. bagging, and hemodynamic instability. And in which case, if you have hemodynamic instability, I would suggest you review the diagnosis. And then if you've got a baby who has an impending or who has actually had an respiratory arrest, I think that would also be, I think most people would consider that a reason to intubate. We'll go through some preparation and things you should consider with this, because in my experience picking babies up from district general hospitals with bronchiolitis, I think people often do want to intubate, and often quite quickly actually want to kind of move on and escalate the intubation, but then they tend to struggle quite a lot with these babies once they've done that, because the hard work is still to be done once you've decided to do that. For the most part, I find that after the gas that's done before intubation is better than the ones that I see after intubation when done in most district general hospitals, and that's my general experience, because there is a real difficulty with ventilating these children afterwards. So I would advise that you pre-oxygenate the child with PEEP if you can by a Mapleson circuit, so you offload the work of breathing and give them a bit more support. If you can't do that, just keep the respiratory support that they're on, their high flow are on, until you're ready to kind of support their airway, and turn the oxygen up to 100%. I would pass an NG tube so you can empty the stomach of feed and air, and have someone who can intermittently or continually aspirate so that the stomach doesn't blow up. Ensure that you have your continuous pulse oximetry, non-invasive blood pressure and cardiac monitoring. Make sure you have at least one working IV line, preferably 2, but use an IO if you don't have one so that you can get things done quickly. And prepare a fluid bolus, as these children might be relatively dehydrated and you might get some hypotension when you give your induction drugs. In terms of the team, this might be a shared process between pediatrics, anesthetics, and ED. So you should define suitable roles depending on the sort of the skill set. Consider using the most experienced neonatal intubator if dealing with a small infant. That might be a neonatologist rather than an anaesthetist. And there is, I have, anecdotally, I have had some anxiety with intubating small children with anaesthetists who don't have to do it very often in DGHs. And so it might be worth having a discussion about who the best intubator is. Consider the setting for intubation. Should you move to theatre or to the intensive care unit? If it's a neonatologist intubating, I would suggest that anaesthetics still prepare and give the drugs, because although I might be out of date, but generally I think the neonatal approach to induction is an opioid, i.e. fentanyl, and then succinylmethonium, and this just won't be appropriate for babies with bronchiolitis. And anticipate potential problems and prepare your plans. So any features of the challenging airway, these babies normally will have a standard airway, won't have a majorly difficult airway, but the whole situation will make it more challenging. Look for any features of hemodynamic compromise. Again, consider your diagnosis with this, and speak to your regional ICU and your retrieval service for advice. In terms of preparing your equipment and drugs, so it suggests use ketamine 1 to 2 milligrams per kilo, plus or minus fentanyl 1 to 2 mg per kilo, plus rocuronium for your induction, and consider having some atropine close by. I would suggest using this mix, even if you're more familiar with other anesthetic drugs, because this is the most cardiostable kind of induction. It's the standard that we use in ICU. Ketamine will give you some tachycardia, which will help with your cardiac output in these infants. You might want to, if you're thinking about using propofol or sevoflurane, it's probably going to be okay most of the time, but I've said to keep thinking about reviewing your diagnosis. And there are at least 1 or 2 children who look like a bronchiolitis every year who turn out to be a myocarditis or a cardiomyopathy. And if you use something that kind of causes more depression of cardiac function, you might get into difficulties with that. So I would suggest just sticking with kind of our standard of ketamine and plus or minus fentanyl and rocuronium. Straight blade is usually recommended in small infants for direct laryngoscopy, but you should use the equipment you're most familiar with. The most familiar video laryngoscope probably is first line. I would suggest a microcuffed DT tube with a stylet as primary oral intubation, but do consider an uncuffed endotracheal tube, particularly in infants who are under that weight range of 2.5 to 3 kilos. You should have inline continuous waveform capnography and maintain it in the bagging in the ventilator circuit. Consider the ventilator circuit you're going to use post-intubation and look at the dead space you're going to create. Use an appropriate pediatric ventilator and circuit if you have one. It might be worth thinking about getting a neonatal ventilator if this is a very small baby, or a transport ventilator that has infant circuit and settings for very small infants. And do set it up. Make sure it's all calibrated and set up well before you put the baby on the ventilator. Other considerations with the patients in particular, so infants and neonates have a relatively a baseline reduced respiratory capacity versus older kids and adults. So they're obligate nasal breathers when they're very small, so they're very narrow airways. Cartilaginous ribs with highly compliant airways and chest walls, so they're very prone to collapse, and that's why you see all that recession when they're working very hard. Gastric dissension will splint their diaphragm and make it harder for them to breathe and make it much harder for you to bag them. They proportionally greater anatomical dead space, and they have a lower functional residual capacity. And with all that in mind, they also have an increased basal oxygen consumption and metabolic rate, all of which will be made worse by bronchiolitis because their heart rate will be up, their breathing rate will be up, and they'll have less lung capacity. They'll have more sticky airways, narrower airways. So all the things are made worse by this. In terms of their anatomy, they have small mouths with relatively large tongues, relatively large floppy epiglottis, lax thyroepiglottic ligament. So this is why we talk about using a straight blade to lift the epiglottis directly, because if you go into the vallecula and lift, you might see this floppy curved epiglottis hanging over your vocal cords. The vocal cords are relatively high and anterior versus older children and adults, and they have dominant vagal tone. So if you instrument this airway, you can cause profound bradycardia. And I suppose the summary of all this is, even if you pre-oxygenate really well and optimize them really well, these babies are very likely to desaturate even with all that. And you will be doing a modified RSI, and these babies, you will have to bag them when you've rendered them apneic with your drugs and your paralysis. Positioning is important for small babies, so keep the head in the neutral position or with slight extension. Avoid excessive flexion or extension, and think about shoulder elevation. You can see in this picture, there's kind of what a bit of shoulder elevation does in terms of bringing the cords into view. Post-intubation, so the work doesn't finish when the tube's in. Actually, sometimes the hard work begins. So you need to secure your ET tube and be prepared to manually ventilate the child with the bagging circuit through the ET tube. Bear in mind, these are very small, delicate lungs, very small tidal volumes, so bag gently. Secretions are likely, unless this is a baby who you've intubated for apnea, who's just stopped breathing and they're very small and very early on in their disease course. Secretions otherwise in other infants are likely to be a major problem. So be prepared to suction the ET, and you should bag through maybe a 0.5 to 1 ml of saline to help loosen mucus plugs. You might have to do this multiple times to try and get as much out as you can. Chest physio at this point will be helpful. So if you can do a wee bit of amateur chest physio, or there's a physio nearby who can help, that will actually help to optimize things. Feel the airway resistance while you're bagging, and feel the turbulence on the bagging set before attaching to the ventilator. So if you can feel that the baby's still got a lot of stuff down there that you need to get out, it might be worth kind of still bagging, still trying your suction before you set them up on the vent. Initial ventilator settings that I would suggest. So try, if you can, we in our unit, we pick a tidal volume mode, but you can also use a pressure targeted mode. So I would suggest aiming below 30 to start. You're trying to get the chest to move adequately, and you'll be aiming with your pressure to achieve a tidal volume of about 5 to 7 mils per kilo. Set your initial peak to 5 to 6. If there's a large collapse or consolidation on the X-ray, this potentially could be increased to try and recruit more lung volume. Keep your rate physiological, so between 20 and 30, probably start at the higher end initially and then reduce if you can. Inspiratory time, usually 0.7 to 0.8. You might be able to, sometimes when I'm transporting these children, I might prolong that slightly if I'm struggling to hit tidal volumes with the pressure I've dialed in, but I would usually stick to 0.7 to 0.8. Aim for oxygen saturations over 88% and your end tidal CO2 between 5 and 10. And if your pH is over 7.25, that's probably okay. You probably don't need to thrash these lungs. There is a risk of ARDS with children with bronchiolitis. There is a risk of gas trapping with a concurrent risk of pneumothorax. So try not to thrash the lungs too hard and trying to accept a bit of relative hypoxemia, a bit of relative hypercarbia. People do struggle after they've intubated and they've tried to get on the ventilator. So basically go back to the principles of the DOPES assessment in terms of trying to address the problems you're having with ventilation. So working through that in order. So D for displacement. So confirm your ET placement with your waveform capnography and then get the chest x-ray quickly so that you can see what positions it's in case you need to move it up or move it down. So in very small infants, a ½ centimeter can make a huge difference. So get the x-ray to see what you have to do and then measure it out on the x-ray to see where you need to position it. Obstruction is probably going to be your major problem. So you might need to suction frequently and mucus plugging is very common. And I've had ET tubes block on me with children with bronchiolitis when I've retrieved them, when I've been doing all this before I put them in the ambulance. If you hear wheeze, it's almost always secretions. I have to emphasize that. It's almost always secretions. So try and clear the child's chest and clear the ET tube rather than reaching for bronchodilators. Assess for pneumothorax. So if you have the ability, use lung POCUS to do that or use a chest x-ray and aspirate if indicated. If there is a big pneumothorax, some pediatric doctors might be happy to cite a chest drain who have extensive neonatal training or experienced in the process, might be able to cite a chest drain if you're struggling to continue to ventilate with needle aspiration only and you need to get on and do that before the retrieval team arrives. In terms of equipment, try and minimize your dead space. I wouldn't recommend cutting the ET tube because the difference in dead space of doing that's fairly minimal, but look at the rest of your circuit. And if you have to bag the patient while you're ensuring the ventilator set up correctly, just do that. And if you can't get them on the ventilator and you need to keep them safe, just continue to bag them until the retrieval team gets there. Thinking about stacking that, so gas trapping can occur. So allow adequate expiration time on your ventilator and if you're bagging. Suction and physio will help with this. If you do have prolonged expiration and gas trapping, again, wheeze, this is almost always due to secretions. So adding bronchodilators or using sevoflurane is very unlikely to help. Focus on clearing the secretions. And if you use sevoflurane, you are likely to end up causing a bit of hypotension and not helping in terms of the airway obstruction. And the reason why I'm highlighting this is because I have seen it done numerous times by people who are really trying to do the best they can for the baby, but maybe aren't as familiar with the pathology that they're dealing with. While you're waiting on the retrieval team, start your IV fluids at 70% maintenance. Recommend that you use normal saline plus dextrose, 5 or 10%. These babies will need sugar, or if they're not being fed and they've been not feeding very well for several days and they're sick, they will drop their blood sugar. So they need some sugar in their fluids. And if they're very small, very new, they might be 10% rather than 5%. Establish your intravenous sedation as per your regional transport team policy. So in our region, that would be morphine and midazolam. And you can give rocuronium boluses as required to keep the patient still and to help ventilate them. Try to ensure there's at least 2 working points of peripheral IV access. Central lines and arterial lines are generally not required for babies with bronchiolitis, and we wouldn't insert these as standard when we bring them to PICU. We would not expect you to insert them either. Once you've got the baby established on the ventilator and got them tubed, you can do capillary or venous gases to kind of see what your initial gas is, and then you can monitor them by looking at their tidal volume on the ventilator, looking at their end tidal and their pulse oximetry trends to monitor the ventilation at that point. You don't need to do gases very frequently if everything's stable from that perspective. And always discuss with your retrieval team or PICU if you're concerned, and review the diagnosis if things don't add up. So all the things that people have been talking about in the other talks in terms of collapse neonates, cardiac, always think about those things. Again, because you've seen 100 bronchiolitis already today, it doesn't mean that this one who looks like a bronchiolitis isn't something a bit different. So do review your diagnosis if they're not behaving the way they should. And what happens in ICU, just to finish up? Well, in our unit in Belfast, usually we will change to a nasal ET. We don't want you to do that in the DGH. If you've got a secure oral airway, there's no need to go messing about with it. But we will change it to a nasal ET, usually if we've got a stable patient who we're ventilating quite well, so that because it's more comfortable for the baby and means we get to use less sedation. We'll start enteral feeding as soon as possible. the babies aren't routinely muscle relaxed. We want them to spontaneously breathe. We'll get some physio and ET suction to help clear the airways. And we'll kind of allow them to have a relatively high PCO2. We'll allow their SATs to kind of run 88 and above, and we'll aim to extubate them sort of 48 to 72 hours later, sooner if possible. And that's everything. I'll run through that quite quickly. I'm happy to kind of take any questions now if there's anybody has anything to ask about. Thanks everybody for listening. I hope that was useful.
Thanks, Damien. As you say, one of the more common conditions we'll talk about today. Most of us will have experience in managing children with bronchiolitis, including those who are acutely unwell. And it's interesting because the seasonal variation, which is so predictable before COVID, has changed slightly, and also with the rollout of RSV vaccines here in the UK for mums in pregnancy, it'll be interesting to see how that affects things. There was a question came through around apneas and how many apneas are too many apneas to buy you intubation, and I suppose the second part of that question, and is there a role for high flow and CPAP in the baby with bronchiolitis who's having apneas, or is apnea itself an indication to proceed straight to intubation?
I suppose it's a difficult one because no one likes to see a baby pause their breathing, and it's very alarming for nursing staff. It's very alarming for medical staff. It's very alarming for parents as well. So there might be a feeling that no apnea is tolerable for some people, and I'm not going to contradict people. If you see a baby and they've stopped breathing in front of you and you feel you need to escalate care, I'm not going to I wouldn't try to undermine your clinical feeling at the bedside or your impression, but I would say that it is that small pauses in breathing can be normal. So when I think about apnea, I'm thinking about a prolonged pause in breathing. So you're talking about 20, 30 seconds. And though I think if you're seeing that kind of standard of apnea associated with desaturation and bradycardia, I think that would definitely be an indication to escalate your respiratory support and to intervene. If you're seeing small pauses in breathing that are kind of self-resolving, the baby's kind of coming out of themselves, maybe with brief desats, or they come out of it with minimal, sort of just a wee bit of a bum pat or a bit of a poke, then I think that's something you can watch and wait. But you should have a higher kind of level of suspicion for that baby that they might get worse in time. Obviously, if this is a baby who's very vulnerable, if they're small, if they're new, if they're preterm, if they've got an underlying condition, then you might have to intervene sooner or think about escalating sooner. So it's all about context, and I don't want to undermine people's own personal decision making. This is ultimately a clinical decision at the bedside. There's no instructions here. It's just that try and see the trajectory. You can have a wee bit of time. You can see how they respond to things. I think that's important as well.
Thanks, Damien. And the second part of that question was really around the apneas and whether apnea itself is a intubation, or whether there's a role for high flow CPAP in babies with or infants with bronchiolitis.
Sorry, what was that, Ben?
Sorry, Damien. It was around is apnea itself an indication to go straight for intubation, ventilation, as opposed to trial of high flow or CPAP?
I think it depends. Again, it depends clinically when you look at the baby. If you think they're kind of and what you're calling apnea. So if you've had a pause in breathing, and but then when you look at the baby and they've recovered from it and they look very vigorous and they're crying and they look like they're really still got quite a lot of fight in them, I would suggest that you could probably start with high flow or CPAP, and I have done so in the past and avoided intubating. And I have to say, the difficulty here is when you're in a DGH, where you've less, I suppose when you're an intensivist, you're kind of in your ivory tower, and it's very easy for you to say all these things because you can go down and you can look at them, and then you can make the decision with kind of loads of time and monitoring around you and loads of staff around you. So I recognize the difficulty when you're in a DGH and you have less staff and you have less ability to monitor these patients on a full pediatric ward. But I have certainly in our hospital seen babies who have paused their breathing quite significantly and have escalated their respiratory support. You have to look at the resources you have at hand and whether you feel that it's appropriate for you to do that in your setting. But I think you can rescue some of these babies even if they have significant apneas as presentation with high flow and with CPAP. But I would caution that in my context, that's where I have ICU on site and I can do something about it if they fail. I think if you're more worried that you don't have kind of the ability to intervene quickly enough, or you don't have the ability to monitor them well enough, then you're perfectly entitled to kind of talk to your local retrieval service, talk to your local ICU and say what your concerns are and discuss that decision with them and try and make that decision together. But in my experience, you can prevent further escalation of care in terms of intubation with high flow or CPAP.
Perfect. Thanks, Damien. Probably time for one more quick question. There's a question around surfactant. I know there's a few trials going on, Cursurfix, etc. Where are we with surfactant in bronchiolitis and ICU?
I might take this one because I'm one of the PIs in the best trial, which is the first RCT to look at the use of surfactant routinely for babies with bronchiolitis. The answer is there's no evidence yet. Certainly not for routine use. Certainly not something a DGH should be thinking on the outset. Is still very much experimental treatment at this point. The best trial results will be published in the next few months. I can't really disclose anything before that. Steroids, again, absolutely not in a DGH, not in children that have not been intubated. We reserve those for the 1% minority of the intubated population that has significant ARDS and have been on a ventilator for, over a week with awful ARDS type pictures, which is not routinely what we see in bronchiolitis. So bronchiolitis, even if intubated, has a very high survival rate, above 98%. And these are for that tiny 1 to 2% that are not improving after a week on a ventilator. So not something you should be thinking of on a DGH, certainly not routinely. This is not asthma, very different to asthma, and don't confuse the two.
Perfect. Thanks very much, Costas. And thanks again, Damien, for your talk. We have one more talk before lunch, slightly longer one. This is a joint presentation of Dr. Peter Cosgrove, who's a paediatric emergency medicine consultant in Belfast, and Dr. Rory Sweeney, who's a paediatric transport consultant in Belfast. And they're going to talk today about traumatic brain injury and time-critical transfer. So over to you, Peter and Rory.
That's great. Thanks very much, Ben. Can everyone hear me okay?
Yeah, we can hear you. We are seeing the slides with the notes as well. That's
super. All right. Well, thanks very much for having me on today and let me talk about traumatic brain injury, henceforth called TBI, and the approach to cerebral resuscitation from a neurocritical care perspective. In the next 25 minutes, I'm going to break this down into 3 components. We're going to review the basic neurocritical care physiology, talk about the
Sorry, Peter. Just to let you know that you are sharing your presenter view rather than the...
Oh, thank you. How about that?
That's better, yep.
perfect.
Okay, cool. Thank you. All right. So, yes, I will talk about the basic physiology, intracranial compliance, and cerebral autoregulation. I will touch on some of the clinical herniation syndromes beyond which we may be familiar with at a basic level. And then lastly, we'll talk about the management of severe pediatric TBI, asthma therapy, cerebral metabolic rate, and very, very, at the end, mention the second tier therapies. This is going to be a little heavy going over the physiology. So in order to break this up, I've introduced some mental breaks at 2 or 3 points during it. So this was a fun encounter we did when I was teaching in the US. So completely not related to anything medical. As an example, I've picked out some coding diagnosis on the ICD-10. We've here in Belfast recently gone on to Epic, and there's been some challenges with our clinical coding because of the UK list of ICD-10. However, in the unabridged and fully available list, we can find other quite hilarious clinical codes that do exist as a diagnosis for a visit. The first one I will introduce you to is the code W5622, where a patient may be struck by an orca on the first presentation. But to jump back into neurocritical care, we're going to start with a brief case just to set the scene. So a 16-year-old male is transferred to the PICU 5 hours after an MBC. He suffered a severe TBI. At the scene, his arms were stereotypically flexed and adducted with wrists flexed. He opened his eyes minimally, but only to a firm sternal rub. Prior to intubation, he moaned but made no discernible words. On arrival to the hospital, he's found to have minimal other injuries. An EVD, an external ventricular drain, is draining and open to 15 centimeters of water. His vitals are as follows, and he's not overriding the ventilator. He's hemodynamically stable with a BP of 94 and 45 after volume resuscitation. So that will set the scene. The first pearl is the difference here between decorticate and decerebrate posturing. As you can see, with the key take-home point is that decorticate, which is the flexor posturing you can see on the left, which indicates problems with the cervical spinal tract or the cerebral hemisphere, essentially a supratentorial lesion, whereas a decerebrate or an extensor posturing, which you can see here on the right-hand side, or at the bottom, which is really a problem with your midbrain or your pons, namely brainstem dysfunction. The Monro-Cayley doctrine really states the pressure regulation within a fixed component. So an increase in volume of one intracranial compartment will lead to a rise in intracranial pressure, ICP, unless it is matched by an equal reduction in the volume of another compartment. As you can see here, the compliance curve of the brain at a high intracranial volume, small volume increases will produce massive changes in the ICP and the intracranial pressure. Venting of the CSF into the venous circulation by increased reabsorption through arachnoid granulation is a very slow process of about 25 mils an hour. The vast majority of the compartment obviously is the brain itself. And then both the CSF and arterial blood drain into the venous blood and subsequently out. The CSF is produced, makes only up about 10% of the volume, and either is drained to the spinal canal or again reabsorbed into the venous system through the arachnoid granulations, and the same with the arterial inflow. What this looks like is a very steep compliance curve at critical volumes. So this is the pressure volume curve for the ICP divided into 4 zones, and I'll just draw your attention to the right half, where in phase 3 of minimal compliance, there's obviously a poor compensatory reserve and increased risk of cerebral ischemia and herniation. And at the very top, we have critically high ICP causing collapse of the cerebral microvasculature and disturbed cerebrovascular reactivity. In a very simple diagram, we have stable volumes of the brain, which doesn't change between compensated and uncompensated compliance, the arterial blood, and then once we have the introduction taking up volume and pressure of mass and edema, which then may extend, we have severe effects on both our CSF and our venous compartments. So this is an old study that is a fantastic graph to highlight the minimal impact of volume at high volumes on pressure. These graphs actually are rarely labeled because their original data come from dog studies. The reason of the importance of this is that the working relationship goes both ways. You need to remove only a relatively trivial amount of CSF also from the brain in order to make a tremendous difference in the ICP. And as you can see here, an increase from 53 to 75 millimeters of your intracranial pressure from only 1 milliliter in your intracranial volume. So how does the brain regulate this pressure volume relationship? And unfortunately, the nature of neurocritical care and TBI is that autoregulation is only effective between a set range of cerebral perfusion pressures, as you can see in the middle with the blue horizontal line here. So on one hand, the cerebral perfusion pressure is really used as a clinical surrogate for the adequacy of cerebral blood flow and perfusion. So when a minimum CPP is not met, whether due to hypotension or markedly elevated ICP, the brain receives inadequate cerebral blood flow and ischemic injury occurs. On the right hand, when you've got high pressure, high perfusion pressure, the relationship becomes pressure passive. So elevated ICP-related injury occurs through one of 2 mechanisms, either ischemia or brain herniation. On the other end of the scale, when the minimum cerebral perfusion pressure is not met, the brain receives inadequate cerebral blood flow, and again, cerebral ischemic injury occurs. Your cerebral blood flow is largely determined by your driving perfusion pressure over your vascular resistance, your cerebral vascular resistance, which is Ohm's law. To break down both of those parameters, your CPP and your vascular resistance, your cerebral perfusion pressure is typically defined as your MAP, your mean arterial pressure, take away your intracranial pressure, or sometimes your central venous pressure, whichever one is higher. In this setting, the ICP is a surrogate for venous pressure in the dural sinus. Your vascular resistance, your cerebral vascular resistance is defined by your Poisson equation, which largely and unfortunately is fairly fixed variables in the brain, with the exception of the radius. The length of the cerebral vessels and the viscosity are obviously not susceptible to rapid adjustment, and so cerebral blood flow autoregulation is really a primary issue of controlling the cerebral vessel diameter. How does the cerebral vessel diameter change? Largely changed and driven by these three systemic variables: your PaCO2, your oxygen, and your metabolic rate. So on the side of your CO2, you have hypercapnia, which drives vasodilatation and increases your cerebral blood flow, which therefore increases your risk of hyperperfusion. On the other end of the spectrum, the hypocapnia results in vasoconstriction, which reduces your cerebral blood flow and also then drives your risk of hypoperfusion. Your arterial oxygen content is largely fairly stable except for levels less than 50, where hypocapnia, severe hypocapnia, is really what drives vasodilatation, increases your cerebral blood flow and your risk of hyperperfusion. However, most critically, the metabolic demand is really the main regulator of regional cerebral blood flow and refers really to the cerebral blood flow, glucose metabolism, and coupling. So that brings me to a very quick and brief review of the basic physiology behind why we do. So the next mental break for ICD-10 diagnosis code that thankfully we won't see over here in the UK, but you can probably find in the US, is the code of V97.33. If you have a patient, maybe in a TBI setting, that has been sucked into a jet engine. The herniation syndromes. I'm going to limit to talk about the most common and well-known rather than each individual one. But as you can see on the cartoon here, we've got quite a few of types of herniation, both supratentorially and infratentorially. On the picture, the extracranial, subfalcine, central descending hernia, a lateral, and tonsillar hernia. And then here on the sagittal, you can see the ascending and tonsillar hernia as well. So what we'll talk about is the subfalcine, the lateral and central descending hernias, and then very briefly mention the tonsillar hernia. As I'm sure everyone's aware, the falx and the tentorium divide the brain into several compartments, but leave openings through which tissues can herniate. So which really means that the herniation is the displacement of part of the brain through an opening or across a separating structure into a region that it does not normally belong. So you can see the falx at the top, and then the posterior cranial fossa, and then the lateral bit of the tentorium here, which is continued on the sketch over here, separating the upper and lower brains. When the ICP increases, the brain tissue obviously drifts toward a compartment of lower pressure. So this is a CT scan at the level of the midbrain. So you can tell a CT scan is at the level of the midbrain because you can see the star above the Mickey Mouse diagram here. I'll orientate you briefly to the anatomy. So this is the level of the midbrain when you can see the cerebral peduncles, which are demonstrated here on each side. Anterior to the Mickey Mouse shape, which you can hopefully see here with the ears and the tongue, is the star, which represents the suprasellar cistern. Posterior to the Mickey Mouse smile is the quadrigeminal plate cistern, which is the flat portion, and then the angles or corners themselves are the ambient cisters, and then the fourth ventricle appears even more posteriorly. The temporal horns are the most dependent portion of the lateral ventricles and are really one of the first places you're going to see dilatation in the setting of raised pressure. For those of you who want some follow-on materials, I've put a QR code to a very good YouTube video for the neurocritical care approach to reading through these and interpreting a variety of abnormalities. But for the sake of time, I'm going to stick to some of the high-yield herniation syndromes. The most common is the subfalcine herniation, and indeed, probably clinically, you might not think of it as one because it can present very, very mildly. So the anatomy is where the herniation of the ipsilateral cingulate gyrus occurs beneath the falx cerebri and is pushed middly here, as you can see, resulting from a subdural hematoma on the left. The clinical presentation is often asymptomatic, and obviously one may have a headache, but specifically due to the compression here of the pericallosal artery, you can sometimes develop contralateral leg weakness. So again, it's very mild as a sign, but in those patients that you're watching, that is a very specific thing to find. What does it look like? So as you can see here on CT, the septum pellucidum, which is kind of the white line, as you can see outlined here, should normally be in line with the falx, which you can kind of see at the very bottom of the CT. So the anterior falx, although technically still somewhat rigid, is displaced secondary to the mass effect. On the other hand, the posterior falx, which is back here, is wider and more rigid and will resist the displacement, which is why the subfalcine hernias occur anteriorly and affect the pericallosal artery. The herniation of the cingulate gyrus here under the falx, seen on coronal contrast enhanced CT, notes the compression of the ipsilateral ventricle and the dilatation of the contralateral ventricle with the arrowheads. So after the most common type, so the second most common is the descending transtentorial herniation. So this is where the cerebral brain tissue is displaced downward through the tentorial notch. It can be thought of really as a continuum from lateral to central, but most commonly what everyone thinks of as one of the most common types of herniation is when the medial temporal lobe, most commonly anteriorly, which is therefore then the uncus, which herniates downwards into the ipsilateral crural cistern through the tentorial incisura. Posteriorly, it's not the uncus, it becomes the parahippocampic gyrus, which herniates downwards into the posterior lateral part of the same incisura. Centrally is, the midbrain. Is the diencephalon is the midbrain and pons, which are pushed centrally as a continuum as a result of increased pressure. What this looks like on MRI here is, you can see, I'll just highlight the labels. So the white arrow shows the cerebral falx and the interhemispheric fissure. The black arrow is again our favorite pericallosal artery here. The cingulate gyrus and the corpus callosum as benchmarks, but here is the temporal incisura, which is kind of the hole in between the two temporal ligamentous regions, which is where the herniation occurs through. The white arrowheads is the tentorium itself, and then the hippocampus here roughly. So at the posterior part is where you're going to have the hippocampal gyrus. What this again looks like as a lateral transtentorial herniation, this is again what a lot of people think of in the context of a blown pupil. Here with the big curvy arrow, you have the uncal herniation, which again you can see on the cartoon mirror, but I'll start on the CT first. You have widening of the perimesencephalic cistern, and then with the star you can obviously see dilatation of the contralateral temporal horn, all indicating a shift to the patient's left. The black arrow here, the black arrow here highlights both the impact on cranial nerve 3 and then the white arrow, the compression of the pericallosal artery as well. So we've mentioned cranial nerve 3. So early, that's why you're going to get that palsy, dilated pupil, down and out, and ptosis. You're going to develop obstructive hydrocephalus because of the aqueduct of sylvius compression. And then later on, if it progresses, you're going to get hemiparesis because of the contralateral cerebropeduncle compression and visual defects due to the pericallosal artery compression, which may lead to occipital infarction. And to a degree, you may have some clinical hyperventilation the patient does themselves due to midbrain compression. Obviously, to state the nature of this interpretation, then the blown pupil with a normal level of consciousness is quite unlikely to represent an uncal herniation because the blown pupil is the cranial nerve compression caused by direct pressure against the midbrain. So you're going to have both things that happen at the same time. Tonsillar herniation. So we're jumping to this as the other, what people kind of most think of as the most severe, which is coning or foraminal herniation, as you can see down here on the cartoon at the bottom with the white curvy arrow. This is herniation of the cerebellar tonsils through the foramen magnum into the cervical spinal canal. And this presents as your perimoribund Cushing's triad, the respiratory and cardiovascular compression collapse due to compression of the medulla, and your obstructive hydrocephalus due to the compression of the fourth ventricle. Last little mental break, maybe most ridiculously, is the clinical diagnosis code for a burn, patient burn, due to water skis on fire. I really don't know who made up all these, but this is the other side of ICD-10 that hasn't been selected out. All right, so lastly, I'm going to talk about the TBI management approaches now that hopefully we have a little bit of a better understanding of the physiology behind neurocritical care and some of the herniation syndromes, in addition to what we might automatically expect. What do we do about it? So this is a busy but overview of brain injury, given the range of what can happen and why, even though we understand the underlying physiology, why it takes a very nuanced and sensitive approach. So the injury itself can be focal, diffuse, rotating, penetrating, or shearing. But we have both a primary and a secondary injury, as you can see here on the left. And then over at the top, you can see the time as it evolves in seconds to minutes, hours to day, weeks to months, longer. And then the systemic impact, or then the more focal neurolocal impact. So the primary injury often is cerebral ischemia, which then drives cell membrane failure, swelling, and lysis or necrosis. And then TBI is therefore then the mechanical disruption of parenchyma and the cerebrovasculature, which therefore then leads to ischemia. The secondary injury, which is most of this, is really the danger zone. It's a cascade of biochemical, cellular, and molecular events that are both endogenous and exogenous, whether it's hypotension or hypoxemia. We get ischemia, swelling and edema, inflammation, and then acute cellular dysfunction, which then over time leads to further issues with neuroplasticity, cell death, and apoptosis, and then long-term endocrine and neuroplasticity effects. The challenge to raise ICP kind of belies its application to a PowerPoint because it is so complex. Indeed, there are two prevailing kind of thoughts or approaches to how one manages your vitals and patient care in TBI. But this is the Rosner one, which really has termed the model the complex vasodilatory vasoconstriction cascade. And the issue, which you can kind of see here in this circle, which is kind of a self-fulfilling one if you go one way or you go the other way. So they're mirror images of each other, really. So I'll just talk about one. Cerebral perfusion pressure is decreased, which leads to vasodilatation. The vasodilatation will increase your cerebral blood volume, which then in return increases your ICP. As your ICP increases, this drives ischemia, which in itself also will then drive decreased cerebral perfusion pressure. So this is where the nuanced approach really kind of comes in, given the multifactorial physiologic effects of how you manage these patients. But thankfully, we have more clear guidelines on basic neurocritical care, first tier, and then second tier strategies. So TBI resuscitation, in terms of very broad strokes, ABCs in the standard way in your spinal precautions. You consider securing the airway if your GCS is low and they can't protect their airway. If you really need to optimally control your CO2 and arterial oxygen content, or you need to actually facilitate other procedures or studies such as CTs and agitated patients. You do it in order to treat hypotension, aiming for somewhere above the 5th percentile for age, and you can permit a degree of hypertension to prioritize your cerebral perfusion pressure, with the caveat as long as there's not uncontrolled bleeding or ongoing bleeding. And then, of course, it allows you to address your surgical issues. Whether you need an intracranial monitor if your GCS is too low, less than 8, or if it's dropping rapidly. Bear in mind, while we're talking about the brain, you also may have neurogenic shock in the cases of spinal cord injuries above T4. The reason being is that the sympathetic denervation of the heart occurs at the T1 to T4 level, and the vasculature will have its subsequent effect, which is obviously decreased inotropism, chronotropism, and arterial and venous dilatation. It can be very difficult to differentiate this syndrome from hypovolemia, but a lack of compensatory tachycardia is probably one of the key clinical signs. So baseline care for TBI. So appropriate analgesia and sedation, whether it's a benzo or opiate drip or, as needed PRN with some combination. Mechanical ventilation, aiming for standard variables, kind of normal everything. SATs, arterial oxygen content, your PaCO2, 4.5 to 5.5 kPas, and its equivalent in millimeters of mercury. Cerebral perfusion pressure targets. Again, these are largely, applied guidelines depending on the individual you have in front of you. And as all of the intensivists know on this call, it's often very individual dependent. We're really aiming for euvolemia and a normal CVP, not too low, not too high, as we learned in the cerebral autoregulation slide. Blood, we're aiming for a minimum hemoglobin of 7 or 70 milligrams per deciliter, and to treat the coagulopathy, both for the arterial oxygen carrying content and then also in the setting of trauma. Nutrition is critically important, and it needs to begin within the first 72 hours, and hypoglycemia aggressively avoided. With close glucose and avoid glucose in your maintenance IV fluids if you have a very strong stress response initially. Bear in mind, cerebral blood flow increases by 3 to 4% for each millimeter of mercury increase in PaCO2. So your responses to changes in PaCO occur rapidly, really within 30 seconds, so far quicker even than your oxygen SATs will pick up to SATs changes. Hyperventilation in these baseline settings are no longer recommended due to the risk of massive cerebral vasoconstriction and therefore poor perfusion. In order to decrease your cerebral venous pressure, head positioning is really important, as you can see with the graph here, with the patient positioned in different feet up, almost 10 degrees flat, 10 degrees, 20 degrees, and standing. As you can see there, the optimum position for your ICP is in that 30 to 45 degrees. Head placed midline, and of course practical things such as a C-spine collar, good fit, and loosen your ET ties. For your central venous line, just be mindful of your right IJ thrombus risk, as there's good utility, having good cardiac CVP readings, and to decrease your PEEP where feasible to allow better venous drainage. Osmotherapy to decrease cerebral edema, mannitol and hypertonic. There are differences. It's not one or the other. Mannitol obviously reduces your blood viscosity and improves your RBC rheology, which is the deformability, the plasticity of the red blood cell. This obviously therefore then improves your intracranial blood flow and decreases your intracerebral blood volume. Both 3% and mannitol increase your extracellular fluid osmolality and therefore draw fluid out of the parenchyma and shrinks your brain a little. But this is a very brief, or it's an effect that's not sustained because the neurons counteract and will generate idiogenic osmoles. So it's not an ongoing thing. And there's some thought that 3% may have some anti-inflammatory properties. Osmotherapy, so drilling down slightly, so you're hypertonic, as most of you know, it's a 3% bolus of anywhere from 2 to 5 mils per kilo over about 10 minutes, and you can also do an infusion to target a serum osmolality of 350 to up to kind of 360 milliosmoles per liter. This advantage does not cause massive diuresis and therefore hypovolemia in someone you might be trying to promote cerebral perfusion pressure or maintain CVP on. But obviously you can get a hyperchloremic metabolic acidosis due to electroneutrality shift and hypokalemia for the same reason, and it can mask DI. Mannitol, on the other hand, is a really effective and very rapid effect, but lasts only up to about kind of 6 hours. The cons is that due to the massive diuresis, it can cause hypotension and therefore hyponatremia. And if you already have a damaged blood-brain barrier in the setting of trauma, it can worsen your cerebral edema, or if your kidneys are already suffering, it can worsen your AKI or cause acute tubular necrosis. The core is decreasing your cerebral metabolic rate, which is your CMRO2. Sedation is really important, especially prior to anything noxious, central line, tube changes, anything that is going to spike your blood pressure. And of course, just to state, ketamine is safe to give in closed head injuries for these reasons. Paralysis is really important, really effective, even though it's somewhat unclear if it derives outcomes. But that's really effective in bad TBI when you have shivering or coughing with suctioning, again, with intervention. Treat seizures and prevent them as well, most commonly with Keppra. Whether it's if there's blood products that have been given, cortical contusion or penetrating injuries or seizures very early. And then, of course, normothermia. Treat fever, avoid it. And if they're starting to warm, use a cooling blanket. Paracetamol on its own is never sufficient, and there's always a slight caution with NSAIDs and bleeding risk. Last slide, the second tier therapies. This is, there's not a lot on these to do a deep dive because you're really into a very nuanced and individual managed setting where you've done all your basic neurocritical care, you've done your first tier therapies, and you're still trying to manage significantly raised ICP. So these are your options. You can do surgery as indicated if there's a mass lesion or or your neurosurgeon recommends a decompressive craniotomy. Barbiturate infusions in the setting that you have an active EEG and there's no direct medical contraindications. Potentially, if everything else, you're really grasping for straws, or you're at the bottom of the barrel, moderate hypothermia of mild to moderate 32, 34 degrees. If there is no contraindications such as coagulopathy or needing a lot of blood products. Hyperventilation, if you're increasing, but you really need advanced neuromonitoring for ischemia, and the only place it's mentioned in the guidelines is in the setting of active herniation, like a blown pupil, and you're trying to reverse that. And then lastly, higher levels of osmolar therapy. So whether you're putting on a 3% drip or infusion, or you're trying to target end sodium concentrations above 160 for the hypertonic infusion, or a serum osmolality of 360. But these are only to be done in specialized ICU level settings with neurocritical care capabilities. That is it for me. I've gone almost 2 minutes over. Apologies. This is the code for our talk, but I will hand over to Rory now, who will take in the time critical transfer.
Yeah, thanks, Peter, for comprehensive run through the pathophysiology, which makes it easy to understand why children might present in the way that they do, and also for the treatments we use. I think we are going to keep questions till the end of this joint session, so we'll maybe hand over then to Rory, and Rory, if you're happy to share, present, and then we'll see if any questions for the end, if that's okay.
Yep. Can you hear me okay?
Yeah, got you, yeah.
That's for starters. I'll try and get my screen shared now. So I'm sharing the wrong screen.
I can't see anything at the minute just yet, Rory. It did look like for a minute ago there it was about to share something. Yeah, give that a second. That might come up now. So I've got your PowerPoint slides, but it's in the it's not in the slideshow mode as such.
It should be coming up into full screen mode now, hopefully.
Got you. Perfect. Thank you.
Any better there?
Yeah, that's perfect. Thanks, Rory.
Okay, so thanks, Peter, for that run through. And thanks, Ben, for proving the technology works. So yeah, I'm Rory Sweeney. I'm a transport consultant in the Children's Hospital in Belfast. I'm just going to run through time critical transfers, and I suppose it's a term that gets bandied around a lot, but what we're coming off the back of a traumatic brain injury talk, so that's one kind of time critical transfer. But I just wanted to get a little bit of interaction, hopefully at the start, if this does indeed function, and try to get people to think about what sort of conditions are out there that do require time critical transfers. Obviously, we've talked about a big group from the last talk, but is there anything else that people know of? And Ben, if you're still around, is there anything else I need to do with this Slido?
It doesn't seem to be coming up, Rory. I've activated your Slido remotely, so if I'll shout out the answers, but they won't come up on the screen.
Oh, apologies. I did have the extension all set up and tested it the other day, and it seemed to be working fine.
No worries. So in terms of what's coming up here, we're getting block shunt, surgical emergency, cardiac, high ammonia, surgical abdomen, shunt blockage, stroke.
Yeah, and all sounds like good stuff. So sort of list of things that I've got as well. So yeah, I mean, the neurosurgical emergencies are the ones that we probably consider most. So traumatic brain injuries being one, and block shunt is another big one for our population. Surgical emergencies, absolutely. I suppose just to highlight around this as well, that not all time critical transfers are necessarily critical care in appearance. So something like testicular torsion presenting to an area where there's no surgical cover is time critical, but it might well not involve a critical care type of transfer. Cardiac ones, certainly your sort of transposition of great arteries with intact septums or obstructed TAPVDs. High ammonia is absolutely, and again, they look maybe slightly different in terms of what you're thinking about in terms of your transfer. And the other thing are kind of, it's always life or limb saving, isn't it? That's talked about in sight as well. So things like an acute compartment syndrome or a vascular injury that might need to move. And again, those might look different from a kind of neurosurgical emergency in terms of the patient that you've got in front of you. So with all transfers, this is the aim. The aim is that the right patient's taken at the right time by the right people to the right place, using the right form of transport, and receives the right care throughout. So throughout this, that's a sort of framework to be applied. It's not just that the idea of a scoop and run and just throwing them in with anybody who's there is not what we're aiming for with any kind of transfer, and in particular an unstable critical care transfer. So we need to consider who the patient is, why they're going and what they're going for, exactly where they're going to. So that needs to be clarified beforehand. Exactly how much time you've got. I'll give a sort of guide of what a time critical transfer should be, but there should be a little bit of consideration if some things you may be able to sort out a little bit more and other things you need to go sooner. Exactly how you're going to get there, and a little bit around the who. So in general, when we're talking about time critical transfers, it's the responsibility of the local team who need to transfer them. But occasionally, due to proximity or due to other issues around actually access to a vehicle, it may be that a transport team is the faster option to transport some of these patients, but we'll talk about that as we get through. So the objective with these transfers is that it should be a swift and safe transfer, and primarily you're focusing on 3 key areas that need to be sorted out to aim to depart so once a time critical transfer has been stated by a receiving team, you should be able to depart your unit within 60 minutes. And you've got these 3 areas: your patient, your equipment, and all of the communication that all need to be happening at the same time, in order that you're able to get everything sorted within 60 minutes to be able to leave. I'm just going to go through each of these areas in turn then. So obviously the patient, again, focusing more on the kind of critical patient who arrives in, so neurological or surgical emergency. You need to take a bit of time to stabilize your patient to make sure that the transfer can go smoothly. However, it's a balance. Do all of the things that will allow the transfer to happen, but don't dwell or don't delay for procedures which are not going to be necessary to facilitate a safe transfer. So things that are often talked about are delaying for central access for somebody who doesn't need it, or arterial access. Can you just insert an IO if something needs to be given via a central route, and then that will cut down your time on the ground in your DGH before you move? Can you get away with non-invasive blood pressure monitoring? You know, are you on something that requires you to have arterial invasive blood pressure monitoring? And having a systematic approach to this. So one part of your team should be focused on getting the patient stabilized, and it's probably useful if that part of the team is also the person who's going to be moving the patient, so that they get a feel for how they're going to be on transfer. The checklist that I've got here is borrowed from the Leicester team and is available online. There are many of the transport teams that have a sort of time critical checklist to go through, broken up into the different components, but it's worth having something that you can go through systematically, because in all of these fraught situations when you're rapidly assembling a team to do something that they don't usually do, it can be easy for things to get missed along the way. So ensuring you've got a systematic approach, your ABCDE, to making sure that your child is stabilized. Next up is thinking about gathering up your equipment. So in most DGHs, there will be some kind of a critical care transport trolley, certainly within the DGHs in Northern Ireland. And sometimes they're very well maintained and very well stocked, and maybe even with too much stuff, and sometimes maybe slightly less so. So what you need to have whenever you're setting off is a trolley and a harness that you can secure the size of your child on. If it is a patient who is ventilated, you need to have an adequate transport ventilator, a supply of oxygen, making sure that you've got an anesthetic bag and circuit, as well as an ambu bag if you have any failure in your oxygen supply, a way to adequately monitor your patient throughout the transfer, with all of the bits of monitoring that you would need to have for this type of patient. Making sure that you've got some infusion pumps which are secured on your trolley. Transport bags, lots of places, especially in DGHs, will have transport bags that are set up for adult transfers. So depending on your size of patient, a lot of this stuff might be appropriate. Or if it's a very small patient, a lot of that might be completely inappropriate, and consider whether, if there's a neonatal unit, do they have a transport bag or a transport trolley that you might be able to use if your patient is, say, less than 5 kilos. And if you're not exactly sure what is in the transport bag that you've got available, always consider taking with you in a sort of an emergency airway pouch that you've put together yourself, knowing that you've got exactly the right tube sizes that you need, the right blades, suction catheters, or pharyngeal airways, all of the things you'll need if you happen to get yourself into an airway emergency en route. And then it's consideration of gathering up all of the things that you might need for whatever might go wrong, condition dependent. So think of the two main things that you're concerned about happening on the way, and make sure that you're prepared for exactly those emergencies. Making up all emergency fluids and drugs before you go. If you think that you might need an inotrope infusion en route, make it up, have it run through, and possibly even attached before you go, rather than setting off without it and then finding that you're having to make something up in the back of a vehicle. The transport, the ambulance environment is not the place to easily make up emergency drugs, and you've got a very limited team. So trying to do as much as you can before you set off to make sure that you're ready, but equally don't be delaying for unnecessary things. So it's again striking that fine balance. The important thing about your trolley is you don't want to just be meeting your trolley for the first time whenever you're setting off to do a transfer like this. So within your hospital, within your department, do you know where your trolley is? Do you know what's on it? Do you know how to use all of the things that are on it? Do you know how to set up the ventilator circuit, for example, and run the pre-op checks? Lots of places still have oxylogs attached to their transport trolleys, but also have Hamilton ventilators available in some areas, and the bracket for connecting the two ventilators is the same, but Hamilton ventilators would be our recommended ventilator for particularly ventilating patients under 10 kilos. The oxylog really struggles, even with the smaller circuit, to ventilate well at the smaller end of the scale. So it is possible to remove the oxylog and put on the Hamilton. Do you know how to do it? Does somebody know how to set the Hamilton up? Do you know who maintains it? So is there somebody regularly checking these? Is it somebody who's a critical care scientist within the ICU? Is it somebody in the emergency department going through it? Is it somebody from theatres? And the transport bags, is there a checklist for things that are in it? Do you know within the hospital you're working in that somebody regularly goes through the transport bags to check that it's been restocked and that the stuff that's in it hasn't all gone out of date because nobody's actually moved it or used it in a couple of years? And again, as with checklists, trying to have something in front of you to try and offload some of the bandwidth for whenever you're in an emergency situation. So there are resus drug calculators. So we at NISTAR have one available on our website, and I'm sure there are equivalents amongst the other transport teams, and sort of a spreadsheet where you can put in the child's weight and get all of your emergency drugs, and likewise through the Paediatric Emergencies apps. The Paediatric Emergencies itself has condition-specific drug dose calculators, and if you look at the PICU calculator, it will give you all of the sort of emergency drugs and infusions that you would need for a child. Once you plug in their weight, it'll tell you how to make them up and what rates they should be run at. And again, if it's something that you're not familiar with doing and you're in an unfamiliar environment, it's much easier to try and offload a little bit of that bandwidth by having something in front of you. So then the next big thing is your communication. So for something like this, there's a lot of calls that often need to be made within a very short space of time, and designating somebody from the team to go off and perform all of the communication can be very useful. But obviously then that means that that often isn't the person who's directly looking after the patient. So there's a little bit of difficulty around that. Some phone calls to be made at your referring hospital. So in neurosurgical emergencies, the advice is that a CT should be performed in less than 30 minutes. So somebody arrives in, you're suspicious of a raised intracrinial pressure from a traumatic brain injury or from a blocked shunt. Some phone calls might need to be made very rapidly in your department in order to get your CT performed. Then phone calls to neurosurgery and anesthetics, all within a very short space of time. Once a time critical call has been declared, then there are calls to potentially your PICU that you're trying to transfer to your transport team, to theatres, and then last but not least, a call to ambulance control. And it can be very difficult, obviously, to get all of these things coordinated, and for all of the people to get all of the right information in a streamlined sort of manner. So even though this is time critical and a lot of the calls, the transfer itself will have to be done by the local team, the transport teams can still offer an awful lot of help. So most of the transport teams around the UK will now have a single point of contact to phone into, which will be able to offer clinical advice. We'll have some kind of conference calling facility to bring in the specialist teams, to bring in theatres, anaesthetics, PICU all in together in one call, or if there's decisions to be made around which intensive care they need to go to, often that can be made through one phone call through the intensive care team who can coordinate these things rather than having to phone different places to ask for beds. And then leaving it up to them to coordinate things at the receiving centre. So though you might be through to the PICU, making sure that getting a bit of the assistance from the transport team to offload some of that organisation with discussing with theatres, making sure that theatres are cleared and ready, or if it's a metabolic emergency and you're coming to intensive care and for filtration, to make sure that all those discussions have been had and everybody knows when the patient's going to arrive and we're all set up for them when they come in the door. In terms of calling for ambulances, again, not necessarily something that people will have had to do an awful lot, depending on the unit that you're working in. This was the more recent guidance from the Northern Ireland Ambulance Service, trying to improve its response times for interfacility transfers. So when it's an emergency and you dial 999, in general, you just get through to a call handling service, and they have a series of questions to go through, just like if you're calling from the community. Is your patient breathing and are they responsive? Which can be obviously slightly confusing when they're ventilated. So you do have to state that this is a time critical pediatric transfer, and hopefully there's a better understanding now when you phone through to ambulance control of what that means. But if there's any difficulty whenever you're speaking to the person, the initial person at the call handling desk, there is always a paramedic available to speak to within any ambulance control centre. And if you need to get sort of more of a clinical discussion to state why this is such an urgent transfer, you can ask to speak to the duty paramedic in order that you can definitely make sure that your call is escalated. As you can see there, the level 1 interfacility transfers, the response time should be 8 minutes after you make the call. However, we've had a lot of difficulty in Northern Ireland, and I'm sure that these problems aren't isolated with us, with ambulances getting a bit stuck trying to offload in emergency departments, and our response times have often been a bit worse than that. So very important to document the time that the call was made. Very important to phone early. So as soon as a time critical transfer has been stated, that's the time to phone for ambulance dispatch to make sure that somebody's there waiting rather than waiting until you're ready to go. And the other important thing is they should be able to clarify an estimated response time with you at the time of the initial call. And if it sounds like there's going to be a significant delay, maybe worth phoning back to your transport team to say, actually, we're not going to get a frontline vehicle and you might be here quicker. And the other person who it's worth talking to in these situations is, particularly during the daytime, there's a hospital ambulance liaison officer, or a HALO, who usually runs out of the emergency department, and they will have a better oversight of what ambulance waits are outside, and sometimes they can free up frontline ambulances by getting somebody moved into the emergency department to free up a vehicle for you to be able to go on your transfer. Very important whenever you're on that call, just to clarify exactly where they're collecting from. So if you're in the emergency department, but the plan is to go to CT, go to theatre to get them on the trolley, it's important that you clarify exactly where they're coming to and exactly where you're going to as well, so that they know which way around they have to go to get into places, particularly out of hours when different gates can be closed. The other part of this is if you need to have a specific crew, this is the time to ask for it. So not all paramedic crews are equal. So you have emergency technicians and paramedics both, and sometimes you can have a 2-person technician crew or 2-person paramedic crew, or a combination of those. So paramedics can do a bit more in terms of an emergency, so they can give more drugs and give fluids. And technicians are a bit more limited in what they're able to perform. So even if you don't need somebody in particular, it's always worth clarifying when your crew arrives exactly who they are and what they can do, so that if an emergency should occur whenever you're en route, that you know what they're able to help with and what they're not able to help with. For example, if you're moving and you have a cardiac kid or somebody who's likely to have an arrhythmia, you're likely to be using the defibrillator in the back of the ambulance, because you won't have most trolleys don't have a defibrillator on them. So it's worth clarifying with the crew about whether they're happy to use it, which they will be, but just to kind of have those conversations with them when they arrive to keep everybody on the same page. So then once you've sort of got all those things sorted, we're talking about trying to get out of your department and get on the road. So when assembling your team, there is a decision to be made around who goes. A lot of this will be guided by who's available, but a big question is about who's qualified. And just again, as I said earlier on, we've moved away from the days of kind of the most junior member of staff, the most dispensable person on shift, and being tossed in the back of an ambulance with somebody who's critically unwell in order to rush them down the road. So it should be the most qualified person. That then does beg the question of who then is going to backfill. So if you're taking away your senior anaesthetist and pediatrician, for example, is there somebody who can provide hospital cover? And that needs to be sorted as part of the process. And then what time is it? So if shift change is happening in 5 minutes, is it better to wait 5 minutes for fresh people to come in? And that maybe depends on the length of the journey and also the capabilities of who's coming on and who will be going off shift. So there are considerations to be made around that. This is a version of the STOP tool, so a safe transfer of pediatric patients tool, just to sort of highlight the recommendations for a time critical level 1 to 3 transfer. So what's recommended is usually an anaesthetist, because we're assuming that they're gonna need ventilatory support, a nurse, and that person who is transferring them, anaesthetist or otherwise, needs a senior airway and pediatric resuscitation competent doctor. And then your appropriately trained ambulance crew should be the people transferring. Also just states on this about kind of less critical care, but also time critical transfer. So for example, a testicular torsion, if agreed with the receiving team and that it doesn't delay treatment and the parents have been updated, it could be appropriate that the parents might be the quickest people to transfer. But obviously, ideally with all of these, you'll want to go in a frontline vehicle. So just as you're getting ready to set off, a few other important considerations. Do you know exactly where you're going? So you might be going to a hospital that you're unfamiliar with at a difficult time of day. Oftentimes the theatres and, for example, the emergency department are quite a distance away, and the best entrance for you to get into might not be where the ambulance crew usually go to. So if you can give them exact details of where you need to go, you might get better access to where you need to get to. Do you know how you're getting in? So again, doors can be locked, gates can be down, barriers can be down. Do you have somebody who you can contact in the receiving unit to make sure, if you're struggling to get in, to make sure that they know that you're there and that you can get in? And do you know who to call in an emergency? So if you're setting off, is it the transport consultant that you're phoning? Is it somebody in PICU that you need to get advice from? Do you have a direct line to contact them through? And whenever you're setting off, then you updated the team that are receiving. So do they know running some infusions and you think you're going to run out of them, or basically run out of them by the time you arrive? Make sure that they know what you've got. In terms of infusions, you should always be traveling with kind of double what you think you need, just in case there are any delays or ambulance failures on the way. But obviously, unforeseen circumstances can mean that you'll be in slightly short supply, and just keeping an open line of communication with the receiving team or the transport team who are aware of the patient is really important to update them on your way. So then lastly, I suppose we'll talk about this issue around using lights and sirens. So for these patients, obviously we're trying to get them down the road quickly, and the temptation is that because it's time critical, you turn on your lights and sirens and go as fast as you possibly can, in order to get them there as quickly as you possibly can. However, there's a considerable amount of evidence that shows that using lights and sirens doesn't really save a huge amount of time. Sort of the maximum time saved was about 6 minutes in most of the studies that have been done, and that was kind of in rural areas, versus usually about 2 to 2.5 minutes within urban areas. And your risks of accidents increases massively, so about a 5-fold increased risk of accidents. But more importantly, these are patients who are critically unstable. We're talking about traumatic brain injuries before, and the impact of raised intracranial pressure on your cerebral perfusion pressure, and the physiological impact of traveling with lights and sirens at high speed can be huge on your more unstable patients. So if you've got somebody with a traumatic brain injury and you're traveling along as fast as you can, and then you suddenly have to brake, that will cause a massive surge in their intracranial pressure. And equally then, as you accelerate rapidly to take off, that will cause an episode of hypotension and hypoperfusion, both of which will have potentially drastic impacts, especially if you're doing that multiple times during a journey. So the recommendation for lights and sirens now is that whilst they can be used, really they should only be used for kind of progressive movement through traffic. So it's to keep you moving at a steady pace, but ambulances shouldn't be aggressively driving. And it's important to clarify that with the paramedics. So they're going to be turning up with a view that this is, life or death. They're going to go as fast as they can, and they usually will ask about the use of lights and sirens. So yes, to go on blue lights, but really only to go smoothly on blue lights, and make sure that they're aware that you don't want them to go as fast as possible, because it's potentially could have very detrimental effects to your patient. So in summary then, we're aiming for swift but safe transfers, and that is all of your organization before you need to leave then. So you might need to split your team up to make somebody's sorting out your patient, somebody's away gathering up all the equipment, getting everything sorted so that there's no delays once your patient is stable, and that somebody's taking on ownership of all of the communication that needs to be happening, and that includes an early call to ambulance dispatch to make sure that they are standing at the end of your bed waiting, and that there's no delays to your departure. So once everybody's ready, you should be out the door. That's not the time to be phoning your ambulance. And having a couple of slightly irate paramedics tapping their watch at the bottom of the bed is a good way to get everybody sorted to go. Transport services are a useful tool to help you coordinate. So it is important to, again, coordinate with them nice and early. And often you can offload a little bit of the communication to sort out some of the things at the receiving side, and a really useful resource for clinical advice as well. And again, to reiterate, steady journey is what you're looking for, rather than going like the clappers, because it can be very harmful to your patient. All right, so I think that was hopefully about time.
Yeah, thanks very much, Rory, and thanks again to Peter for the first part of that talk as well. Time for a couple of questions just before lunch. So first one is really with regards to sort of anti-seizure treatment and trauma. So there's a question around the theory of anti-seizure treatment and trauma, chance to try and decrease the chance of developing epilepsy, and therefore phenytoin can be used. But a lot of patients with traumatic brain injury are ventilated and often sedated with benzodiazepines. And is there therefore a role for phenytoin on top of that on those patients who are on benzodiazepine infusions?
I'll go first, but I'll probably pull some of my intensivist colleagues. Phenytoin's not usually the first one to go for because of the risk of hypotension, particularly in a very severe TBI. Usually Keppra or levetiracetam is kind of the first line now for neuroprotection because it's so cardiovascularly neutral. Because while you might be on a bit of a benzo infusion, for sedation and reducing your metabolic rate, and to keep the patient under. You don't want to go too high because benzos can also lower your MAP. So you're going to tolerate that within reason, because in the most severe TBI cases, your CPP and your perfusion is going to be one of your top priorities.
I think I'd have to
Sorry, I sort of
agree with what Peter's saying there. I suppose the question is, do you need anything on top of the midazolam? I think is what the question was about, whether it's phenytoin available locally, maybe Keppra mightn't be immediately available. And I think you probably do. Phenytoin, there's some risks to. Keppra, there's almost no downside to giving. And the big advantage is you're going to prevent seizures. And if this kid seizes, it brings a whole load of blood into the head. And as Peter's showing you, you're often in that steep part of the curve where any tiny increase of blood is going to massively increase your intracranial pressure. But it's not going to be a tiny increase of blood if the brain starts seizing. It's going to be a massive increase, and your pressure is going to go up massively. So that's the reason we would rather prevent seizures than treat it. And adding it on top of the midazolam is definitely a good idea.
Great, thank you. And I know, Gyula, you had a question that you put into sort of the faculty chat around the use of hard spinal collars. Maybe, I don't know if you want to ask that, maybe?
Yeah, actually, it was just, I was really curious about your practice, because as far as I know, these so-called rigid cervical collars like stiff neck and so on were really a routine practice. And actually, I remember several exams, people being kicked out because they forgot to put on a cervical collar in a for example, in a pre-hospital trauma situation. But as I learned, they are not really routinely used and actually cause more harm than good these days. And I just wondered about what's your practice about them is.
There's nothing good to be gained from traumatic brain injury by putting a tourniquet around someone's neck, is what I would say about the matter. And especially if we're doing children, and they can be combative if they're awake, it's counterproductive. You need a visual reminder not to let that C-spine flop around. So so blocks is basically what does it, or a note. So you need to address human factors when we forget that the neck can be compromised. But actually, tourniqueting the neck itself is counterproductive. It doesn't improve anything. It causes more pooling if there's real trauma up there, so it makes everything worse. I don't use it.
I agree. If you think of why we're using a C-spine collar, is to try and prevent a secondary C-spine injury. Nobody really knows the number needed to treat in order to do that, and it's estimated that's probably somewhere in the hundreds, if not low thousands. So the benefits are unclear, the risks are well known. The problem with C-spine collars in children are multifactorial. One of them is that the collars come in different sizes, and I've certainly seen patients with ill-fitting collars that were definitely causing a tourniquet. So it's for the ones who are unconscious, they can put on wrong. With the ones who are conscious, they will actively fight against it. It can act as a fulcrum, and you can find that they'll get more movement in their spine than if they don't have it. The only possible benefit is in the kids who have been intubated and are paralyzed, and that if teams are used to the collar being in place as a visual reminder that C-spine is not cleared. That's the only potential benefit that I can see for it. From our practice, if they come with it on, we try and take it off. Is what we do.
Okay, thanks very much, guys. I think we're gonna hold it there and make a pause for lunch. We're about 15 minutes over, but we can take a slightly shorter lunch. So plan is to meet again at 2 o'clock when we'll have a talk from Dr. Stephen Mullen on managing cardiac arrest. And I hope you've enjoyed this morning. Thanks again to all of our speakers. Do take a bit of time to get some food and enjoy it, and we'll see you then. Good afternoon, everyone, and welcome back to Paediatric Emergencies 2024. Hopefully, you've had a chance to stretch your legs, get some food, and are ready to go again for our afternoon session. Some great talks coming up. We have a talk on post resuscitative care following cardiac arrest with Dr. DGH. But without
all right,
So
like
guys, we're gonna. We've got Stephen Mullen here for post cardiac arrest resuscitation, and then we're going to have Tom Waterfield later on and Costas Kanaris on sepsis before we head to Shilpa Shah for questions from the DGH. But this is Dr. Stephen Mullen from Paediatric Emergency Medicine.
Same question that everybody else starts with. Can people see my slides?
Yeah.
Perfect. So thanks for that great introduction and welcome to the afternoon session. So the topic of this course focuses on post-resuscitation care. So we're going to look at those who've had a cardiac arrest and you managed to get ROS back. So the plan is to cover some of the core concepts, and really after the core concepts, we'll focus on two cases and use those cases to reinforce the learning, but also to bring in some different new ideas that might differ between medical cardiac arrest post-management and from the pediatric trauma patient. And at the end, we'll hopefully leave between 5 and 10 minutes for a panel discussion. Now, as mentioned in previous talks, it's impossible to cover everything in a 20-minute period. So if you have a question that I haven't answered, or there's a topic you want a little bit more information on, please stick it into the chat function and we will happily discuss it in greater detail. So I am an emergency physician, so my viewpoint is different from the ICU colleagues. So Costas last year done an excellent talk on post-resuscitative care when the patient arrives into the PICU environment. There's a huge amount of information there in terms of pharmacodynamics, pharmacokinetics, and generally he's an excellent public speaker. So to augment this talk, I'd highly recommend you reviewing some of the information that's shared here. Probably important to start off that APLS and most of our resuscitation guidelines end almost with ROSC as the endpoint. And that's not necessarily the case. It's not a time for which we all lean over the table, high-five each other and congratulate each other for doing an amazing resuscitation. That time must come later on. You must recognize that patient in front of you will still be the sickest patient you see that day, that week, that month, and potentially that year. And if you get too carried away with the fact that you got a rhythm and a pulse back, you're going to let time lapse, which is key in order to try and improve survival for these patients. So in a way, the way I think of it, that this is almost a second resuscitation. I park everything that I've done before and I start focusing my team and my leadership skills for this post-resuscitation care. And as part of the team, as the team leader, I want people to know what my aims are. And we must recognize that just as we vary from team members in terms of seniority and experience, the outcomes will be different. And the junior members of the team may only be aiming for being involved in a pediatric resuscitation or getting the patient stabilized to be ready for transfer. But as the senior members of the team with a little bit more experience, our aim is to try and get the patient to survive with good neurological outcome. And everything we do should be for that aim. And the Resus Council says this really nicely. So we want to return the patient to a state of normal cerebral function to establish and maintain a stable cardiac rhythm and normal hemodynamic function. So essentially look after the head, the heart, and then the rest of the body. And although it's not meant to be addressed in that area, I think if you followed that direction of travel, you probably won't go too far wrong. Recognize that our role is one of a longer part of the chain of survival. And this is a really nice graph that comes from the American Heart Foundation. But what we do in the emergency medicine and what we do when we send them to the PIC unit is part of the rehabilitation process afterwards. And we are not able to do anything about those cases if there's not good pre-hospital care, either from the pre-hospital medical team or from bystanders initiating CPR and recognizing that patient has collapsed. There's a variety of different studies you can look at, and I think it's worthwhile recognizing that cardiac arrest is not what you see in the movies where you get 100% survival after putting a few pads on and doing some chest compressions. The outcomes are much worse than this. So for pediatric cardiac arrest, we're expecting about 20% to get ROSC. And this varies depending on the study, but there's a really nice one published in 2016 from North American data, which quotes around about 20% figure is what you'd expect. Of all the ones who arrest, we get about 10% discharge, and 1 or 2% will have no neurological insult, which is slightly different than good neurological function because that varies, but 1 to 2% of them won't have this insult. And this really hasn't changed over the last 10 years. really nice paper in February 2024 will make us kind of change what we're thinking about this. So this is a Scandinavian paper from Sweden, which looked over a 30-year time period at their survival rates for the under 30s. So we take you to the middle graph. I want you to focus on that blue line where you can see it peaks at 32%. So this is 32% survival at 30 days after cardiac arrest in the 1 to 5 year olds. And this is a massive increase from single figures. And this is really replicated through lots of different age ranges. The next graph is what the rationale that they're showing for this. So again, focus on the blue line. What they're able to say, if the graph goes back a little bit, that their mean time to initiate in CPR was 14 minutes, and this is decreased to 2 minutes, which is absolutely phenomenal if you think of that time difference. So from a child collapsing to be recognized in cardiac arrest to a bystander starting CPR, they've managed to get 12 minutes off that time. UK data would say that about 70% of all cardiac arrest, somebody attempts to some form of resuscitation, and about less than 20% will get a defib. And they really praise a huge educational drive throughout their entire society for promoting this. And I think if we're looking at how we can improve the survival rates for these children, then this data really is fantastic. So the key aims from my point of view when I'm leading resuscitation is that I want to stabilize, optimize, and package that patient. So stabilize and optimize means that I'm thinking that individual patient. I want them having to be stable as possible, to have the best chance of survival. And then packaging is for two real reasons. The first one being that I want that patient ready to move so that they can get to definitive care and management. The secondary reason is that in my emergency department, I can have up to 60 or 70 kids waiting to be seen or lying in some form of illness. A cardiac arrest has the ability to suck in a huge amount of the resources in my department, and I need to start to redeploy them as quickly as possible. So my goal is to have the patient packaged and ready to go when the resuscitation or when the transport team arrives, so that we can minimize the time for them to move on to definitive care. I'm also thinking about my staff, and for simple things about breaking at all times, I have to think about the family and parents, if they've been involved in resuscitation, if they've been in the room, how to support them, and simple things. If the ambulance cannot take them to the tertiary centre they're going for ongoing care, how am I going to organise transport for them? If we look at post-cardiac arrest management advice, it falls into 4 key areas. So post-cardiac arrest brain injury, myocardial dysfunction, systemic ischemia and perfusion, and persistent precipitating pathophysiology. In really simple terms, because again in ED I like things to be kept as simple as possible: head, heart, body, and stopping the patient going back into an arrhythmia or arresting again. So post-cardiac brain injury. So for any that were children of the 90s, like most of the people are in this group, there was an excellent band called the New Radicals, and they had a tune that was "You Only Get What You Give." And the tenuous link to this is that if we're aiming for 100% oxygen, so if we give too much oxygen, essentially we get excessive free radical formation, which is a bad thing. The brain has had a period of underperfusion and starvation, and even if you have good quality CPR, cerebral blood flow will be 50% of what the body can normally generate. So there's cell death, there's accumulation of calcium, you've got a huge amount of release of inflammatory cascade, and with the excess free radical formation, you get neuronal brain damage and death, and this process can last up to potentially days, if not weeks, after that arrest. The longer the downtime, the worse the outcome will be. And in order to improve morbidity and mortality, this is something that we should be focusing on. Adult models will support excessive free radical formation when we aim for high oxygen levels, and there's very few pediatric studies, but one observational one, which would note that we're aiming for 100% as opposed to mid-90s, and there was worse outcomes. So the way in which we accommodate this is aiming for oxygen levels between 94 and 98%, and I will be interested in discussion at the end of this, because I think some of my colleagues will aim for lower levels in PICU. From my point of view, when I'm running resuscitation and somebody has literally got a rhythm back and are still incredibly unwell, I want to aim for my lower oxygen levels. But I'll be happy to hear other people's opinion on this. As mentioned in the traumatic brain injury, CO2 has to be maintained within normal levels, as an increase or decrease will change my cerebral blood flow, either increasing the pressure in the brain or decreasing oxygenation in already hypoxic tissue. So measure these, have a look at them, and see how you're going. Now, this stunning picture of a myocardium is to lead us on to myocardial stunning, which I know we've touched about a little bit. But for a second, think about what has happened to this heart during the arrest. So whether it's shockable or non-shockable, that heart has went through a period of sustained pressure. It's just lay there either doing nothing, or it's ended up in a terminal arrhythmia, resulting in decreased perfusion, hypoxia, and tissue damage. On top of this, you're going to have somebody that's either 80 or 100, 120 kilos, putting a huge amount of force through that heart, causing damage to it. And if it is shockable, we're sticking pads on and delivering a huge amount of electricity. So that heart will be stunned after everything that it's been through. If we look at some of the data, we'll expect to see this in between 50 and 80% of patients, and it can peak around about 8 hours after the injury, but can present straight away and can last that for 2 to 3 days. For a lot of these patients afterwards, we'll expect them to be hypotensive, and this is due to systemic vasoconstriction, as well as just having a huge amount of inflammatory cascade that's still going around the body. So we need to think about the heart, and we really want to avoid hypotension. And if you look at the therapeutic cooling trial, post-cardiac arrest, they would identify about 25% of the population will end up having low blood pressure in the first hour, associated with poor outcomes, and less than half of these got any vasoactive agents in place. Part of us is probably concerned of the fact that the heart has went through a huge period of instability. We don't want to overflow it, and we don't want to overstimulate it. But as Chris talked about rightly, that heart is at high risk of rearrest, and we need to put something in place. So avoid hypotension, know the blood pressure parameters, and certainly don't be accepting anything less than the 5th, and you're probably aiming closer towards the 50th for these. If you need to use fluid and vasoactive agents, do so, but use the minimum amount possible in order to get your blood pressure to where you want it to be. So systemic ischemia and reperfusion. And the reason I put the sepsis 6 up here is that the cascade or the pathophysiology is very, very similar. So we've got tissues that have been hypoxic, who have got no blood flow, and they suddenly got these massive increase in inflammatory cascade. You think of a huge amount of adrenaline going on your body, cortisol, you've got instability in terms of your glucose. So a lot of these kids will have high glucose afterwards. You will get cardiac dysfunction as a consequence of all these, which will make your hypotension a lot worse. And you've got activation and inhibition of your coagulation pathway, which may put these patients into DIC and increased risk of clotting or bleeding. And things that we need to think about is for these children is what temperature we are aiming for. So how are we managing these kids? And this has been talked about throughout the day. I've talked about the dangers of hyperthermia. If you increase the temperature even by 1 degree, you're massively increasing the metabolic requirements for that tissue. The tissue is already on the verge of viability. To do so will result in an increase in necrosis. So stop your temperature rising and actively cool. We would also say avoid hypothermia, and this is probably the best trial, which is New England Journal of Medicine, published in 2015, which showed there was no real benefit in therapeutic hypothermia in the pediatric range, which is different to what we think for neonates and again some adult studies. We would probably accept the glucose being slightly higher than normal, as we're aware of the dangers of trying to give insulin, causing hypoglycemia, and the impact that can have on an already starved brain and body, essentially. In terms of persistent precipitating pathophysiology, from my point of view, I want to try and identify what the etiology, so what made this patient arrest. And if I know that, I might be able to put some parameters in place in order to reduce the chance of that happening again. So I'm aware we've only got a few minutes left, so we're going to use 2 cases to really discuss about what we've talked about so far and put it into a little bit of practice. So 14-year-old collapse of football, shockable rhythm, and you've got Ross back after the 4th shock. So as mentioned before, our pathway for this patient is not just limited to the ED or ICU, but if they survive, it's a long process. And the median early intervention and intermediate will usually be done between ED and ICU. And the focus initially for that is to try and limit that ongoing injury and support the organs. And it's really only after about 72 hours we can start to prognosticate and think about rehabilitation and ensuring those services are in place for our paediatric patients. Underpinning all this is this preventing recurrence theme that sets the whole way through. So again, to reinforce this, I'm thinking about stabilizing, optimizing and packaging these patients. I'm thinking about the head, the heart, the general system, and also trying to decrease the chance of them go back into an arrhythmia. So I'm going to give you a few seconds. I just want you to really think about how you would prioritize these interventions. And I do strongly believe in an ABC approach, as it helps the team focus on where they're going and helps me remember what I need to do. So in terms of airway, while you're waiting for the team to arrive, you're thinking about securing it, making sure position is in the correct place, and if you haven't got a definitive airway, to put it in place. We've mentioned the importance of looking at the saturations in your CO2, and you'll have constant discussions with ICU and the transport team. You don't want to limit that transport, but if they're adamant they want an arterial line, if you can get that in place before the transport teams arrive, it will speed up the transfer and extradition of that patient. You want to be careful with your rate and the volume that you're using to resuscitate these patients, particularly if you haven't a huge amount of experience in these areas. Anecdotally, people will have a huge amount of adrenaline. They will start bagging at a higher rate and volume than required. This will result in distension of your lungs, decrease your vascular return, and decrease your cardiac output to the detriment of the patient. So think about putting them on a ventilator early. We mentioned about looking after our perfusion, our blood pressure, our pulse. Vasoactive agents, as Chris mentioned, have early, and once you have successfully resuscitated them, you're redirecting your staff to try and get those agents ready early, and we would probably use adrenaline in our units, and ensuring you get decent vascular and arterial access. From a D point of view, I'm thinking there's any neurology, so as well as the child arresting primarily probably from some sort of cardiac dysrhythmia, am I having any signs maybe think that there was concurrent head injury with promoted that arrhythmia, or trying to prognosticate things on blood sugar, and making sure it's not low, but accepting that's a little bit high, and keeping an eye on that temperature and targeting it as necessary. Multitasking is something that we do particularly well in the ED, which I'm proud to say. So communication is a key part of this. So as well as communicating with your team, you're also communicating with all your staff in your department, and you're communicating with parents, you're updating the transport team, and you're updating the unit that's receiving them. And that communication should go both ways, as well as giving them information. You're looking at information to come back to you as what you may need to do to that case. And use that time while you're waiting for the team to get things in place. So think about imaging, blood work. Do you require any other medications? And definitely getting things like an ECG. There's very little medication you might think for these patients, but we know the post-cardiac arrest patients, up to about 30% of them will have a seizure. So if you've paralyzed them, if you don't have CFM on, you might not know what's happening. In that case, you'd have a low threshold for giving probably Keppra, as mentioned, but that will be done in discussion with your transport team and accepting units. And the key to me from ED is that my department doesn't allow me to focus on this one patient for an infinite amount of time. I have a sea full of essentially undifferentiated kids who can be in different periods of distress. As mentioned, all my resources are pulled into resus, so I need to restart to redeploy my staff to start look after all those other cases, because those category 4 patients can quickly become a category 2 or 1 patient if they're left for a prolonged period of time. Think about your staff. So a huge amount of staff in the NHS is experiencing burnout, and events like these in overstretching on the resource departments just can make things worse. So look after them, make sure they're getting breaks, they've time to clear their head before they get back to work. So case 2, we'll run through reasonably quickly. We're going to talk about a 10-year-old male road traffic accident who had an arrest, downtime for about 10 minutes. Causes of trauma, we change our algorithm slightly, we give him some blood products, we've done bilateral thoracostomies, and we have got Ross back. So I want you to think initially about how does your post-resuscitative care for a trauma patient differ from your medical one, or is there a difference? I would argue there's not a huge amount of evidence out there, but from my point of view, there isn't really, in that we're still going for these same parameters, thinking about the head, the heart, the body, and trying to prevent them re-arresting. And how we approach this differs because our resuscitation algorithm differs, and the reason why they've arrested will differ, but the same ABCD principles still are at play. About 40% of traumatic cardiac arrests are a consequence of hypovolemia due to bleeding. So think about where that bleeding may have come from. If you've got an obvious bleeding source, try and reduce that either by putting some pressure on it, and by using tourniquets, pressure dressings, or clotting. From an airway, thinking about C-spine injuries, and we talked about collars and their use, blocks and tapes, in my point of view, are an excellent means to do this. But you need to consider this early. As you've got a C-spine injury that's not been addressed, your consequences can be dire. As well as doing our normal breathing activities, if this patient responded to bilateral thoracostomies, which is essentially putting 2 holes in the chest to let some air and blood out, you're going to need to formally insert chest drains so that the patient is ready for transport. So who is able to do this and how you're able to check that in the right place? Blood pressure and cap refill we've mentioned, and even more importantly, I do not want my trauma patient to be hypotensive. I want to be aiming towards at least the 50th centile, and if there's a coexistent head injury, I'm going to be aiming for a little bit higher to try and perfuse the head, but also from worried about a spinal injury, I don't want it being getting under-perfused either. Thinking about activating my major hemorrhage protocol, but given tranexamic acid, access is already mentioned. Blood sugar is really important, neurology from head injury, and then temperature is even more important. I do not want my trauma patient cold. We know that being cold is part of our deadly triad of trauma, so I'm actively trying to get these patients back into normal thermia. Hemorrhage control, I might be putting a pelvic binder on if it's not on already, and neuroprotection, as we mentioned, for traumatic brain injury needs to be considered and implemented. And before the transport team arrive, I want the patient to get through a CT scanner. For the likes of this patient, you won't be ordering a pan scan, but essentially for all purposes it is head, neck, chest, abdo-pelvis, in order to identify any injuries that need addressed. Now, this will give you a huge amount of information that you can then pass on to the not only the receiving area, so that they've got the correct people there to initiate immediate life-saving interventions, but also from your department if there's anything that you need to do before the patient is transported. Again, from these point of views, you're thinking of the simple things that need to be done well. So if you're involved in traumatic cardiac arrest, there's generally blood and material all over the place. It takes time for this to be cleaned and restocked for the next patient. These events can have a huge impact on your department. So you're thinking about your hot and your cold debrief. And then you're also thinking about any learning, because there's such rare events. If there are learning, you want to get it in place for the next one happening. And in pediatrics, we always think of prevention. So is this another stabbing injury? Is a road traffic accident in the same area? Is there an intervention we can put in place to try and prevent this happening again? So many thanks for giving me the opportunity to talk through my approach to post ROSC patients and what we need to do from an emergency department in order to stabilize them from transfer. So code is at the bottom. Any feedback is greatly appreciated. And if you have any questions, we're happy to answer. And thank you for listening.
Okay, I don't think, are you here, Ben? That's okay, we seem to have lost Ben.
Sorry, Ben's internet is being reset.
Okay, no worries. Was there any questions in the chat for Stephen?
There was one question that came in from Jenny. Is there a length of time of arrest, i.e. 2 minutes or lactate not above 5, for example, where you feel full neuroprotection is not needed? Is it always tricky to decide?
I think it's always tricky to decide, and I'll see if the panel has any further information. I don't have any huge evidence base to play from. So I think if you're going by individual patients, I'm probably going to try and look for the best outcome from, in which case I will neuroprotect all cardiac arrest patients until I am told otherwise. There's different prognostic factors, but obviously the longer the downtime is, the higher the lactate, the greater the risk. For those who have a short arrest, theoretically, you could probably get away with it. But if they come into the emergency department, they've usually had a reasonable downtime before the chance to get to my hands.
I think it differs between in hospital and out of hospital. Out of hospital, the history is so uncertain, isn't it? And you might get, there was only a short arrest, but actually they could have arrested for longer than that. And they could have had a significant low cardiac output prior to the arrest. So I think you're on the side of caution, don't you? You protect them until you know otherwise. In hospital is different, where you can have a shorter, more often witnessed arrest. And if you get a patient recovering quite quickly afterwards, neuroprotection is not probably necessary. But I think it's probably more the history. But if you had any doubts, probably are on the side of caution and neuroprotect them. You'd lose nothing by doing that.
You rarely get a lactate less than 2 in ED and health. I'm not sure you're going to get. That might be a moot point. I think a lot of lactate to 2.4 just on kids who are smiling at you.
There's another question coming. What is your criteria for not starting resuscitation?
That's a really difficult question to answer, and part of that's reflected by the fact that pediatric cardiac arrest is such a rare event. So if you look at some of the data, the most common age group to arrest are the young infants under 1. And for those, my threshold is much lower. So for the cities of the sudden infant deaths, where essentially the parents put the child to bed, they don't see the kid for a few hours, wake up, they're cold, they're mottled, they're stiff, will happily call those as soon as they enter the department because their downtime has probably been quite significant. The variations in that might be if they come in, they're a little bit warm, if the parents have seen them in a shorter time frame, or there's been some signs of life. Bar that, I think what we do, by the time they come in, there's usually such a huge period of activity for other arrests. It takes you maybe 5 minutes before you get some additional information, and you might be reorientating your care quite quickly. So if they clearly come in, their pupils are fixed, there's no pulse, they're cold, they're mottled, and they've had some CPR before they arrive, as a team, as we'll probably discuss early, saying that this is a time frame that we think we'll do active resuscitation for, and then at this time we'll start to think about stopping. So it varies depending on the case, is probably the best way to answer it. Any other thoughts from the team?
I would add that sometimes, even if they're dead on arrival, you have to go through process for the parents' sake to witness that you've tried and you've treated their child in with respect and due diligence, and that you still gave it a go. I think that means a lot to them in retrospect when people look at the data. So unless they're in rigor mortis, and if there's family presence, I would generally resuscitate. I mean, if they're stiff as a board and dead for a while, obviously there's nothing to be gained and it's more traumatic. But unless they're in rigor mortis, I would generally, in family presence, resuscitate regardless.
There is this perception that when you're doing chest compressions and bagging, that the child's alive, and then so even though the child is physically got no heart, but there's no pulse and the pupils are fixed, and the family still feel that there's some form of hope. But once you stop doing that, you're very right, it just all ends. So I think the best piece of advice is you treat it on a case-by-case basis.
And that's a team decision.
Yeah, I think you don't take the sole responsibility unless you are the only consultant there. If I'm there with other consultants, I'll usually pull them to the side, and 3 or 4 of us will have a discussion outside the general team and the family to come up with what our action is going to be. And that seems to work well. The difficulty is when you get a breakdown, when one consultant wants to go slightly longer than the other, and you always have to default to what is potentially the safest one. So you go with the one that says that they want to go a bit longer.
We have a question from one of our panel. So mention keeping as that blood gas, Shilpa, on the higher side. Are we thinking of 8 to 11? Understand the rationale, but just clarifying. So I think this was in relation to you talking about the CO2.
So trying CO2 within a normal range.
Normal range, yeah.
Apologies, I was talking more about the blood sugar.
Yeah, so I think I'll speak from an ED point of view. So I think any child that's under stress will have a huge amount of catecholamines and cortisol, which will result in an increase in glycogen breakdown and production of glucose. So we'll expect most of their BMs to be a little bit higher. The evidence that I've seen, I think it's mostly from adult studies with some pediatrics, that if you try and target that blood sugar into narrow range, you increase the risk of them becoming hypoglycemic. If the brain's already been underperfused and is already a little bit kind of starved by given periods of hypoglycemia, it's associated with poor outcomes. But anyone from ICU have any differing thoughts?
Yeah, I think you just want to keep the glucose in the normal range. It's hard initially. Starting insulin's not what we tend to do because you'll tend to overshoot the other way. Kids over 2, I don't tend to put any dextrose into the fluid, would be the first thing. And normally within a short period of time, the blood sugar evens itself out as the stress stops. The under 2s, I would put it in because they're more risk of going the other way with hypoglycemia. But most of them will settle by themselves, and we're not doing strict glycemic control because you'll do more harm than good with that.
The key is avoiding hypoglycemia aggressively. and not starting insulin is important. And there are studies looking at the efficacy of tight glycemic control, including starting insulin on patients, and it actually makes matters worse. The exception to that is the diabetic population, obviously, and then they need better glycemic control and starting insulin, but that's the only exception to that. And we talk about it. Ben wanted to plug the paper in archives from a couple of months ago. If someone can put the link in the chat, that'd be useful. And we address this very issue. But the take home is the brain needs sugar to function and not be further damaged. Don't let it starve of sugar. So be comfortable with high sugars unless they're diabetic, but don't let them go hypoglycemic. It's quite a simple message. It's not difficult to implement it clinically either.
Can I maybe make one more point? It didn't come up as a question, but this is I suppose another common thing people get wrong, and that is we've changed from, it's been mentioned already, we've changed from cooling these children to targeting normothermia. And quite often these children will come in a little on the cool side, and people love to warm them up. They'll put the bear hugger on, and next thing this child will be parexic. I don't think you should be warming these children up until they're in the ICU. The studies show that there's not much of a difference between active normothermia and hypothermia, in that normothermia is better when you can actually control the temperature because you get less cardiovascular instability and people are more comfortable with it. But you do harm if you try and warm this patient up in an uncontrolled environment. The big goal for these children is preventing pyrexia. And as long as they're above 32 to 34 is where we used to target. And as long as they're up and above that, I wouldn't be trying to warm them up because you will overshoot. And really the only safe place is once they're in the ICU that you can bring them up slowly to normothermia.
The exception being severe hypothermia under 30, where you warm them quickly to 30 because they are at the high risk of arrhythmias, arrests, and the drug's not working. And then you stop rewarming when they hit about 32 and then gradually rewarm then.
Yeah.
Okay, I think, guys, that is enough for questions there at the minute. Good talk, and thank you very much, Stephen. We're going to go on to a joint talk by Tom Waterfield, a pediatric emergency medicine consultant, and Dr. Constantinos Kanaris from pediatric intensive care and transport background. So, guys, thank you very much.
If you can hear me okay, and then hopefully can you see that okay, Tudor?
Yeah, can see it.
Yes, it's on now.
Okay, cool. Yeah, so I'm Tom. I'm a PEM consultant in Belfast and a senior lecturer in paediatrics at Queen's. That photo's not that long ago. It's been a bad year or so. Right. Anyway, and then Costas. So I'm gonna do the first half, and Costas is gonna do the second. You should have that already if you're on Slido. This is, but if you're not, that's just for the pediatric emergencies thing. I will say the feedback code for this is on the slide with the diagram of smooth muscle. So keep an eye out for that. And it means if you're just trying to watch this back and skim to the code, it'll be difficult. So the code for the feedback is on the slide with the smooth muscle. So keep your eye out for that. So my aims are to go over the initial assessment and management, essentially, of a child with sepsis. And then so that's what I'm going to do. And then Costas is going to do the second part. Just put this is our department in Belfast. This is on a social event. This is not in ED. But I suppose I'm going to make the point. I feel I'll probably get in trouble for this, but we kind of do a bit of everything. So I'm not going to be talking about, my talk isn't going to be that you need point of care ultrasound or central lines. I'm going to talk about what you do really in A&E. And if you have some of these specific skills that make you superb, then that's brilliant. But my talk isn't going to be about them. I'm going to be a kind of jobbing tradesman who's going to do the job and hopefully resuscitate the child. Don't be this guy. The name escapes me. That the teacher from the dark arts from Harry Potter who says he can do everything but can't do anything. So do the basics really well, and that's kind of the aim of my talk. So it's a 6-year-old. I'm going to go around the case. I've got to thank Costas for the case, and he'll give you a bit more of the end information at the end. They're known to have febrile convulsions. They're fully vaccinated, and I've had a bit of a sore throat, high temperature, a few days that hasn't really gone away. They had a short febrile seizure outside the GP practice, and so they were sent up to hospital quite rightly by the GP, and they were given, because we've heard already today about how important it is to give benzos early. The excellent pre-hospital paramedic crew gave midazolam, and because they gave it so quickly, the seizure terminated. The initial assessment in A&E resus is that they do have an airway. The SATs post-seizure are coming up, and the heart rate is 168. The cat refill's prolonged. They're cool around the edges, and they're not really responsive, but they have just had a seizure and have got equal reactive pupils, 3 millimeters, and their blood sugar, as we expected, because we've been hearing about high blood sugars, is a little bit high as part of their stress response, and they're very hot. And you notice that they have a widespread rash, a bit sandpapery, a bit rough feeling. They have petechiae, just a bit of conjunctivitis, and quite a red-looking tongue. So petechiae and purpura, we can't just talk without sepsis without putting them in. So petechiae are small, typically pin dots, less than 2 millimeters, and purpura are much larger, typically like bruises. Petechiae on their own are very weakly associated with meningococcal disease, and that's even if they're spreading. And my paper's in there if you don't believe me. But whereas purpura and fever are typically synonymous with meningococcal disease, a far, far less common presentation and a far, far more worrying one. So with that in mind, on the slide, what do you think the most likely cause of this child's raging temperature, seizure, and just kind of moribund appearances? Is that working? Is that working? Tudor? Anyone?
Yeah, people are voting on it, Tom, I can see online, but you must have hidden the results. Are they coming out?
Fair enough. There you go. I thought I'd mastered Slido. Okay, yeah. So haven't seen we're changing their minds. Look at that, and it's like more people even waiting for the oh, maybe it's top 6 shock. Okay, so what's the most likely? So you're adjusting around meningococcal. I kind of led you there with a non-blanching rash. Actually, this child's born after 2015. So you've got to remember meningococcal C vaccine 1999, meningococcal B 2015, and then we also had AC YW came in as well, although that's not until older children. So we see far less meningococcal disease than we used to. We also see very little pneumococcal. So actually now invasive group A strep is more common, and this syndrome, this pattern, is a fairly typical description of someone who's perhaps had a sore throat, scarlet fever, and progressed towards a kind of streptococcal toxic shock. But all worth considering. So group A strep, so it's a gram-positive cocci, so you get them in chains. It's beta hemolytic, and that's all the ID you ever need to sound clever from an ED point of view, at least. Remember, we're not there. We do a bit of everything, and it causes lots of different disease manifestations. So it can cause local disease, so sore throat, tonsillitis, cellulitis, erysipelas. So that's local disease, local infection. You can get your exotoxin-mediated disease. That scarlet fever is a mild form of an exotoxin-mediated disease. And most children with scarlet fever recover very well with oral antibiotics, but very rarely you get this streptococcal toxic shock syndrome. And then you can also get post-infective autoimmune conditions, such as a post-streptococcal glomerulonephritis. And thankfully in the UK, it's extremely rare now, rheumatic fever. So streptococcal toxic shocks is probably under-recognized. Mortality is much higher than its staphylococcal friend. Vast majority end up in ICU, and its treatment is slightly different from sepsis, although we're going to predominantly talk. It isn't so far different that there's just a few nuances. Invasive group A strep is seasonal, and with peaks at extremes of age. Peaks are usually January and March time. Mortality can be 20%, and we certainly had bad invasive bupe strep not in the previous winters. And eye gases is not just toxic shock, as about a 1 in 5 admission rate, with about 1 in 4 needing some sort of surgical intervention. And most of the ones we've been seeing or have seen are nasty pneumonias with empyemas. So not all non-blanching rashes are due to meningococcal disease. Group A strep, we talked about. I mentioned invasive meningococcal disease and vaccines. Gram-negative sepsis. So any sepsis, if you're sick enough, you will get some you'll get DIC and you'll get non-blanching rashes. And then also consider that child who has perhaps been tired, run down, some unexplained bruises or spots, who's come in with a viral illness and actually may have malignancy, or they could even have a neutropenia and secondary infection, although that is thankfully very rare. So initial help, this management of this child, you're going to need some help. You're going to move them to an appropriate setting, and that actually is quite important, moving someone to the right place. You heard Mullen talking about resource use, and sometimes if you have a child who is sick and you want to dedicate resources and focus people's attention, that physical movement to resource can do that. You need access, and you're going to send some bloods, including PCR. And PCR, actually, I'll mention that here, it's really important. So particularly things like meningococcal, only about 50% is blood culture positive. And we've got that from the paper I mentioned previously. PCR, if you've got it available relatively quickly, it's far more sensitive. Give some fluid boluses, you're going to give some antibiotics, and you're going to reassess. We haven't said much about those because we're going to get your thoughts on those bits. So, which fluid bolus do you want to give for this child initially, a 10 or a 20 ml per kilo bolus? I'd love to have done this 10 years ago and seen what people wrote as well. Okay, I think that's enough to go. So vast majority going for 10 ml per kilos. So I know why you've done that, and we're just going to go a little bit into the background. So we go back 20 odd years. Early goal-directed therapy was all the rage. And there was talks of people giving 60 mils per kilo, and a lot of this is adult research, which gets extrapolated to children very, very quickly, and at getting central venous monitoring very, very quickly. And there were some very good results reported, but it was very team dependent. And people were very interested in this. And then the FEAST trial came out in 2011, also in the New England Journal of Medicine, which was looking at giving fluid boluses to children in 3 countries on the African continent. And they got 20 or 40 mils, and they got different fluids, and had to be stopped because there was increased mortality in the fluid bolus group. It's probably worth noting that very few of those actually had sepsis. There was lots of malnutrition, lots of malaria, lots of anemic children, and not access to ICU. But it was enough to cast some doubt over whether just use of fluids without thought was a good idea. And then systematic review, looking more at adults, but showed that, to me, really confuse things. Greater survival if you give more fluid in the first 3 hours, but lower survival with more fluid in the first 24 hours. And I'm going to explain a little bit of the physiology and go through a little bit of this. But essentially, if you're hypotensive, and there are various ways you can manage that, you can use different tools, fluids being one of them, to maintain perfusion, which is what you're trying to do. But we've heard, and Chris talked about it pretty well in his talk, is that these things are temporary. There's a limit to what you can achieve with them before they become harmful. So it's not so much the volume, it's knowing that there is a limit to what you can achieve with fluid. You will not fix a very septic child with no peripheral vascular resistance, poor cardiac output, just with fluid. So to answer that question, the 10 or the 20 actually, there's not a right or a wrong. I think the thing is about reassessment, and I'll talk a bit more about fluid refractory shock. What you don't want to do is not give enough fluid and also you don't want to give too much. And there are ways of monitoring that. And I don't mind if you give 10 and reassess and give another 10 very quickly if it's needed. This child will need more than 10. Or if you give 20, but ask someone to remind you, or you set a system for monitoring them or reviewing them partway through the bolus. What you don't want to do is give a bolus, have long periods of time reassessing, and then decide to draw up and administer another bolus. So in resus, I'll often say, I'd like you to prepare the 20 mils per kilo bolus, give 10, ask me, we'll reassess, and then we'll go straight with the next 10 as a compromise way of essentially providing some sort of monitoring. So which fluid do you want to give? There are other fluids available. They're just ones I put in. Hass's human albumin solution. Who wants what? Let's have a look. So lots of people. So I wouldn't give albumin. You may need it, but not yet. This child has no fluids yet. Don't you have to change your mind? I can see it going down. For the first bolus, I actually don't mind whether you give saline or plasmolite. I ticked plasmolite as the correct one. I think if you're going to use large volumes of fluid, using a balanced solution, plasmolite, Hartmann, Schwinger's lactate, is preferable. I'll explain why. But also human factors. If your department stocks normal saline and the nurses are used to it, and that's your first bolus, one bolus, in my opinion, of normal saline isn't going to be the be all and end all. But if you're going to give large volumes, you should start thinking about balanced solutions. And you as a team leader can do that. Because again, we've talked a bit about human factors. You don't want to be complicating things if you can avoid it. So I'm glad no one mentioned blood products. Blood products are often needed, but are actually harmful if they're used initially. So once you hematolute, you're going to need to replace packed red cells, platelets, coagulate, and coag factors, but you don't need to do that. Crystalloid, absolutely fine initially, but just think about balanced solutions. They're not harmful. There's less AKI in adults. There's less death in adults, and you're less likely to have hyperchloremic acidosis, which I believe for my colleagues in ICU is annoying. So we want to try and help them as much as we can. So if you're going to go beyond that 10 to 20 per kilo bolus, start thinking about balanced solutions. If your department could do it from the off, even better, but don't be delaying things. Okay, which antibiotics do you want to use for this child? Let's have a look what people are saying. Okay. All right, so a bit of variation. So first of all, you haven't got a choice about the third generation cephalosporin. You're going to need to give that because it's pediatrics. It's also penetrates the CSF and it's very effective. Out of the two, ceftriaxone and cefataxime, my preference would be cefataxime if they're very sick, just because you can give it much more quickly and it doesn't have the same issues with calcium through the same line. I think clindamycin in this case, if you've made a positive diagnosis of streptococcal toxic shock, or you think it's very likely, is a really good shout. Gentamicin is reasonable, but I wouldn't, without clindamycin, I think it's useful if you're thinking gram negative, if you've got a renal or intra-abdominal suspected cause of your sepsis. And I would keep an open mind, and I may be the only one that does this, but if someone's very sick, even if I think they have a focus, I have no issue asking surgeons or for an ultrasound to look for other causes. Intra-abdominal causes are easy to miss in children when they're very obtunded. So I've mentioned this, but that's just reminding you. So with third generation cephalosporins for CSF penetration, you can give ceftriaxone fast, and I've done that as well. Again, you don't overcomplicate it. Do what needs to be done to get the antibiotics in, but just remember the issues with calcium. I think cefataxime is a better choice, but it can cause some confusion if you're not used to it. We've talked about gentamicin, metronidazole, and clindamycin. So clindamycin, it's the reason we want it is, I should have done this as a question actually, but it's bacteriostatic and it reduces toxin production, or that's the argument. The other medication we can use is IVIG. IVIG is not a resus drug. Just in case anyone didn't hear me, IVIG is not a resus drug. It is really useful, but it's not a resus drug. Clindamycin is very good for streptococcal toxic shock. And as that table there basically says, if you give clindamycin give clindamycin with or without IVG. Whatever you do, your mortality is reduced by giving clindamycin. So clindamycin is good. IVIG is not a rhesus drug. So progress. So the child becomes more acidotic, lactates up, their calcium's a bit low, the cat refill's still prolonged, they're still a bit tacky, and their blood pressure, at least you've got a blood pressure, because often if you don't get one, is in their boots. And that's after you've given 20, you might have given 10 and 10, or you might have given 20 straight away, and you've given your antibiotics. So we're now in fluid refractory shock. And these are the things that we can do for fluid refractory shock. So we can give more fluid, and we can give lots of fluid in the first 30 to 60 minutes. We can correct the hypercalcemia. We can give vasoactive drugs, and we can also intubate and ventilate. And that's, I'm going to let that come in the next talk, but sometimes actually taking complete control in that way can almost you almost see that like they've given another inotrope. I know it isn't, but you sometimes see a big improvement. So fluid boluses, we can give up to 40 to 60 mils per kilo. You can actually give as much fluid if you need to, but beyond that, you're going to be needing to really think about monitoring in the first, you want to be trying to give that in the first 30 to 60 minutes. So if you are giving fluid and they really need fluid, you should be assessing and you should be giving it in 10 mil per kilo aliquots, but you shouldn't be, there's no situation where restricting fluid early in resuscitation has ever been shown to be beneficial. And this comes from the International Sepsis Consensus Guidelines, 10 to 20 mil per kilos, 40 to 60 mils in that first hour. And the paper's there. So correct the hypercalcemia, so you can give calcium gluconate or calcium chloride. The doses are in the Paediatric Emergencies app, which is incredibly useful. You all know this already, but just for a refresher, so half your calcium's ionized, the other's bound to proteins or bound to anions. When you have a bacterial infection, you will often be hypercalcemic. PTH, the parathyroid and the parathyroid hormone function is impaired. Unfortunately, it's not as simple as just giving everyone calcium, because hypercalcemia is also bad, and there's some adult data. If your calcium's overcorrected, actually can affect mortality as well in the longer run. This is the slide with the smooth muscle in bottom corner if you're looking for the code. So this is you'll have adrenaline. I was thinking about how does calcium work or what's the effect. So this is adrenaline here. I made this actually, this diagram. A calcium channel. You get increased calcium, intracellular calcium entry. That activates your myosin light chain kinase, which phosphorylates myosin, and then you get, remember, your myosin actin cross bridging from kind of sixth form A level. So calcium isn't an inotrope. If you've no calcium, it's very hard for this signaling to work. If you've got adequate calcium, this will work really well. And having too much calcium probably doesn't do anything because you've got enough calcium. And calcium has lots of other transmitter roles in lots of different parts of the body. So it's not just more is better, it's just having enough, the correct amount of ionized calcium. So peripheral vasoactive drugs. So I've written peripheral. There's a place for central lines and centrally given drugs, but that's not what I'm going to focus on. I think it very much comes as part of Stephen's talk, which you've had already, stabilization. I'm not a big fan of someone trying to very early in the resus get a central line unless they have a very particular set of skills. So a few pictures you may have seen already. So remember the dead space, that's that picture on the left, and Chris discussed that today. Go and check. It can take the same for the setup there, 27 minutes to reach the patient. Start adrenaline early if you know it's going to be required. So there was a question earlier about, do you have to wait? As your experience grows, you will know whether a child is likely to respond to a small amount of fluid. And if they're not going to, I would be getting my inotropes prepared whilst we're doing the basics well and starting them. And I would have no issue starting them after 20 ml per kilo bolus, personally, if they're needed. You can give push dose adrenaline if you're stuck, and that's that 1 in 100,000, 1 mics per kilo that we talked about, where you can dilute 1 milligram up to 10 mils. Sorry, you can get them in a jet and dilute it 1 mil into 10 mils. Or you can start an infusion with 1 milligram and 50 mils at 0.3 mils per kilo. which is that 0.1 mics per kilo per minute that Chris had talked about in the inotropic talk. And then a bit of physiology again, just I know you know all of this, but what have I done wrong? Okay, now someone's saying about my biology teacher and the messages. So blood pressure, cardiac output, it's not exactly times, it's cardiac output and vascular resistance. So we go back to kind of why we need fluids, why we need what we're trying to achieve. And cardiac output's your heart rate and your stroke volume. So adrenaline, noradrenaline essentially can work on different parts of these. So adrenaline, I like because it's easy and actually for something quick, most of our children are cold shock and they need their blood pressure supported by cardiac output and vascular resistance. So I get the alpha and beta effects, I get a higher heart rate, a larger stroke volume, and I get some squeeze. Noradrenaline is more alpha effects. We're going to get the squeeze, but we're not going to get so much cardiac benefit. And then we think about fluids. So essentially, if you've got vasodilated wide vessels, the volume of fluid that's in there, you're not going to have blood pressure. So you can temporarily restore perfusion and blood pressure with fluid, but it is going to leak out of that circulation. You can try and restore it with drugs, or you can use a combination of the two, which is why if you need to restore blood pressure and perfusion quickly, you give fluid quickly, you start inotropes early. No one of these on their own is going to be the complete fix. You're just trying to support that child through that illness until your antibiotics or other treatments actually result in cure. So you're just trying to support and get through without causing so much harm as well that the team after you can't manage them. We go back to the fluids arguments. We might get them through resus, but then the fluid management is a real issue in ICU. So I think trying to understand fluid isn't harmful. It's just a tool in what we're trying to achieve. And fluid refractory shock. So the last part's taking over their airways, and that's where I need some help, and I can't do that. And that's coming up to my kind of 30 minutes just under, and that's where I want Costas to come and give me some help.
Yeah, I'm impressed with your timing, Tom.
Pardon?
I'm impressed with your timing.
Oh, very good. I'm gonna try and stop sharing. I'm having a bit of a. Let me just get back onto the right page. Why am I? What am I doing? Stop share. There we go. I'll silence myself and.
There we go. Can everyone see my presentation now? Stephen, can you see my presentation?
Yeah, I can see your presentation, but I can also see all your slides on the left-hand side.
On the left-hand side?
Yeah, when I'm looking at it, and so it looks like it's not in presenter.
Have you started the presentation yet?
About now?
That's still the same screen. That's it now.
We got it.
That's it.
Lovely.
Yeah, I see two vitals on gas.
Great. Okie dokie. So you're lucky enough to have Picky on site with this patient. A brief recap on the case. So Chloe's 6 and we think she's got a sore throat, probably group A strep, toxic shock syndrome. She had a seizure outside the GP practice when she was walking out with her antibiotics. And also when Picky arrived, Mum said she's injured her head on the step as she was fitting. A bit of blood on the head. Looks quite superficial, but a bit of a worry. So when we arrived there, these are her observations on the screen. So I'll give you a second to digest them. Please take a screenshot on the gas, and then we'll see what worries us about this gas and about these observations, and we can try and solve the case together to try and see if we can get Chloe to survive. So together we'll formulate a plan. So we will address airway breathing circulation and disability and exposure. So this will be done through Slido. I'm using my own Slido, so it's a slightly different code. So please use this Slido and this hashtag PICU sepsis.
Process, I don't see your slides changing.
Are the slides not changing?
No.
What can you see?
You can still see vital signs on the left and venous gas on the right.
So the slide's not changing. That's odd. It's
There are little arrow keys that you could probably use on the screen to move them if you need to.
but they've changed on mine. Can you see now?
No. Just the vitals and venous gas.
Maybe Costas, you should reshare the screen again, because maybe not the correct one is shared with us.
Okay. Stop share. What can you see now?
We can see the presenter mode, so it's the wrong way around. So you need to share the other one.
Now?
Yes, that's it.
Okay, good. So we're cooking. So please go into Slido. This is the code again. PICU sepsis is a different Slido to the previous one, so don't use the previous one. Now the design is to be interactive, so if you can type some stuff into the YouTube chat room as well, then one of the team will relay your answers to me as well, and I'll try and address them as we go on. Okay, so first question, if it works. Okay, so I showed you the gas earlier. What's the single most worrying feature of closed capillary gas? So let's try and brainstorm. Okay, pH, acidosis. The lactate, yes, the lactate is a bit of a worry. Okay, low calcium, yeah, that's a worry. The CO2. Okay, lots of good stuff. Right, so I can't see the YouTube responses. So if Tudor can answer me, if anyone wants to comment, does the normal blood sugar worry anyone?
So online lactic acidosis, respiratory acidosis, and mixed acidosis.
Okay, so an unpopular, and this is slightly advanced blood gas interpretation, and you're not going to find this in the books. You'll find it from spending time on next to the patients in a critical condition. My most worrying part of that gas for me is a child that sick with those observations having an entirely normal or a low normal sugar. So it's on the lower end. So that suggests to me that this child has already exhausted her adrenergic response. It's a subtle feature, but it's one that is worth pointing out. She's not a baby, so she's 6, so she's got enough stores there to be able to mobilize and increase her blood sugar, and those have been utilized already. So in low normal blood sugar in a child with septic shock is a considerable concern, because it suggests that with someone who's already used their catecholamines, their own innate catecholamines, and they are likely to arrest very soon because they don't have any more reserve. So all your answers are correct. Lots of worrying features on that gas. The numbers do not make a pretty read, but what stands out for most experienced frontline physicians that deal with emergencies is that blood sugar should be much higher. She should have enough stress response there for her to have a blood sugar that's 9, 10, 11, and it's not. It's about 4.5. I can't remember off the top of my head. So that is a subtle but very important point, because it will allow you insight as to how to prepare sooner, and it will also help you prepare for intubation slightly differently, because you know that you probably need to have your inotropes ready before you intubate her. Okay. Any questions on this from the group already? I'll take that as a no. So next slide. So now clearly
there's no questions.
We need to intubate this child. So I'll give you a moment to see what the best choice or the least bad choice is in terms of how we intubate her. I'm going to wait till about 100 people respond, because there's about 400 on the channel. Although we've got a clear front runner. So you've chosen the correct answer, and let's dissect it. So is the choice of paralytic important in this situation? And if so, why? Can anyone on the channel tell us about it? Why do we want rocuronium over succinylcholine, or is that just a whim?
So we've got an answer here. Sux has you get bradycardias and raises potassium.
Good, good. So that's a ballpark correct answer. So we need to know the illness to beat the illness. We need to know how this disease is going to behave. So we have a child whose potassium is already high on the gas. I think it was about 6.2 or something. And we have a child who is likely to get acute kidney injury secondary to the sepsis for a number of reasons, generally pre-renal failure to begin with. Giving succinylcholine will cause further potassium release. If she needs blood products as well later, they are potassium rich because we use potassium citrate to stabilize blood. Again, we are particularly going to give more potassium through blood products. So if we give Sux now, we are risking this child arresting on induction by causing an acute hyperkalemia, and I've seen this happen. So even though succinylcholine generally has a faster onset of paralysis, which is favorable in some situations than rocuronium, merely by doubling the rocuronium dose, which is a much cleaner drug than Sux, we can get a quittable fast onset of paralysis. So rocuronium is superior to Sux in this situation because it's a safer drug to use. Equally, propofol is quite a dangerous drug to use in very septic obtunded children with shock because it's a potent vasodilator. And the last thing you need in a child with warm shock is to vasodilate them further, because you're going to drop the blood pressure, and by extension, they're going to arrest on injection. Which then brings us on to the reasoning for why we need a cuffed tube. Can anyone in the group tell us why we might prefer a cuff tube to an uncuffed tube?
I think you really want to intubate once and once only. And if
Absolutely.
you should up or downsize the tube, that's no good.
Yeah, so excellent. So cuff tubes are quite forgiving. You might be slightly off with the sizing of them, but all you have to do is put some more air in the cuff, and then you have a tighter seal around the airway, which will allow you then to ventilate better. If you have too small a tube, you won't be able to ventilate a child that is likely to have very high ventilatory requirements because they have sepsis. So you don't want to be reintubating and exposing this patient to more risk by having to tube them again. And also you need to work smarter, not harder. So by using a cuff tube to begin with, you make less work for yourself. But more importantly, you're taking some of that risk away of intubation from Chloe. Which then, once we've done the tube, then ideally we would have pre-optimized for the tube, and we would have started peripheral adrenaline to begin with. We need to decide how we ventilate her. Okay, now how are we going to do that? A slightly more advanced question, but you are likely to need to hold the fort until PICU arrive if you don't work in a big center. So this is stuff that you need to have some basic understanding of. So I think what we're seeing on the screen now is a good example of confirmation bias. Because, I mean, the right answer is gaining ground, but the right answer is not the one that 63% of you have answered. It's the second one. And I'll go through my reasoning now. So again, back to basics. We need to know how the illness will behave in order to beat the illness. So we have a child with fulminant sepsis. With fulminant sepsis, we get a considerable amount of vascular leak. There's increased vascular permeability, and you're going to give a lot of fluid. So the combination of that means that the lungs are going to be flooded. When the lungs get flooded, you get lots of pulmonary edema. And when you get pulmonary edema, ventilation becomes very, very tricky. Now, the best way to displace that fluid from the alveoli is to have a higher PEEP. Okay, and remember, oxygenation happens during the inspiratory phase, so you need slightly longer inspiratory phase, so a higher I time than usual, so 1.2, in order to keep those alveoli stented longer. So you need a higher PEEP of about 10, because that stents your alveoli that are more prone to collapsing because of all the fluid and keeps that fluid out to allow better oxygenation. Now, with that comes the risk of changing your intrathoracic pressures enough that it will affect your blood pressure in a bad way, but you're already on inotrope, so you need to be ready to mitigate for that and ride it out with more inotrope and possibly more fluid. Okay, so you need to go on. Most people will start on a PEEP of 8, and that's entirely reasonable, and then titrate down or up as much as the child allows you. The risk with low PEEPs is that the alveolus collapses, and when it collapses, the energy expenditure needed to reinflate the alveolus is significant and causes a lot of atelal trauma and predisposes to more lung damage. So in terms of how it affects your patient is going to be much worse for both the acute and the long-term outcome. Okay, so the principles here, we have a high PEEP strategy, a high I time strategy, this child was very difficult to oxygenate. And even those very high settings, her SATs were about 75%. Okay, so I've not put this as a formal slide or question, but you have a child who's on very high PEEP strategy. We ended up on a PEEP of 15, 16, I think, which is not something you should be doing without support of a PICU right next to you. And FR2 of 100%, high eye time, and the SATs were still in the low 70s to mid 70s. So what can we do to try and oxygenate this child more, or to try and make her survive? Again, I can't see the text, so if one of you guys or girls tell me about it, that would be lovely. Is there anything in the chat?
No,
Tudor?
not yet. Not
No.
yet. I can't see the slider though. So if anyone else, so can try APRV or high frequency.
Yeah, so I need to move this child from a small hospital
oscillation.
to a bigger hospital. So an oscillation would be not unreasonable, but I can't do that whilst I move. APRV again, it does have its utility for retrieval, but it has been shown in more long-term studies using PICU that we don't use APRV well enough in PICU, so mortality is higher. I think part of that is us not using it correctly yet as a community of PICU, but the adult intensivists use it to good effect to the extent where they got rid of the need of high frequency oscillation. So good suggestions, but not practical for me in the middle of the night to try and move this child to a smaller to a hospital with a PICU.
Another suggestion is nitrous.
Good.
Nitrous.
I'm glad someone said nitrous. So what is the main side effect of nitrous? So you suggest nitrous because you have high pulmonary pressures, so you want to drop the pulmonary pressures. Does nitrous only drop your pulmonary pressures? The answer is no. So it's a potent vasodilator, and this is a child who was already predictably coagulopathic, and pulmonary edema manifests with essentially bloody, frothy secretions. So if you give nitrous, those secretions will get more bloody and worse, and you will also vasodilate her. So the chances of her on arresting with using nitric are quite high. So in this context, I opted not to use nitric, but with those sort of numbers, it's a considerable concern for the team that she will not survive if she was to go to a conventional PICU. So you need a PICU that can do ECMO. So we had to make sure there was an ECMO bed available for us to take her to. Otherwise, she was unlikely to survive because she was on maximal ventilatory therapy at that time with poor oxygenation already and an awful X-ray. So it's important to, you can be clever about it and calculate the oxygenation index, which is not hard to calculate. But if you are needing a PEEPs of 15 on 100% oxygen and you can't ventilate, then on balance, you need to think of ECMO and push for getting an ECMO bed, really. Otherwise, she's likely to not survive in a conventional PICU. Okay, so any questions on that?
Would so a suggestion is coming here. Would you try and hand ventilate until ECMO available?
That was a distinct possibility. The thing is with hand ventilation is that you can deliver the same breaths on a ventilator. You just don't want to see the numbers. You don't want to see that you're giving a 50 on 20, which is going to completely mess up her lungs. So you can do that through the machine. So, you know, I'm a big fan of hand ventilating, but actually the machine can generate. It's just going to tell you the truth about how dire the situation is, if that makes sense. Because the Hamilton, which is what we use, can't deliver those pressures. It's whether you want to look at those numbers or not. So I think it's a bit of a willful blindness if we hand ventilate them because we can't put them on the ventilator that can deliver those pressures anyway. Right, in the interest of time, I need to move on.
Can I ask a question? Sorry, Costas. Was there
Yes.
pleural effusions?
There were no pleural effusions. There were
That
just
would obviously be
significant
some-
pulmonary edema with severe ARDS picture on the X-ray. We did a point of care ultrasound. There was a tiny bit of fluid, but nothing worth draining. She did end up with more effusions later because she had a lot of fluid, but not during the acute presentations. So let's move on to our circulation plan in warm shock. I'll be quick because it was touched upon by Tom. Good. So you know your warm and cold shock. I know it's not used a lot, but we all know what we mean by talking about warm and cold shock. So although imperfect, I quite like using the terms. So like Chris said in his own presentation, if you're not a specialist, adrenaline is quite a forgiving drug. It's on the guidelines as a first point for a reason. People are comfortable using it. So there's absolutely nothing wrong with starting with adrenaline and then adding other bits in. You just then need to decide what the best parts to inotropes are to add in. And NORAD is the go-to drug because you need more pressors. She's vasodilated. You need to vasoconstrictor and squeeze her a bit more. So that's a good drug to use. And then third line is vasopressin. Now, as per the international consensus paper, and as per her blood sugar that we knew earlier that it was low normal, she was always likely to need hydrocortisone because she's getting it after 2 inotropes. You are formally into the catecholamine resistant shock arena, and therefore you need to be drawing up your hydrocortisone and giving it. But we knew she was likely to need this from the beginning, and that's why that first gas is important. And even the normal numbers tell their own story. So be aware of what the so-called normal numbers and pay attention to them. So take home message: once we reach the 2 inotrope threshold, get your steroids out. Now, I like blood products because they are useful volume. She had a lot of blood products because she was severely coagulopathic. So she got blood, she got platelets, and she got fresh frozen plasma. I do not like saline, and that's been touched upon before. We have a child with severe acidosis, and we need as normal physiological parameters as possible for our inotropes to work. If your pH is less than 7, none of those inotropes are going to work very well at all. So by giving pasta water, which is acidic, you're going to confound the acidosis further and make the pH much worse, thereby causing detriment to this child. So if you must use colloid before the blood products arrive, do not give something acidic, give something basic. And both Hartmann's and Plasmolide are basic solutions. There's a few areas of misinformation in respect to Hartmann's, whose other name is Ringer's lactate, saying, oh, we can't give lactate to this child. That is not based on evidence. The lactate that is in Hartmann's is metabolized by the liver into bicarbonate. So it's not an acid. Physiologically, it's a base. Giving Ringer's lactate does not increase a child's lactate. Okay. The other aspect of this is that she's already hyperkalemic, and significant acidosis drives potassium from the intracellular to the extracellular space. So by making her more acidotic and by giving blood products at the same time, you're going to cause a further hyperkalemia. So try and achieve a pH above 7.15 ideally, and try and avoid saline because that will only take your pH in the wrong direction. Okay. Any questions on that?
Sorry, we don't have a question on that, but we did have a question about your ventilation strategy.
I'll address that at the end probably because
That's
we've
fine.
moved past from B. While I'm on circulation, I'll touch upon calcium. So critical illness, especially septic shock, comes with critical illness hypocalcemia. The best way to check our calcium again is on ionized calcium. That's the free calcium we have. And these children really go through their calcium very quickly. Calcium is known as the hidden inotrope, so make sure you stay on top of it. So generally, most people try to aim for an ionized calcium of more than 1.1 or thereabouts. So if it's dropping below those numbers, keep checking and rechecking. And if you've given it once, don't forget about it because it will drop again. So Chloe needed 3 lots of calcium gluconate in a space of 2 or 3 hours for it to stay above 1.1. So always keep an eye on the calcium because drugs again needed to work, and it does work well on the myocardium. So don't forget it. And if you've given it, remember that you might need to give it again. So remember, Chloe injured her head. We think it's superficial, but we have no means of proving it, and she needs to go to an ECMO center. So what are we going to do? Are we going to risk taking a very unstable patient through to CT, or are we going to pick and run and go to the ECMO center anyway? Okay, so it looks like the majority have been cautious and decided not to CT her. I'm disappointed in people choosing propofol because we just said that propofol is a potent vasodilator, so we shouldn't use it in kids with significant sepsis. So put the white stuff in the bin for this case, and rely on good and tested morphine and midazolam for now. So generally, you don't need a CT to make you eligible for ECMO, but because you had a head injury and because children on ECMO are anticoagulated, no ECMO center would accept her unless we cleared her head with that story. Because if she had any intracranial mischief or injury, if they had anticoagulated her, that would have made things worse in terms of trauma. So we had to make sure there was no intracranial bleed. So we had to take a very sick, very wobbly patient on 4 inotropes and very high ventilatory pressures who was hypoxic to CT just to prove that she was, whether she had an intracranial pathology or not. And thankfully she didn't, but it wasn't a pleasant experience. But otherwise, she would not have needed a CT if she didn't have that complex history to go with it. In terms of neuroprotection, we've touched upon these on previous slides. It's important to do the basic things well. So ventilate, aiming for normal oxygenation, 88 to 92% is what the evidence shows for the children is fine. CO2 ideally needs to be between 4.7 and 4.8. Ideally, don't let them become pyrexial. Try and bring the temperature down to between 36 and 37 is a good sweet spot. Don't let them go hypoglycemic, and aim to have a normal blood pressure using fluid and inotropes, essentially. If you can elevate the head to 30 degrees, then do that. If there was any concerns of seizures or anything like that, then I would have given her some Keppra, but at the time there hadn't been any, so I opted not to give her Keppra at this point. And I think this is our last slide, and we've touched upon it with Tom. Let's see if you were paying attention. Yeah, okay, good. Some good answers. Right, so IVIG has in sepsis has in barn door sepsis doesn't have a role to play. However, the international consensus states that IVIG, specifically in toxic shock syndrome, so toxin releasing diseases, does have a role to play, and if available, we should give it. Okay, it can change the disease trajectory. Sometimes it works, sometimes it doesn't. About 20 years ago, before the pure version of IVIG was available, we used to give fresh frozen plasma because that has dilute immunoglobulins in. So she had that as well. But thankfully, we did manage to give her some IVIG and get her hands on it. Half the battle is convincing the microbiology team to unlock their safes and give them to us, because it's a very precious resource and we don't have the stores required in the UK post-Brexit, unfortunately, so it's harder to get hold of. But if you can, it's worth asking the question. Problem with IVIG is that it's a blood product. It can be anaphylactogenic, so you need to give it slowly and be ready to respond, because sometimes they will drop the blood pressure, especially if you give it faster than you should. So be aware of the side effect profile, but it's generally a good drug to use in toxic shock syndrome in the context of sepsis, but it's not appropriate for every septic child by any means. And obviously, because we're thinking about toxin releasing bugs, clindamycin is important because that can mop up the toxin and stop the toxin production. Okay. And it's more important to give Clinda than IVIG. So this is what we did with Chloe. This is a real case, and we have consent from the family to use Chloe's real name. So we used a Cufty T-tube. Because of all the blood that was coming up from a tube, she was increasingly harder to ventilate. And we used some nebulized tranexamic acid and adrenaline to try and mitigate that. The evidence for nebulized tranexamic acid is anecdotal. There's no high quality evidence, but anecdotally it works very well. And there are a few papers looking at children with post-adenotonsillectomy bleeds and adults with hemoptysis and pulmonary bleeding that shows that it works. And so for under 25 kilos, the dose is 250 milligrams nebulized, and over 25 kilo children, we give 500 milligrams nebulized, and it did work quite well. We employ a high PEEP strategy with a long eye time. We avoided nitric, and very importantly, recognized the need for ECMO. And I can guarantee you that if Chloe went to an ICU without ECMO, she was unlikely to survive staying there, and there was no need to expose her to more risk by moving her to a second PICU afterwards. In terms of circulation, this is before dopamine was phased out. So she had been on 4 inotropes plus steroids, and we gave lots of calcium corrections. We see teeth in scan, and during scan, we were worried that she showed signs of raised ICP because she became quite hypertensive and bradycardic. So we gave some hypertonic saline, but there was nothing on the CT suggesting that why she should behave something like that. We gave Kev, Clinda, cyclovir, and IVIG, and got lots and lots of volume, most of which thankfully was blood products. And unfortunately, she had already had some saline before we got there. And this is her. She spent 11 days on ECMO, came off ECMO around Christmas time, and this is her 2 years later celebrating her 8th birthday riding on a unicorn. And that is the talk. So these are some more resources about Chloe's case and about where we got our material from. And that's your feedback code on the screen. Thank you for listening.
Thanks for that, Kostas. We did have one question on the system so far, just in relation to your ventilation strategy. And someone was wondering if you would use a volume guarantee in a sick patient like this.
Yes, I would consider it. The problem is if I turn my eye away, then I don't know what pressures we're giving to achieve that volume. So with volume guarantee, my biggest anxiety is that someone is going to end up on pressures of 50 on 20 to generate the volume needed, and then they blow pneumothorax because that's what the machine is telling them to do. So if you are going to do that, you need to stay there and watch exactly how the ventilator and how the patient is behaving on that for at least 5 minutes, and try not be distracted with other things, which in that situation is quite difficult. So it's down to how risk averse you are, whether you want to try that out. But if nothing else is working, then it's absolutely worth trying. But be careful with it because the machine will deliver what is needed and the patient might not like it.
Yeah, I certainly would be more confident in recent years since we moved over to the Hamilton of using a volume mode of ventilation. With the previous Oxylog, it was completely inaccurate and you were dialing up 10 mils per kilo of tidal volume, knowing that the patient was never receiving the 10 mils. So I think that historically we used pressure modes on transport because we had unreliable ventilators. We couldn't believe the volume that was being delivered and there was lots of dead space in the circuit. But I think if you've got a good ventilator that you believe the volume that's given you, volume modes are fine. It just depends on the kit you have in front of you.
Anything else for me on Tom?
I think you answered the question that Tom had. Tom, do you want to jump in about the steroids in this case? So Kostas used steroids. You didn't mention them, and there was a question a couple of times for you as to whether you'd consider that.
Yeah, so actually that's nice. I think there's a point. This follows a journey through arrival, assessment, initial diagnosis, that treatment through to ECMO and recovery. So there are things in there that are not appropriate at the initial stage that become appropriate later on. So steroids is one of them. If you've got fluids and one inotrope, that's not steroids that we needed, but it's not something that I'd be prioritizing without the retrieval team or without someone there. And this is all about the retrieval team. And the same IVIG. So just in case, it is indicated as treatment. It's just not indicated in that resuscitation period. It's going to take hours to give. The protocols are complicated, and it works on T cell modulation. So it's not going to be something that's you give a few mils and your T cells are modulated and you're better. It's going to take time to work. So please understand this is a journey, and some of the things that I will do is because they're not part of the journey at that point, and then later on become appropriate. So steroids, IVIG, become appropriate later on. I see Kostas nodding. Anything you want to kind of add on that, or?
Yeah, so the key with that low blood sugar that I focused on, or the low normal blood sugar, is that you get an insight that this child is likely to be on 2 inotropes very quickly and therefore needs steroids. You don't need steroids there. None of the guidelines will say start with steroids because your sugar is low. But you know that you will need at least a couple of inotropes. So therefore, plan your intubation and your journey accordingly. Pre-draw stuff. Have the adrenaline running before you put the tube in, if the child allows you the time to do so. And that's why it's important. But steroids as a first line, no one will do that, and nowhere does it say that we should do that.
No, probably the most obvious examples, things like blood products. If you give a fluid bolus, if you first fluid bolus with blood products, you do lots and lots of harm. but blood products will become necessary. So it's just knowing when something comes into play.
Okay, guys, I think that's great. Thank you. And in the just due to time, we're going to move on to the next talk. But thank you very much. We're trying to answer some of the other questions in the chat. So now we've got Shilpa Shah going to talk to us about questions from the DGH. Shilpa is a paediatric consultant from one of the district generals in Northern Ireland, and she has some insights on this. So let me get her talk up.
Thank you, Tudor, for the introduction and also being my wingman for bringing up the slides for me and moving them along. And in case you think I'm rambling on, you can move them along a bit faster. So just to say that, as Tudor said, I am one of the pediatricians working in a district general hospital. And I am going to be talking about some of the comments that were relayed to me by my colleagues in various district general hospitals, and my colleagues include anaesthetists, pediatricians, nurses, and other healthcare providers who have been involved in either transfer or stabilization of a sick child prior to transfer. So Tudor, do you have my slides there for me?
Just give me 1 second. I'm just trying
to. Take your time, don't worry.
Yep.
I do intend this to be like a quick to and fro, and obviously during the chat, if there are other questions that are appearing on the YouTube channel, then they can be addressed as well. I certainly don't have the YouTube open there, so somebody could keep an eye on those as well for us.
Okay, so that should be.
Yeah, so if you want to go on to the next slide. So I don't see, yeah. So obviously I did receive feedback. Some of these were corridor conversations and some of these were, some of these were corridor conversations which were given to me personally face to face, and some of these were by emails. But I would like to assure you that I have responses from various district general hospitals. I do understand that this YouTube live broadcast is being viewed by people from across the world, and certainly some of the things that are discussed right now might be in keeping with what happens within their area, and some things might be quite alien. So Northern Ireland is a tiny, tiny, tiny country, but they have their own issues which may be unique to us. But either way, just wanted to start with thanking you all for giving us the opportunity. So if you want to go on to the next slide then. So my plan really is to highlight the positive comments, and might I just add to say that there were overwhelming number of positive comments and responses from my colleagues thanking the PICU team, the retrieval team, for all the effort, the support, and the expertise that has been offered through the years. And I want that to be the main take-home message. Although it does seem like one point there. And then I tried to thematize some of the responses and the questions that were put forward, and sort of some of them maybe logistical and not particularly educational and might want to be addressed at a different sort of setting. But these were the themes. One was the NISTAR availability, which can be a difficult topic to discuss within this conference. The second point was using a single point of contact or coordination or video conferencing facilities where necessary. And I remember Rory pointing out how this would be beneficial. I wanted to plug in the Telelink meetings, which we as a district general team member feel that is a really incredible educational opportunity, and just how grateful we are that they can continue. Wanted to highlight some of the queries around the challenges of time-critical transfers, and I know there were previous sessions which outlined the challenges, but just wanted to bring our perspective through here as well. There were a lot of questions and comments made about the borderline sick, the ones that are not quite intubated, but sick enough that potentially would fit PICU, but the thresholds differ. The borderline age, which is 14 to 16, which is a thorny subject again, and about the unwell, unintubated children. So just saying which children would be, which we would think would be more appropriate for PICU, but PICU wouldn't. So there was just a few wee comments on those. Also some discussion about seizures and questions about those. And I know Seana covered beautifully some of the key issues that were highlighted. High flow nasal oxygen and its ever pervasive uses, which have been expanding through the years as well. So just a few comments on that. And then the last point was made by one of the other colleagues in another district general hospital about receiving feedback from PICU, positive feedback. So these are the sort of main areas to cover. So if you want to move on to the next slide. So just again, wanted to highlight the very positive comments that were made by a number of my colleagues. My anesthetic colleagues in different district general hospitals are incredibly grateful for when the transport service is available, and even when it's not available, to have a conversation about suitability of various induction agents and the process of difficult airway management. So wanted to highlight that. One of my colleagues in a district general hospital highlighted an opportunity when she was awaiting the retrieval team with the view to get the patient across, but as it turned out, things changed, and the transport team were very helpful and supportive in helping with withdrawal of acute intervention and reassigning to palliation. Another comment made was they're always at the end of the phone to provide advice if asked. The kid that doesn't need transferred yet, the kid that is potentially sicker or trickier than usual, and an invaluable resource of a source of help, support in these invariably stressful scenarios. So just wanted to bring in somebody from the expert panel here just to say, in terms of the patient who was initially intended to come into PICU, but then was reassigned to palliation, is that something that you would land up doing reasonably often, or it's a rare event? I don't know who wishes to answer that. Maybe maybe Chris wants to answer that, or
Yeah, no, happy to. It's quite a rare thing, Shilpa. Palliation in the district general hospital is something that is probably the right thing for the child. You know, I think moving them to the intensive care unit sometimes gives the parents false hope that something can be done. And actually, if the district general need help, the retrieval team coming out and helping with that in the DGH is probably the right thing for that child and their family. It feels probably quite uncomfortable for the district general to do something like that they're not used to. And that is something that we're very happy to support with. You know, as a transport team, we have a set of skills that's in that area, and we do unfortunately look after a number of children in the end of life care, and we have expertise in that area. So we're very happy to share that. So it's definitely something we can be involved in. It would be quite a rare situation, though. What we normally find is the district generals aren't happy at all to entertain that, and would quite often would come and move the children to ICU to do that there. But certainly, and it sounds like that was probably the right thing in that situation. Did it work out well for?
Yeah. So the feedback was really positive in that specific situation. I haven't experienced it, but certainly there was significant support and reflection that was very positive. Thank you.
There certainly has been other situations where I've certainly been asked to go out and put a line in a child for palliative reasons, and we've gone out and we've done that, and that's meant the child could get a trial of treatment in their local hospital without being moved to a new team that's not so familiar with them, and again that has worked well too. So we're more than happy to help out with those situations.
Thank you. So then moving on to the other questions then, Tudor, if you could go on to the next slide, please. So as I pointed out, the very first one was NISTAR availability. And obviously we understand that, you know, we're all under a lot of pressure, and in a district general hospital, there are curveballs thrown our way at all times, coming from the emergency department or from the acute ward, the postnatal ward, the delivery suite, or the neonatal intensive care. Some units have bigger intensive cares than other units. So it is a packed area with lots of different areas to cover. And certainly a sick child is obviously sucks in a lot of time and energy and effort and resources. And therefore not having the NISTAR team adds another layer of complexity. Certainly in the bank holidays and weekends, etc., where the cover is patchy anyway. And also there were some comments made about if there isn't availability, is there any private outsourcing that is available? So maybe this is not the right forum for it, but Chris, I'll let you comment.
Yeah, so the first thing I want to say, Shilpa, thank you very much for collecting all these really valuable questions and comments. You shared the presentation with me beforehand, so I can see you've an awful lot in it and really interesting questions from a lot of people in Northern Ireland. The difficulty is we're not the right forum to answer these questions in. Some of us work for NISTAR, others don't. They work from transport teams around the world, and we've also people who don't work in transport teams, and we have no authority here to answer on behalf of NISTAR, particularly in a public forum as well. We're also an international conference where we have an international audience, and you know, the individual policies of a transport team in one area aren't going to be interesting to probably 95% of the people viewing along today. What I have done is I've spoken to our transport lead, and we think these questions are important, and we're very happy to answer them at our Telelink meeting, which thankfully you've mentioned. So we'll get you answers to those questions, but I don't think this is the forum to do it in. I think we probably should stick to general questions about management of critically ill children that will be relevant to most of our audience watching today, but we will get you answers.
Thank you. That's brilliant. So we can move on to the next one then. The other comment that was made, and this is just italicized because I am phrasing it exactly as it was. So the sort of key area was to have a single point of contact where a phone is picked up, information is taken, coordination is done, and then we are informed and supported accordingly rather than making a number of calls. Oh, sorry, okay. So one of the comments was, I would like a one-stop shop where just disappeared there, where we could liaise with NISTAR specialist general pediatricians in RBHSC rather than contacting them separately, but there is a single point of access. That was one comment. And another comment on the similar theme was just a reflection from one of the consultants that in one of our SAIs, the PICU consultant had mentioned the service of single point referral center for retrieval. This central point could receive the call, arrange appropriate levels of retrieval, keeping the DGH updated, and provide different ways, say, for example, an MDT discussion with a PICU consultant or a relevant specialist. And he also said that this service is well established in England, and I'm not sure why it's not happening in Northern Ireland, but worth exploring the views of the PICU consultants. So these were the two sort of comments that I picked out from the lot. So maybe get your comments on that. And is that something that is happening on the ground?
Yeah, so you've really described the gold standard of the way transport should work, Shilpa, and you know, having worked across in England, this is how it happens. You phone into a single centre, there's a call handler, takes your call, and then they are bringing the relevant people in, so you're not having to chase, for example, a PICU consultant round, you're not having to chase up a bed. If we need a neurosurgeon, they're brought into the call. So you're describing the gold standard of the way a retrieval team should work, and it takes the pressure off the person making the referral. They're getting all the people in one call, the bed agreed, and like I say, it's the gold standard. And I'd be interested to hear what the other retrieval consultants here, do they work in a similar system?
I think, Chris, it depends on what your local system is in terms of, if you're commissioned for critical care transport, then you're doing critical care transport. Therefore, the phone call comes to me as the intensivist. I accept or decline the patient, and the retrieval consultant goes out on the call as required. If it's not, so general pediatricians are not involved in that conversation, because if it's a critical care transfer, I would accept them to a critical care unit, and I would do whatever critical care medicine is needed, and then I will link in with whatever discharge pathway is appropriate for that patient. It's not a discussion. If the patient is going to a ward under a specialist team rather than PICU, it is not by definition a critical care transfer. So I will not be getting involved in that conversation. Everybody's pretty busy. You need to pick who your people are rather than bringing everybody in as a one-stop shop if it's not entirely appropriate. So it comes down to what your transport service is actually commissioned for. Is your transport service commissioned for critical care transfers, or is it commissioned to do all transfers? And that's the crucial question.
So it does exist for adult trauma services. So they do a call and send model, where if they arrive in the A&E department, they're critically unwell, the onus is to get them to the major trauma centre, which is the Royal Victoria Hospital. And all the ED does is pick up a phone, say we're transporting this patient and moving them as quickly as possible, and that's it. And it's up to the receiving unit to do essentially what you're saying. Organise the specialties, get a bed secure, and the whole emphasis is to get the sick patient to the area they need to be. For paediatrics, that does not exist, because when they came to commission the major trauma centre, paediatrics didn't really feature in it. So I assume it's all about money, like everything else, unfortunately.
Okay. Thank you. Shall I move on to and I just wanted to plug in at this point the PICU Telelink meetings, and I really want to thank Lindsay, Mark, etc. for giving us the dates out in advance, which helps us plan our team. And we have local champions, so I don't know what's happening within other trusts, but certainly in Craigavon we have an anaesthetic lead for PICU sort of Telelink leadership, and a general pediatrician. And we also have a trainee champion. So I suppose the work is distributed, and also it's very helpful to have the cases identified. But I was just wondering whether this could be even further formalized, have some admin backup, create learning summaries, and maintain a repository of this learning, because this is such an incredible opportunity to meet in relatively real time, because it is happening on a monthly basis, and also lay out an annual calendar, understanding that of course it's really busy and things might have to be cancelled, as a lot of meetings do get cancelled, especially when things are really busy. But I just wondered if there has, and I suppose we can discuss that at our next week's Telelink meeting, but just in terms of even further formalizing the process, is there anything in the pipeline about it?
Yeah, I think this is probably best discussed at the local meeting, but good points.
Okay, thank you. So then we can move on. So one of the consultants and I suppose that this is kind of a comment that involved more than one person, but I have chosen this particular one because I thought the point was well made. So the time critical concept needs to be explored, as I feel that NISTAR team should be able to mobilize themselves as soon as possible and give us an indication of time of arrival to a district general hospital. Sometimes organizing a DGH team and ambulance to do this transfer can take longer if the NISTAR team could be there within, say, an hour to most DGHs. And I suppose, Derry and Earn might take a bit longer. But I know Rory raised this point there, and he did mention that, yes, sometimes, NISTAR could do it, but I don't know if you want to make any further comments on that, Rory, or anybody else, because that was one of the comments raised.
Yeah, I think this should probably be the exception rather than the rule. It's not a complete no to NISTAR considering doing the odd time critical transfer if there's mounting factors against the DGH being able to do it in a timely manner. The difficulty is a time critical transfer. There's obviously something that's critical in it, for example, the child's brain, that needs to get to a neurosurgeon. And the fastest way of getting that child to that definitive care is the priority. And it's not who comes and does it. Generally, coming out to a well, sort of not a child that doesn't need time critical intervention, a retrieval team has been shown to get better outcomes for the child. I think if a retrieval team was coming out to a child who needs time critical transfer, you're likely to get worse outcomes, and that's the reason we ask you guys to do these transfers. I understand there's logistical problems at times. We have the same. We're not sitting in an office ready to go at out of hours. The transport consultants quite often at home at night time, and they'll be making their way in. There'll be preparation of kits and preparing things before they go out. You'll have the journey to a DGH. The average handover and packaging of that patient, even with a quick and there's nothing to do, takes about half an hour. So you're probably talking at least an extra hour of preparation on both sides, journey for that person to come in, the extra journey to the patient. So even if things in the DGH are taking a little bit of time, they still should be able to get the patient to definitive care much quicker than that. And one major bit of advice I was given about time critical transfers, and Rory mentioned it in his talk, is call the ambulance as your first thing that you do. And there's some really good practical advice in Rory's talk about how to get the right ambulance. If you have the paramedic standing at the bottom of the bed, you're not going to put central lines in, you're not going to put art lines in, you're not going to go and do anything unnecessary. That is a reminder to you to get out the door and get that patient to the care they need. So like I say, for 99.9% of patients, the district general hospital should be doing them because we are just too slow. We're not an emergency resuscitation team, and you guys are the best people to move these patients. Doing simulations in your own department, working as how you can speed these up in terms of getting them out the door is probably the key thing, rather than us coming and taking over and doing these ones. Obviously, like you say, there will be that odd one where we might be the best people to come and help. There's a delay. We're actually ready to go, and we could get there quick enough to do it quicker than what you could, and that would be the right thing for us to do that then. But they're going to be incredibly rare that we will be able to do that.
Yeah,
I would back that up, Chris. I kind of feel like, and this might come across a little bit harsh, but sometimes PICU is the backstop of when beds are tight, who's going to be able to look after these patients. When the wards don't feel comfortable, they go to PICU. The buck stops with ICU a lot of the time, particularly from a nursing point of view, because of how highly skilled the nurses are. So they're used around the hospital to plug gaps, which is difficult from an ICU resource point of view. Time critical transfers exist across the world, across the UK, certainly. And in those circumstances, it is recognised that the local team should be doing them because it should be faster. If it is not, or if it's felt not to be faster, the answer to that is not to get somebody else to do it for you. The answer is to review and evaluate your own service and create the improvements that you need to make your service efficient and better. The buck cannot stop with another team, and that is a problem that ICU face in so many regards. So I would bounce that one back and say we cannot pick up the flag for something that should be done, commissioned and led by yourselves, because you are perfectly capable. And the job that district general hospitals do is phenomenal. And they are fully capable of doing it, and they do it exceptionally well.
Yeah, I think the biggest delay is the paramedics getting the ambulance out. So I think there's some really good practical advice in Rory's talk. I imagine, for example, the ambulance might be called, when you're ready for it, rather than when you recognize it's time critical, or, for example, there's some maybe confusion over what type of ambulance you're looking for and the contact number. So I think definitely if that is your time limiting factor, working with your local ambulances and trying to find out how they want to be notified about time critical transfers and trying to get that time down is probably the best way to speed up those transfers.
That makes a lot of sense. Thank you.
I imagine some part of the difficulties is even within the time critical period, there is different variations, and that's I've seen extradurals who are time critical who can sit there for 4 hours, be absolutely fine. I've seen an extradural sit there for 15 minutes and cone, and the same with block shunts. And you have block shunts that someone will watch overnight, there's block shunts that deteriorate really quickly. So if the feeling is that they're stable for a while, the transportation can come and get them, but you don't know what they will do. They're all individuals, so I think that's part of the difficulty, that in time critical there is still variations.
Even within the UK, there's huge variations from region to region, because each region is geographically different. So London is small distances, lots of ICUs. They can get from A to B generally faster. If you work in the northwest, they cover North Wales. There's 32 hospitals, 8 million population. The furthest away point is 3 hours on the road. Scotland is even more challenging. So it needs to be region specific, I would say. So I think London, it's probably easier for the retrieval teams to be there physically and move them in a way that doesn't affect transport time. So if a child needs neurosurgery, it wouldn't probably affect how long it takes for the child to be in theatre. Whereas if you're in a DGH that's an hour and a half, 2 hours away from where the retrieval team is based, you're talking about 2.5 to 3 hours at least before they even get there, plus handover, plus going back. The outcome is going to be much worse if it's an acute surgical problem, whether this is neurosurgical or general surgical, which is generally most of the time criticals anyway. So it needs to be region specific. There's no one size fits all. Scotland is different to London, and so on.
I think you have to be careful as well as a district general team when you're maybe in resus or something, and there's this false impression that, oh, we'll ring to get a team, and everyone stands around and maybe people walk off, whereas you have to bring the team together and say, right, we are the transfer team. And we're mobilizing this patient in such and such a time unless told otherwise.
Well, thank you. Lots of comments to take home. There were a few sort of specific situations of 14 to 16-year-olds which were mentioned in terms of feedback. Now, this might be very specific. This refers to 3 cases. There were 2 cases of pneumonia in a smaller district general hospital, ages between 14 and 16, who required high flow but not intubation. And it was felt that the smaller district general hospital, it would be difficult to manage them within that setting. And then another 15-year-old with a neuroleptic malignant syndrome following a medication with a very high CK with further elevation in subsequent blood tests. And the specific consultant said that the difficulty we have in this setting is that some adult ICU consultants won't answer the phone to us if the child is under 16, and PICU won't take any unintubated children. Now, I'm not sure about the latter comment, whether that is necessarily true, but whether it was only in this instance. So maybe if somebody wants to comment about that, and then the next one is a separate issue. So maybe.
Yeah, so I think with that one, we do take on intubated children. The difficulty with a lot of these cases is getting the unintubated child to PICU. So there's a lot of kids who need extra support in the district general hospital, and that's the right thing to do for them. Although sometimes the district generals are unhappy with doing that support, but they don't have the ability to do it. And the difficulty with that is the only alternative to move those children safely is to put a tube in and move them to ICU, which is not in their best interest. If some high flow in the district general could turn them around. I think a lot of it is, again, maybe Northern Ireland Pacific in terms of the ages. The issue you have is there's different ages for paediatric patients in district generals compared to the tertiary centre, and there's obviously a group in the middle that overlap, and I think that's potentially region specific. But the other issue of the transport is there's a lot of asthmatics, for example, that we're referred. They're sick, but the only way we can put them in the back of an ambulance is to intubate them, and they're not quite sick enough for that yet. And sometimes the DGH is going slightly outside their comfort zone is the right thing for that patient, and maybe putting high flow in a slightly older patient and turning them round is the best thing for that specific patient. So it's not always that ICU won't come and take the patient or won't transfer them. There's quite often there's a good reason behind us not coming out, and the fact that we have no way to move this patient. They're in that middle zone where we just have to wait and see what they do. And the thing is, a large number of them will get better. And if you look at asthma as a major example, if you intubate an asthmatic, as I'm sure Gail's going to tell us later on today, there's a very high risk that you're going to kill them by intubating them. And trying to avoid that at all costs is what we're doing. So some of that may have been lost in translation, but there's often a reason why we can't come and move certain patients.
I think there's also regional variability depending on whether there's...
Yeah, sorry, Ben. Sorry, go on ahead.
No, you're okay. Grant, I was just going to say there's also probably regional variation as to whether centres have HDU sort of units specifically. I know in Belfast we don't with PICU or kind of there's the wards in District General or Children's. Other centres will have specific HDU beds where you may be able to move patients who don't maybe need PICU care, but maybe need often from a nursing ratio more than anything else need that extra bit of attention. So that also feeds into the regional variation.
And of course, if the patient does need ICU and they are 14 to 16, you would take them in PICU, isn't it?
Yeah, and PICU, and I know this is slightly still regional, but we're happy to deviate to that. We take up to 16 in terms of age. Sometimes we will take older patients who haven't been transitioned over to adult care. So, occasionally we will have an older patient who is still under a consultant in the hospital and hasn't been transitioned. But as a general rule, we take up to 16.
Thank
you.
Yeah,
we would do the same. Sometimes we would ask, sometimes our adult ICU, if we're pushed for beds, would take an adolescent if they have got an adult based problem, if it's a drug related problem or something like that, they would take those patients. I do think we need to debunk some of the fear about high flow oxygen, to be honest, because we were doing that in Antrim when I was ST1, which was now a number of years ago that I will not care to mention. And for some reason, the fear of doing that in a District General actually seems to have grown over the years rather than dissipated, and it's a very safe therapy. And I don't consider it to be a critical care therapy. I consider it to be humidified oxygen. And I don't think we should be pushing to move these patients away from their families, away from, where it's local to home, just because they're on high flow and they tick that box, which the threshold to put that on is entirely, subjective on many occasions. If they deteriorate to the point where they need critical care intervention, as Chris says, absolutely, you go ahead and you do that. But I think from an education point of view of how to look after these patients on the ward, that's probably the thing that will make the biggest difference. Take the pressure off your transport service, take the pressure off your ICU bed so they can be used for actual critical care patients, keep families closer to home, better patient-centered care. I think that's the way forward.
True. We'll probably leave the last comment then for Gail's talk later on, because I think she'll cover that. So if you want to move on to the next one. So again, this was covered earlier on by Seana, so it might be answered already, but colleagues in the District General Hospital still have quite significant reservations about trying to extubate a patient that they've intubated for seizures. So Seana, having that guidance that you had put up there is very helpful. The correct patient identification, correct patient selection for extubation would be useful, although I can just highlight the reservations. It's quite a valid reservation there, like who will make the decision. The pediatricians must stay, it'll block a theatre. Is this really feasible? So I just wanted to highlight this comment, but I don't know if you want to add something to it.
It might be worth actually mentioning what happens to these patients when they come to the ICU. So in general, when a seizure patient comes to ICU, we stop their sedation, we wake them up and we extubate them, and they're ready to come back to you within an hour or 2 hours. The difficulty of bringing them to ICU just to extubate them is probably not the right thing when you look at that patient's journey as a whole, because the parents are worried they're going to ICU, and actually you're using up valuable resources of a transport team, particularly over the winter. There may be other children waiting. And the difficulty is, I would almost argue with you that actually keeping this child asleep until the transport team arrive and then get them packaged up and out, you could probably have had them extubated before the team have arrived. I go into theatre occasionally and there's a child trying to climb out of the bed and propofol is being injected in to keep them asleep. And that is not a child who needs to be kept intubated to move to the ICU to be extubated. I think Sean hit the nail on the head with the guideline. There's specific patients we should be doing this in. There's specific patients that we shouldn't be doing this in. And that's probably, we need a regional guideline before we start moving on this. But it is something that we think actually you would have probably less time recovering this patient than waiting for ICU to come out and retrieve them.
There needs to be a culture change, Shilpa. So so I'm talking about the Northwest experience. So when Newt started about just over 10 years ago, no one was doing this in the DGHs. And after 10 years of a lot of education, outreach, trying it out, we have a nearly 75% extubation rate of our fitters in DGHs, and everyone is singing from the same hymn sheet, and people are comfortable, with the exception of a specific population of patients. So, if the CT is abnormal, the trauma cases, we don't push for extubation. Babies under 6 months, which are higher chance for, NAI or encephalitic processes, they're the ones that tend to not extubate. The rest, provided you don't give morphine, you don't give any more midaz for ongoing sedation, and just having them on propofol and then switching it off if they tend to extubate. So it's a culture change that's needed, more education, but it's definitely feasible to achieve in any region. It's not good for the patients to move them 2 hours away where they don't have the social network to support them, only for them to go back the next day. It's just not good use of resources. It's not good for the patient. But I feel the anxiety because it's change, isn't it? It's changed from what we have always done, and it's more work for DGHs who are inundated already. So it's not easy, but it's definitely feasible.
Well, thank you. That was very good insights, and certainly hoping that culture changes. And then we go on to, I think there's only 1 or 2 more questions. I think this bit has already been answered a couple of times. I certainly, my personal experience with high flow is really positive, but again, it is about the patient selection. So maybe just a quick note about who you would feel is not suitable for high flow within the setting of what we have.
Yeah, I think it's the child in extremis or who's obviously heading there. It's picking your patients, as you say. There's a patient that you think you can recover with high flow, by all means, give it a go. And we save intubating lots of children using non-invasive support. If there's a child who very obviously is well over that hill and is rapidly deteriorating, putting them on high flow just delays the intubation. And that's probably what the person at the bottom was describing. It's using it early to prevent the child getting this sick, rather than using it when intubation is inevitable. Although if intubation is inevitable, it might buy you a bit of stability while you're getting the anaesthetist round and getting the child prepared to move to theatre.
Thank you. I think the last bit then, this was just a comment made by one of our DGH colleagues to say it would be nice for PICU colleagues to send back compliments and acknowledgements. I certainly have received positive comments, but I just wanted to highlight this, maybe just in terms of positive feedback, and it potentially could happen at the PICU Telelink meetings, but even otherwise. I remember there used to be a certain consultant who used to send letters just to sort of send a thank you for your positive input, and I thought that was very helpful. But I don't know if you want to say or comment about this, Chris.
Yeah, I think it's a brilliant idea, Shilpa, and it's something we probably should do more of. It's funny, Damien Gates was telling me a story recently. He spoke earlier on, and he actually does this quite a bit. He had actually phoned a midwife up who had spotted a sick baby recently and gave them feedback, and that meant the world to them. And he got lots of letters, emails back from that department thanking him for what he did. So spend some time and a few words of thanks for somebody who's done a great job really does help. And you're right, it's something we should do more of.
I just want to come into this. So my comment has got nothing to do with the transport, but just about a change in practice. So if you're trying to get a culture change, I think giving that positive feedback gives the team an idea that they're doing well. So my example is we do a lot of reductions in our emergency department of fractures. We started it off our own bat, but soon fracture clinics started emailing us to say thanks for what we had done. Good reduction on this patient. Thank you. It makes a huge difference to how you feel about continuing on with that action. So I do think, Shilpa, that is a great thing to do, and I think the team can adopt that or should adopt that, because that positive feedback is going to instill that change within the DGHs as well.
And certainly within the setting of critically ill patients, you know, that because we're obviously on the edge for it, and certainly would reflect a lot on a situation like that, and receiving compliment would help that reflection, obviously.
And what's the system, Shilpa, for the reciprocity of that? Does the PICU get letters to say thanks for taking the patient and things like that as well? Or is there, because I just, you know, I would expect when I arrive to pick up a patient, I would already be saying thanks, great job, you know, you've done really well and all the rest of it. And like, I would expect most transport teams to be pretty complimentary of the district general for getting the patient as far as they have without even needing to be formal about it. I think that's just common courtesy, isn't it? Because they've done such a good job, right?
Yeah, Peter, I can only talk about my own self, and yes, absolutely. I mean, it is a real sigh of relief to see the transport team. I can't thank them enough, and certainly do. Yes, and the ambulance crew get their teas and coffees and you know, little feet up moments as well. But yes, absolutely. I think it's a reciprocal thing, you know.
Yeah, I think sometimes we worry about formalizing just being nice and appreciative of each other, and actually that should just be every day.
Yeah, absolutely. Agree. I think that's, and then just before we go there, I just wanted to show the last slide, which has some acknowledgements. So this is not the exhaustive list of people who gave me their comments, but these are the list of people who were happy enough for their names to come up and the acknowledgements. So I just wanted to acknowledge all of them. And then you can go back to the QR code, Tudor. Thank you. And that's me. Sorry, I've definitely run over time.
No, thanks very much, Shilpa. It's really good, and I think thank you for going and seeking comments from people. And I think they captured a lot of the issues that people face in DGHs around the logistics of transport, but also those children that cause concern, the sick asthmatics, those who are too unstable to move, but everybody feels uncomfortable keeping. So I think it captured a lot of discussion. I think that's the telelink aspect and the feedback. That's what this is about. It's about building those links between intensive care, DGHs, and getting everybody working and get together, feeding back on each other's performance and learning from each other. And that's the whole idea of today. So thank you very much for your time. I was just a slight change to the, we should be having coffee now. Now, Dr. Richardson actually contacted me. She's due to speak after coffee on DKA, but for other reasons has to leave a little bit earlier for work. So she was wondering whether we could move on to do the DKA presentation now, and then we'll take a quick 10-minute coffee break after it before moving into the final two talks of the afternoon. Is that okay with everybody? Yeah, perfect. Okay. In that case, I'm going to introduce Dr. Gyula Richardson, who's a paediatric intensivist here in Belfast, and she's going to share today with us on DKA. So, Gyula, over to you. Thank you.
Yeah. Where's my share? Right. Can you hear me?
Yeah, perfect.
Yep, sorry. And many thanks for letting me go ahead. I'm in work and have got work to do, so
No problem.
I appreciate you letting me go a little early. So I'm here to talk about diabetic ketoacidosis. It will be a topic that many of you are familiar with, and I'm not going to tell you how to do the basics that you do exceptionally well. For those of you that are not from the UK, I would highly recommend the British Society for Paediatric Endocrinology and Diabetes B-SPED guidelines. This has been finessed and changed many, many times over my career. And I think the current guidance is reasonable. I don't agree with absolutely everything in it, but it will work for most patients. So if you're not familiar with it, it is a really good resource. It takes you through step for step, and it will talk about the basics of fluid, insulin, electrolytes. I suppose the one thing I don't particularly like about it is that it's a little bit, they're quite keen on fluid boluses, which I would still be a little bit more reserved about. I think 20 mils per kilo as a bolus is probably as much as you need to give for the majority of patients, even if they're really quite dehydrated. So they go up to 40 mils per kilo. And that is the standard guidance, but I personally wouldn't generally go that far. So what do people worry about in terms of DKA? Sorry about the door. The people worry about the pH. The degree of acidosis. They're really quite fixated on it. Sorry, apologies, at work. They also worry very much about cerebral edema, and they worry about fluid management, more precisely the calculations of fluid. And the B-SPED guidelines that I alluded to before are absolutely walk you through those. So they make it really, really easy. So that's what people worry about, but that is not what I worry about. So what do I worry about? I worry about misdiagnosis. We sometimes label things as DKA when they're not, or we miss DKA. So the classic things are in the mid of winter, when everybody's got bronchiolitis or chesty infections on this side of the equator. We occasionally miss the odd DKA, first of all, treating it as a chest infection, which seems a bit crazy, but it happens. Those of you that can smell ketones will pick it up straight away, but not everybody has that genetic ability. And if you haven't thought about DKA, you will miss it. The other classic things that are misdiagnosis are with children with DKA who get treated as an appendicitis because they have pain in their abdomen. They've got a little bit of acidosis, but actually they've got DKA, and vice versa. Somebody that's got abdominal badness going on and their sugars are high, their pH is high, their lactate is high, but they don't actually have ketones and they don't have DKA. So that's a group that, again, gets missed. And if you don't question, is this a DKA or could this be DKA, and not everything with a high sugar is DKA, then you will miss that. The other thing I worry about is non-response to usual treatment, and we're going to talk about that in a bit more detail. I do also worry about GCS because I'm really not terribly keen to go anywhere near a DKA with a laryngoscope. Their GCS has to be pretty bad and they need to be in extremis before I'd even think about that. And I'll explain that through the course and the case as well. So everybody worries about edema. It's a thing, DKA, edema. So who's most at risk? So new onset type 1, age under 2, because parents and doctors don't pick it up as early because they're in nappies, they don't know they've got polyuria, they might not notice that they're polydipsic. So they turn up a little bit later, or someone that's got prolonged illness. But the truth is it can be any single person with DKA. And if we did an MRI on all the children in DKA, over 50% and maybe up to 80% in some studies have a degree of edema. And it's been the real fear and the driving change of why algorithms and pathways have changed over the years. And we certainly give a lot less fluid these days than we did at the beginning of my career. And we limit in the UK 10% dehydration rather than go up to 15% dehydration, because we've proven over the years that we are really terrible at deciding who's dehydrated and how dehydrated they are. And particularly in DKA, when they're breathing fast, they're going to have dry lips. They've got cusmal breathing. They're usually cold to the fingertips and their edge because they're acidotic. So it's really tricky. Weight in a known diabetic is the most accurate way of knowing how dehydrated someone is. But usually these children in the UK are new onset these days. In terms of cerebral edema, all patients with DKA are at risk, although they're specific groups. It's really important the days that we now swap between shifts and there's not continuity of care, that you hand over very carefully what the conscious level was. And as they arrive, if you're acidotic, you're going to be a little bit confused. That just goes, you know, you're not supposed to function at a pH of 7. You're supposed to function properly at normal pH. So they were always a little bit confused. But a change in conscious level needs to be taken really seriously. And a new onset of headache in the teenage child who can tell you about it. But most of our children can't do that. So they're not going to tell you there's a headache. But it's really important that conscious level is documented and recurrently assessed, ideally by the same person. And it's much more likely to happen in the first 12 to 24 hours. So if you think that you've got cerebral edema, you need to treat it. So I know you've talked about neuroprotection earlier today in terms of TBI. Some of the basics here are the same. So sit the child up. The quickest thing to do is to half the fluids. The current protocol may say differently, and the one at the moment does, but this is the easiest thing to do straight away, and then you can look up what the current guidance is. And then I would give 3 mL per kilo of hypertonic saline, and then I would get the CT. And I would do it in that order, because if you really think this is cerebral edema, treat it, then get your CT. And as I said before, really step away from intubation unless you're in absolute extremis, and in the ideal world you've discussed this with PICU, because we really don't want to do that unless we could make things an awful lot worse. So why do we do a CT? Well, obviously looking for edema, but actually that's usually not what I'm looking for. I'm actually looking for another cause. Why has this person dropped their conscious level? Is it because they're really dehydrated and they've actually got a sinus thrombosis? Children with DKA are at risk of thrombosis. That's why we tend not to put lots of big lines in and arterial lines in, even when they're sick enough to need intensive care, because they're at high risk of clot. Or have they actually bled? Is there something else going on? So the CT is there to look for edema, look for other events, such as sinus thrombosis and bleeding, which are less common. Most of the time these days when we do a CT, it's normal, but not always. So let's talk through a case. So this is a child who's 14-year-old, presented with vomiting, BM25, pH 6.8, the CO2 is less than 1.3. Bicarbonate is unrecordable, ketones are 5. GCS on admission is 13 and respirate is 35. Child is cosmal breathing, and I think we can all agree this child has good DKA unless there's something else in the history that we don't know about. They were shocked in presentation and given 20 mL per kilo of fluids. The GCS then subsequently fell to 9 to 10. While they were ringing intensive care, they had given 3 mL per kilo of hypertonic saline and a further bolus of 10 mL per kilo of fluid at the same time. It's a little bit unusual because on one hand you're trying to treat edema, which we've said is we give less fluid, and at the other side the team believed that this child was still shocked, so gave some more fluid. The GCS rose 13 to 14 and the CT subsequently was normal. They contacted PICU to talk to, they were in a district general hospital. Heart rate was rising, now up to 160. They were cool. The CAT refill was less than 3. Blood pressure was stable and the GCS was fluctuant. While on the phone, the GCS dropped again and the team treating the child gave a further dose of hypertonic saline, but it didn't actually do anything. So the question here was, what are we treating? Is this a child who is obviously severe DKA, who has a low pH, which is enough to make them confused? As they came through the door, they've had good signs of shock, which was treated, but they've also got concerns that this child has cerebral edema due to, and has risk factors for that first presentation, etc. Discussion with the team was this: is this child dry versus edema? We've got a CT scan that is normal, but as we've all been taught, the normal CT scan does not equate to the fact your ICP is normal. So yes, it was reassuring, but was it that reassuring? On further discussion, it really did sound like this child was really dry, but on discussion with PICU, we could not get the local team they were so terrified of edema, cerebral edema, which is the thing we're told about so frequently and the thing that we are told kills children, that they could not bring themselves to increase any further fluids. These were the initial gases at the time of the call. So, where pH is low, and the CO2, those of you that don't intubate regularly will probably not pay an awful lot of attention to CO2 in a DK, because you're looking at you're looking at the pH, you're looking at the base excess, you're looking at the sugar, you're looking at the electrolytes. The child is trying to compensate themselves, and they're blowing off CO2, and it is often exceptionally low. So a CO2 of 1.3, 2.8 is not uncommon in this group of patients. And this is partly why we're not keen to intubate them, because trying to replicate that on a ventilator to blow off enough CO2 is almost impossible. So intubating could actually make this situation much worse and this child is maintaining their airway. So there was no question of intubation at this point. And I would very strongly advise you to, if there is time to discuss, if you're planning to intubate someone with DK, that you talk to an expert about it, because you can do a lot more harm. Just to give you a little bit more background, these were the initial bloods that came back. So sodium's 140, you can see them. For the age of the child, perhaps the urea and creatinine are a little bit higher than you'd expect, and the phosphate is low, which is in keeping with the diagnosis of DKA. The child was collected and transferred to our unit. It took quite a long time, and as you can see, if you just look along, there was absolutely no response with the pH. And again, there was discussion with the transport team in relation to this, but not with the receiving unit. And clearly the current treatment wasn't working. We were absolutely stuck. pH had not moved over hours, and there had been no improvement with the current management. And as you say, draw your attention to the CO2. Look how low it stays. Bicarbonate, most of the time we didn't get a recordable one. Base excess is exceptionally high as well, and keeping with being dry. And the chloride is rising. The lactate was high on admission, but subsequently fell, and the sugar is being treated. Most importantly, on arrival, this child had deteriorated from a GCS point of view. So if you'll remember, we're sitting at sort of 12, 13 at the point of referral. This child's GCS was very definitely lower by the time they arrived in the unit, which was 6 to 8, which is really rather worrying. But she was maintaining her airway. So at this point, standard management is not working. They've treated this child as a cerebral edema, and just having done that, the child has deteriorated from a GCS point of view and has made no progress in terms of resolving acidosis or resolving DKA. So at this point, it would be useful to look at the anion gap. It's typical to have a raised anion gap of 20 to 30 millimoles per litre in DKA. If it's more than 35, it's one of the indications to go, have I actually got the diagnosis right? Is there sepsis? Is there something else going on? Is this right? So the anion gap continuing is maybe due to inadequate resuscitation, sepsis, might be because you've got insufficient insulin to switch off the ketones, or it could be because there's salicylates or some other drug involved that's giving you an unusual picture. So we look at these gases again, and we bring in the anion gap. Now, to start with, it was over that 35 number. It was 38. That's because we had no bicarbonate. But it became more in keeping with a standard DKA. So I think it was reassuring that we had DKA and that we weren't missing something else going on. But the treatment that had continued was not working. So then I go on to look at a corrected sodium, which I wouldn't do for every DKA, but when there is a child that standard treatment is not working, which is unusual and rare, then I look at corrected sodium. Corrected sodium is controversial. Not everyone believes in it, but I have found it really helpful over the years in the very complex, difficult DKAs. I found it a useful thing to do. So tells you how to work out your corrected sodium. If your corrected sodium rises by greater than 5 millimoles in 48 hours, you're probably losing too much fluid and you need to increase the amount of fluid you're giving. On the opposite hand, if it's falling over that time, you're gaining too much fluid, which is a risk for cerebral edema. Now, just to make a point, cerebral edema is not all just about fluid management. Certainly in the past, when we were very aggressive with excessive fluid, it didn't help. But a child that can come in and have, horrendous cerebral edema from before we even start treating them. So it's much more complex, and it's about changes in osmolality and all sorts of things, which are too complex for this chat. If the corrected sodium is falling or not rising is one of the things you need to think about looking for signs of cerebral edema. And I would just reference the paper if you want to read more about the use of corrected sodium. Durward et al. The paper is at the bottom and it's worth a read. And if you work in the UK, the Evelina protocol is interesting and quite a different approach to DKA management. It's not what I would use on a day-to-day basis, but it is a useful adjunct when things are not working out as you might expect. So if we look at if we add in our corrected sodium over the hours, this child had a rise of 7 to 12 millimoles over 5 hours. This all point, when the child arrived, they looked as dry as a stick. They were tachycardic. However, they dropped their GCS. The local team had been too scared to increase the fluids in terms of cerebral edema. To be quite honest, so had our transport team. And I understand why, because it's so drummed into everyone to be careful. But in actual fact, this child was exceptionally dry and we had not resuscitated them. We were not giving them enough fluid. So in terms of fluid management, what did we do? So the first thing we did was change to Plasmolite because this child had been given normal saline. The chloride was rising and was contributing a little to the acidosis. It was not the main problem. So but we were hyperchloremic. At the onset of the concern about drop in GCS and concern about cerebral edema, they had worked out her deficit at 10% and had been given maintenance fluid, which had been reduced by half, and the deficit was being given over 72 hours, which is the current advice for cerebral edema according to BSPED. So what we did was basically go back to, I did consider, will we do something a little bit more complex and a little bit more mathematical and use the Evelina protocol to increase things a little bit. But to be honest, in the next couple of hours, all we did was return the deficit to being replaced over 48 hours, and we returned the maintenance to full maintenance. So we went back to standard protocol. And then as the night went on, this child improved, the pH got better, The CO2 began to rise, electrolytes got better, the lactate went away, the base excess disappeared, and the most important bit was the GCS steadily climbed from 8 up until normal. And by the morning, this child had pretty much, well, normal for ICU gas with low ketones. So the learning from this case is when there's non-response, number one, keep talking to your experts. Do try and listen. It is so drummed into people that cerebral edema leads to death that people are terrified of actually considering that you might need to give fluid. And I understand that. And most times, you know, this is an unusual situation. We're not usually so dry that we're so far behind here, but it is possible. If there's no response, your pH is not improving. And remember, when you start treatment, your pH almost always drops for the first couple of hours and then improves, particularly if it's at the lower end of the scale. So that's normal, but it should improve over the next number of hours. If it's not, review the diagnosis. Are you sure this is DK? Look at your anion gut, look at your potassium, take the history, make sure that actually you have everything you need to have to make DK work and that you're not missing a sepsis or an abdominal disaster. Remember, in DK, not everything is edema. And then look at the evidence. And in terms of that, I mean, look at your numbers, think about it, spend some time. And in the vast majority of cases, standard DK management almost always works. And in this child, had they received the fluid earlier in the piece, they would not have deteriorated and had a GCS of 6 on arrival many hours later. We actually made them worse by being scared, which happens, but we have to be brave sometimes. Thank you. I'll take any questions.
Hi, Julie. Thank you very much. As you say, I think there's the fear sometimes around cerebral edema. I mean, we tend to hold back, and actually that fear can at times then actually interfere with us delivering the care that they need. So I suppose it's taking stock of the clinical situation, look at the patient in front of you and make a decision based on that. I see Gail's hands up, and then there's a question from Gyula, but maybe Gail, do you want to ask a question first?
Yes, thanks. Hi, Julie. Thanks very much. I think you're right. I think we tend to be overly cautious, and we've had a series of patients coming through ED where, you know, they've confirmed DKA on their bloods and their GCS isn't great, maybe 7 or thereabouts, and you end up then, as you say, you're reducing the fluids first and you're getting the CT brain, but the CT brain's normal, and you're giving them hypertonic, and then they seem to improve a bit, and then you're stuck with keeping the fluids down low, although sort of in heart you sort of want to give them more fluid, but you're stuck with the logistics of having a low GCS.
Yeah, and the reality is that we, you know, admission to PICU for cerebral edema or being treated for cerebral edema is relatively common. And to be quite honest, many of the times, if all the other numbers are good, we actually just increase it back. But then we have the ability to be watching them minute by minute. So there are lots of children who get treated for cerebral edema locally and in the UK who actually, when they arrive in PICU, when we've had time to look at everything, see the lie of the land and assess them ourselves, that actually we go, do you know what, I don't think we need to be this mean with the fluids. So we would be quicker to increase, but I wouldn't expect that from a DGH or at ward level. I do think that's our decision. Now, to be fair to the local team talking about this patient, they knew they were dry, but they just could not bring themselves to put up the fluids, and we tried. And to be fair to the team that went out, it's the same. Like, the child looked as dry, like, you know, this was not subtle. They looked exceptionally dry, and we did the wrong thing by holding their fluids back and by just, you know, and I felt nervous increasing it, which seems ridiculous because I had this child in front of me that was clearly dry, but everybody else was too scared to turn the fluids up. So I was like, why is it on me then? So I get it, but it was 100% the right thing to do, and the child got better very quickly, actually quicker than the numbers show. And remember, when your pH is as low as that, it's going to take a while for it to come back up, because it's logarithm.
And I suppose for all the patients that you have with cerebral edema and DKA, which is a small subset, then you're going to have to be cautious with another subset who are then going to not improve as quickly as possible, and maybe that's just a balance.
Yeah, and over the years, I've stood beside children that are definitely in cerebral edema at the point where, is their airway, should I be intubating them? Should I not be intubating? Like, they're really sick, their GCS is low, they're protecting their airway just, and by, intubating a DK, is an undertaking that should only be thought of with a lot, not entered into like, oh, just intubate, GCS less than 8, intubate. That is not at all what you should be doing in this situation, because replicating that really low CO2 is almost impossible.
Thanks, Julie. Gyula, I think, did you have a question you wanted to ask? And then after
yes,
that, we'll move on.
I was just wondering if there's difference between already known diabetic patients. Is there a difference between a normal subcutaneous bolus insulin regime and a continuous pump regime? So is there a difference in terms of how they present with DK and how you can manage them?
So the vast majority that we get at the moment are still not, they don't have a pump. The very little ones would have. I would hope the pump will prevent us seeing quite so much DK in that group. But most of the ones that come to us are new onset DK, because our teams around got excellent diabetologists across the UK, and in all the DGHs there's a lot of good care goes on, and it's much improved with all the technology, and the little ones are going on pumps. But to be honest, I haven't seen any of them come in DK on a continuous pump. I don't know if anyone else has. I haven't.
Shilpa, I think you mentioned about a BSPED addendum, pumps versus pens. Do you want to speak to that?
Oh, yes. So you're quite right, Julie. Obviously, managing diabetes and preventing DK has been the crux of prevention of bringing these children in. If they're known patients. And certainly sick day rules have done a very good job in preventing them. But even so, sometimes known diabetic patients do come in with DK, and we keep the background insulin running on a pump even if they are in DK, and just manage them with fluids, and don't start IV insulin if they're in mild to moderate DKs even. And the ones that are on pens, we keep the long acting insulin running. We give them the long acting insulin. So certainly we modify the management, and it is there as an addendum in the DK pathway as well.
Thanks, Shilpa. And thanks again, Julie, for going early, because I know you're busy at work and you've other things to get on to. So really do appreciate you taking the time to talk to us.
Sorry, it was a bit rushed. Apologies.
No, it was great. Thank you.
All
the best.
Bye.
So I think next talk was due to start at 5. It's now 5:05. We haven't had a coffee break. Will we even give it till 5:05 and aim to start about then? That gives us 10 minutes to get a quick tea, coffee, and get back to the computers. Does that sound reasonable? So we'll cut off now for 10 minutes, and then afterwards we have Gail Davison, who's a paediatric emergency medicine consultant in Belfast, talking to us about acute asthma. So we'll see you back about 5:05 in 10 minutes time. Hello everyone, and welcome back to last session of Paediatric Emergencies 2024. We have a talk from Gail Davison to come on asthma, and followed by 2 of our abstract presentations. So please do stay tuned. I know it's been a long day, but it's been really enjoyable. Hopefully lots of learning, and hopefully you can stay with us till the end. So in the interest of keeping things moving, I'm going to hand over to Gail Davison now. Gail is a paediatric emergency medicine consultant in Belfast, and she's going to talk about asthma. Thanks, Gail.
Thank you. Just getting these slides up. Are you able to see the full presentation?
Yep. Perfect.
Thanks. So as Ben said, my name is Dr. Gail Davison from Belfast. And I'll be talking on acute asthma. And it's within the current theme, obviously, of awaiting the retrieval team. So this presentation aims then to address just specific concepts of near fatal asthma within the management of being within a DGH rather than an exhaustive sort of overview of everything asthma. So we'll be focusing on use of IV bronchodilators, the risks prior to and during intubation, exploring some of the human factors, and looking at post-intubation stabilization. So let's consider a case. It's a hypothetical case. It's an 8-year-old boy called John Knox. So you're working in a DGH one evening and you've been asked to review an 8-year-old boy on a pediatric ward. He presented 12 hours ago with a 2-day history of a cough and coryzal symptoms, and then had acute onset of increased work of breathing that morning, despite 2 puffs of salbutamol at home. In ED, he received 3 back-to-back nebs of salbutamol 5 milligrams and epipropyl bromide 250 milligrams, and then he had hourly nebs thereafter. He also had dexamethasone 12 milligrams and magnesium sulfate 40 milligram per kilogram. So he seemed pretty sick, but actually he improved in ED and then was moved to the ward and was just on 2 liters of oxygen to maintain his SATs at 92. He also had a chest X-ray at admission, and it showed perihilar bronchial wall thickening, just some viral changes and some hyperinflation. On the ward, he was relatively stable for a few hours, but then he deteriorated. And in the last 2 hours from now, he deteriorated, and the ward SHO gave him a further 3 back-to-back nebs, a bolus of IV salbutamol, and then started him on IV salbutamol infusion at 1 microgram per kilogram per minute. On assessment now, his saturations are 90% on 100% high flow at 40 litres per minute. His respiratory rate is 44. He's poor air entry bilaterally. He's not able to speak in sentences. He has a high heart rate and a sinus tachycardia, and he's a high blood pressure, and he appears anxious and tired. And his blood gas, pH 7.35. As you can see there, lactate's high at 4.2. His potassium of note is normal. So for this case, I'd just like you to tell me then what your management would be, looking at the options here. So do you increase the IV salbutamol rate to 2 micrograms per kilogram per minute? Do you repeat the chest X-ray? Do you give magnesium sulfate nebulizer? Do you give IV hydrocortisone? Do you call the PICU team and prepare for intubation? Or the other option there, do you get some physio suctioning and DNAs? So 6 responses so far. We'll just wait to have some more. So just a variation of responses there, but IV hydrocortisone seems to be a top one, increasing the salbutamol rate. Sort of comes thereafter, giving mag sulf, repeating a chest X-ray. I don't think many have chosen the physio. So let's go through them. So intravenous salbutamol. So yes, salbutamol is one of the mainstays of treatment, bronchodilator. The standard pediatric dose is 1 to 2 micrograms per kilogram per minute. Now, this is fine if the patient is 10 or 20 kilogram size. But remember that the maximum dose, which you cannot exceed, is 20 micrograms per minute. So that means if you have a 20 kilogram child and you're starting them on 1 microgram per kilogram per minute, then actually they'll already be at the maximum. So any child who's heavier than 20 kilograms, you'll risk giving them salbutamol toxicity if you don't know the maximum adult dose. So this child had significant salbutamol toxicity with hypervigilance, anxiety, tachycardia, and lactic acidosis. And the lactic acidosis was driving the tachypnea. And this was caused by, you know, the bolus of salbutamol and the infusion at the increased rate, and co-administration of nebulizers. And this lactic acidosis with tachypnea can actually resemble worsening asthma. IV treatment then should be reduced to 20 micrograms per kilogram per minute, and the neb stopped, and you need to monitor the patient for improvement then. So just of note as well, lactic acidosis sort of driven by beta-2 agonists can be distinguished from acidosis driven by tissue hypoxia by calculating a lactate pyruvate ratio. Now, I've never done this myself in practice, but just reading on it. In severe asthma, lactic acidosis is driven by hypoxia, hypotension, and liver hypoperfusion and overproduction by respiratory muscles. Whereas in salbutamol toxicity, the beta-2 agonist leads to increased intracellular cyclic AMP, glycolysis, lipolysis, fatty acid production, and then this diverts the metabolism of pyruvate from the Krebs cycle towards lactate. So in this patient, we could hypothetically expect the type B, where you have a increased ratio greater than 25. So one of the options was a chest X-ray. So a chest X-ray is definitely worth doing on any presentation of a child in respiratory distress, near fatal asthma. Initially sort of to check for any underlying cause, a mediastinal mass, lung collapse, consolidation, and what their expansion is. As well in this patient, because he had improved and then deteriorated, you might want to look for a pneumothorax. So this child didn't have a pneumothorax, but here's what you need to be looking for. Also, we had on the options magnesium sulfate. There's no evidence for magnesium sulfate. There is weak evidence, and it is in the APLS algorithm, but it's only for within the first hour. So for this patient, it wouldn't help. IV hydrocortisone, well, the child's already received a good dose of steroids, but considering that they've deteriorated, it would be worth giving them a dose of IV hydrocortisone, and then they'll likely go on to 6 hourly IV hydrocortisone of 4 milligram per kilogram subsequently, but it probably won't change sort of the patient's outcome immediately. For physio DNAs, suctioning, a bit of suctioning might be fine, but you won't be doing anything extensive because the patient will not manage. So you might want to call PICU just at these early stages, and maybe just to set up, but maybe expecting the patient to improve after you've reduced the salbutamol. PICU would probably rather be called earlier rather than later to be aware of the patient and to maybe guide management thus far. So this patient, so if we're imagining that he's sort of deteriorated further then after you've reduced the salbutamol, then you'd be thinking about intubation. I know we had chatted about this earlier, and Shilpa was querying in regards to intubation. Maybe the patient is too sick to be moved or too sick to intubate. Well, there isn't a magical number or a sort of definitive indication, but certainly the decision to intubate is a clinical one based on hypoxia, based on impending respiratory failure, and based on dropping GCS. So ongoing deterioration at this stage for John Knox would mean you'd be strongly thinking about intubation, and the deterioration is likely not due to bronchospasm at this stage, but due to mucus plugging and alveolar hyperinflation and increased dead space with ventilation perfusion sort of mismatch. And then the need for positive pressure ventilation is more acute. But intubation won't cure the patient. It'll just mean that the disease process is on the end of a tube. So for a sick asthmatic, if John needed intubated after deterioration, then you would be probably wanting to use a 5.5 millimeter micro cuffed tube, cuffed so that you can reduce air leak. You probably want to use ketamine, 1 to 2 milligram per kilogram, and ketamine has a good bronchodilator effect. And you'll be using rocuronium, 1 milligram per kilogram, plus or minus fentanyl, and doing a bit of slow bagging. Now, today we've talked about how teams work together, and we've talked about sort of human factors. And I'm coming from the perspective of working in the pediatric emergency department. So thinking about that, then I've created a video, and on the next slide, I will show a video of a pediatric and anesthetic team setting up for intubation. And I've simulated this to happen in possibly a district general theatre for our patient, John Knox. So for this video, I've one video and then a subsequent video. You can assume that all of the staff know each other's names, specialties, and grades, and you can assume that there's ongoing cardiac monitoring. And you can assume that John had subsequently deteriorated after reducing the dose of IV salbutamol, which meant there was a more acute need for intubation. So while watching the video, if you're able to type some comments into some note function on your device, and then you can paste these in to the Slido when the Slido appears in the next slide. But if you have the comments ready, that would be convenient. Hi guys, so I've just been on with the ICU and the retrieval team, and so a few of you have just joined, so I'll just recap. As I said, this is John Knox. He's an 8-year-old boy. He was admitted this morning, came in through ED, had back-to-back meds and Magsoft for acute exacerbation of asthma, and seemed to get better, but then deteriorated. We started on IV salbutamol, 30 micrograms per minute. We have since reduced that to 20 micrograms per minute, but as you see, he's not great. He's deteriorated. His OBS aren't great. His respiratory rate is 44. His saturations are 90 there, and that was with the high flow on at 100%. He's poor air entry bilaterally. His heart rate's 145. Blood pressure's up 134 over 72. Pillar refill's okay, but he's anxious and he's quite tired. So the advice from PICU is that if we feel he needs intubated, then to go ahead, and they will be here in due course. So considering his assessment, I think it's appropriate to move to intubation. What does the team feel?
Yes.
Damien, your anaesthetic reg.
Yeah.
Are you happy to do the intubation?
Happy enough to crack on.
Okay. And you phoned your consultant?
They're on their way in, but it won't be here on time.
Okay. And do they feel it's okay for you to proceed?
Yes, I've done this before, many times.
Okay. And you've managed children's airways before?
Yeah.
Okay. And what's your intubation plan?
We've got a 5.5 tube, I believe, and we've got some PET and rock 1 milligram per kilogram run up, and I think we should be ready.
Yeah, I think so. Yeah, we're ready.
Yeah. Okay, so you're ready, great. Yeah. And then Amy, you're on breathing, or sorry, you're on circulation, Amy. We'll go to Mohammed, you're on breathing. Mohammed, do you want to listen to the test then afterwards? Dami, is that okay for Mohammed to listen and confirm? And do you want Mohammed to check the sats?
Yes, if you can give it this, do the saturation, which knows is okay.
And do you want to be alerted when the sats are low?
That'll be very helpful.
Less than 80 or?
Less than 80 would be good, yes. We've got all that stuff ready, I believe, to change around.
Grand. And then Amy, you're in circulation. I think it would be worth if you do the drugs, administer the drugs. You've checked the dosages there with Damien, have you?
Yep.
And if you're able to give the 10 ml per kilo bolus.
Grant, I do that now.
After, well, if you give the bolus after the drugs.
Grant, yeah, sure. I do that.
Okay, just to keep that blood pressure up. And then if you just keep a finger on the pulse, then during the intubation and after the drugs.
Yeah. Is that the right size of big probably? Is that, you know what, it's fine. Let's just have that one.
So is everyone ready?
Yeah.
Okay.
Happy for me to go ahead and get
the
Yes.
Go ahead. Okay, so that's the end of the video. So as I said, it's just a simulated sort of setting up for intubation, and the question is, what are the risks of intubation? and how did the team prepare and mitigate for these? Now, if there's any other comments you want to put in, feel free to do so. Constructive criticism is appreciated. So some of the comments: clear handover, S-bar, current situation explained, query about the cardiac arrest prep, hypotension, fluid bolus given, cardiac arrest prep, no clear plan, which is correct. Anesthetic reg, would not do this before consultant arrived, probably right. Risk of arrest, close monitoring, yeah. Did not prepare for difficult airway, yeah. There was no further plan. So yeah, all great points. So we'll move on. We'll have a second video.
Hello, I'm Amy, the Pete's Rage. I've just put to ICU and the trauma retrieval team. They have advised us to intubate if we feel like it's clinically indicated.
Okay. And are they on their way?
They're on their way, yeah.
To give us a ETA?
Oh, sorry, I didn't get an ETA now.
Okay. No, that's grand. Thank you, Amy. So Amy, Mohammed, you've just arrived. So we'll just recap. So this is an 8-year-old boy, John Knox, who was admitted this morning through ED. And went on to the ward, had back-to-back nebs and IV magnesium sulfate, but deteriorated. Was then put on salbutamol, has some salbutamol toxicity, so we've reduced the rate from 35 micrograms per minute down to 20 micrograms per minute. Our clinical assessment at the minute is that he's sort of an extremis. So his respiratory rate is 44, quite high. His saturations are 90%, and that was on the high flow that's since removed. He's per air entry either side. He's heart rate of 145, his blood pressure's up, he's anxious, he's pale, clammy, and he's tired. So I think based on that clinical assessment that it would be appropriate to intubate at this stage rather than waiting any longer. I don't think we have sort of any time to wait because he could deteriorate further and go into cardiac arrest. And we know that PICU are aware that he's here and the retrieval team are on their way. Damien, what do you feel about that?
Yeah, I think I'm quite worried about him really. I've had a chat with my consultant there and we're waiting because I'm really worried about what you said he might arrest. But I do agree that yes, we do have to plan to intubate because we do not have time to spare.
And is your consultant, and are you happy for you to intubate at present?
My consultant is on their way, but I think in the room I'm the most experienced to intubate this child, but I do would, my consultant is going to call me straight away because I'm quite worried about them.
And you've managed children's airways in the past, or you came from adults?
I have.
Yeah, okay, for your experience, that's great. So are you ready in terms of your intubation equipment?
We've got an ET tube ready at 5.5 for our first plan, and another attempt sized down if we have challenges the first one, and our plan C will be LMA until my consultant gets here before we have further attempt. And we have our drugs ready, I believe, 1 milligram per kilogram of ketamine and 1 milligram per kilogram of morphine with flushes.
Okay, that's great. So you have a plan ABC. And did you see our checklist there? Have you been
the
done?
checklist has been confirmed for the pre-intubation. So happy enough, ready to go already.
Okay, great. And then we'll come to breathing. So Mohammed, will you be happy, Damien, for Mohammed to keep an eye on your saturations?
If you're happy, yes.
Yeah.
And my chest and entries as well.
And do you want an alert?
Yes, when it starts on your 18.
Yeah, okay. Thank you.
Okay. And then after the intubation, then Mohammed, if you have a listen, and there might be a chance this child could then progress to tension pneumothorax. So would you be happy to assess for that and to treat for that?
Yes, definitely, I would be.
You're happy with that? That's great. And then Amy, you're on circulation, so you want Amy to give your drugs?
Yes, if you're happy.
Yep, sure, I'm happy. Yeah.
And you've checked them with Damien, have you?
Yeah, sure, Damien. Just double check the doses for me again.
Ketamine 1 milligram per kilogram.
And he is 35 kilos. Yeah. Grand, and they're off Ronian.
1 milligram per kilogram as well.
Grand, great. Okay. Yep. Yep. Got those.
Great, and you have 2 cannula in anyway, so you have 2 access. Now,
circulation might be an issue, and it was great that we were able to get that arc line in, so we can keep an eye on it. But give the first fluid bolus anyway. If the map then drops based on the arc line measurement, if it drops below 70, then give the first dose adrenaline. So the first dose adrenaline is the 1 in 100,000, and you've double checked that with the nursing staff, haven't you?
Yeah.
Yeah, great, that's great. And you've sort of drawn it up there, and there's a 3.5 mils of 1 in 100,000. Okay, that's great. And then you have the rest dose adrenaline as well.
Yeah.
Okay, because there is a chance that this child can go into cardiac arrest. So if a cardiac arrest was to occur, then if you're able to stay on the drugs, and then if that was to happen, Mohammed, if you could get the defib and the ultrasound machine to check for a tension, pneumothorax, and the defib obviously to check the rhythm and deliver shocks. And we'll have our wet flag done, so we're aware of the dunes that we need. Okay, so I've given you a few extra things to get there. Do you want to go and get them and get back to me when you're ready? Okay, hopefully it'll just be a few minutes.
Want me to go ahead and give the drugs to everybody's ready?
Okay, so I'm handing over team leadership to you, Damien. But me and Amy will focus on the circulation if you stay with the airway.
Okay, so that's ketamine going in.
Okay, so that's the second video and the second sort of team scenario. So if you could enter a few comments in. So we appreciate the comments before were that the first team didn't appreciate or didn't set up for cardiac arrest. There was a few sort of failures there. So if you want to sort of even compare, thinking about human factors as well. And I appreciate that in many many specialist centres such as PICU, you know, you've got maybe a team where the team will come together quite frequently and everyone knows each other. Whereas in a DGH, you're going to have teams that don't know each other and don't have possibly a shared mental model until they come together. So we're hearing that it was structured, valid concerns from the reg, intubation checklist used, all to do it in a Mulligan. We don't have anything else. Didn't focus on air trapping. So yeah. Was the first dose adrenaline too high? Well, it's 0.1 mil per kilogram and the child was 35 kilograms. So that's why it was 3.5. Step by step approach, structured approach. Took time to go away and get more equipment. So yes, so I suppose the aspects of that. The bibs are quite good, although we don't use them all the time, but they were created for trauma scenarios. But we actually find that even in simulations and resusces, that the team, by wearing the bibs, go into the roles themselves. As well, I suppose, with getting them to go away and get the equipment and come back, then you've got that closed loop communication, which works very well. And as we know, with the technical side of what needs done for the patient and then the non-technical side, so is Max not too? So we'll just move on to some sedation and ventilation. So naturally, after you've intubated the patient, then you'll be confirming the ET tube position with auscultation, chest X-ray, and expiratory CO2. The sedation for a sick asthmatic then probably want to avoid morphine. So you might want to use fentanyl with midazolam. As you know, morphine gives a histamine release. And then you really want to muscle relax the patient, either by giving boluses of muscle relaxant and then moving on to infusion. Ketamine might be worth adding as well because ketamine has bronchodilator properties also as a ketamine infusion. So in terms of ventilation, yes, I never covered this within the simulation, but slow bagging initially, and then you can manually decompress the chest if you feel that there's stacked breaths, and using the dope mnemonic, with dopes with the S on the end. So what I mean by that is, yes, with a sick asthmatic, there'll be issues with expiration, and sometimes when you're bagging, you bag too quick. So you need to slow down the bagging in order for the air to be released in expiration. But if air has accumulated in the chest without adequate expiration, then you'd need to disconnect the child from the ventilator or from the bagging circuit, and manually press on the chest, and you'll hear a hiss. So you're going to put the child on PRVC ventilation is the standard, and the respiratory rate, you really want it low. So you're probably going to start with the normal respiratory rate and lower that subsequently. The tidal volume, you want between 4 and 8. And then the expiratory time, you want good expiration. So you maybe start with 1 to 2, and then move that on to 1 to 3 or 1 to 5. As you can see from these sort of ventilator flow curves, you can see the first one there, A, is normal. So you have inspiration and then a full expiration where the line is going up, going back up here. So there's been full expiration. Whereas in B here, you've had inspiration and then expiration has been insufficient and it hasn't reached the line here. So there isn't adequate expiration. In this circumstance, sort of where you're seeing this, then you really want to reduce the respiratory rate and increase the expiratory time to optimize ventilation. Other therapies, just the PEEP as well, you probably want an adequate PEEP in order to keep those alveoli opened that you've recruited. So a PEEP of at least 5. In terms of pressures, so for a sick asthmatic, you'll really be using quite high pressures that could go up to 40. The peak pressure isn't as important as the plateau pressure. So the plateau pressure, you'd want that to be less than 35. And here you can see, you've your peak inspiratory pressure, but you've actually got your plateau pressure here. And if you do an inspiratory hold, you'll be able to find out the plateau pressure. And the plateau pressure is what is the pressure being delivered to the alveoli. So that's why it's more important to identify the plateau pressure. The peak pressure will give you the pressure in the airways, but by doing the inspiratory hold, you're allowing the gas flow to settle, and then identifying the plateau pressure. So you'll be wanting to obtain permissive hypercapnia. You won't be wanting a normal CO2. And in the expiratory CO2, you'll be wanting to aim for less than 10. If you were to try and gain a normal CO2, then you would likely cause barotrauma, which wouldn't be good for the patient. And you'd want to aim for a pH of greater than 7.2 and SATs of over 92. So additional therapies, which we won't be covering in this talk, would be ECMO, DNAs via bronchoscopy, physio and SIVO. But as this talk is about the retrieval team coming out, then that would be further therapies that are beyond the scope of this talk. So I actually had a slide on take-home message, but I think this is possibly Peter's slide coming up. Maybe we have the same slide, Peter. If you want to add to that slide, you're welcome to. Or put up on the YouTube chat. But that's me. Thank you very much for listening. And there's the feedback code.
Thanks very much, Gail. Appreciate that. As you say, it's one of those scenarios that you don't want to intubate unless you really, really have to. But if you do have to, then it's about taking the appropriate precautions, making the team aware of the risks, and thinking it through. There's a question come through around salbutamol toxicity, and if there are shown signs of salbutamol toxicity, would you consider switching to aminophylline instead?
I suppose when you're starting your bronchodilator, usually in a DGH or any hospital, you're selecting one or the other, your salbutamol or your aminophylline. I suppose with any medication, then there's the risk that you're going to have side effects. And with salbutamol, this patient had salbutamol toxicity. Whether you want to then, I suppose the main thing that I was getting across was to reduce it down so that you had the bronchodilatory effects, but that you had those effects without the toxicity effects. Yes, I suppose theoretically you could completely stop the salbutamol and then move on to aminophylline. But you probably have good enough therapeutic effect from salbutamol and could just reduce it down.
Yeah,
Peter,
I
do you
think
want
that's the an aminophylline itself is equally toxic. Neither of them are good. The evidence, I guess, around IV bronchodilators suggests there's evidence for mag-sulf ahead of the other two, but between aminophylline and salbutamol, there's not a big difference, and there is a regional variation in that.
And this patient already had mag-sulf, and yes, you could push mag-sulf boluses as well. And I know a lot of units use both aminophylline and salbutamol together.
Yeah,
but not much evidence for that.
Peter, do you have your hand up? Do you want to comment? Or?
Yeah, I've got loads of opinions on asthma, particularly asthma that's going to end up in PICU.
It's 20 to 6, so
yeah, well, I could talk
P1s.
about this for 3 hours. But yes, IV aminophylline, ban IV salbutamol. It'll work by nebs if it's going to work. Get rid of the IV stuff altogether. Move on to the other parts of the pathophysiology and get on with it. Stop delaying. Get good physio. Don't manually decompress the chest just because you want to manually decompress the chest. If you want to manually decompress the chest, do it in the form of physio, because then you're actually addressing the pathophysiology, which is mucus plugging, and you can justify that in a court of law. Otherwise, you're compressing the IVC that's already got reduced blood flow into the heart, and you risk a cardiac arrest. So you have to be able to justify it. So if you're going to do it with physio, because it'll be more productive and more useful. But yeah, I'll not keep talking because I could talk for about an hour.
Yeah, I wouldn't mind making a few comments as well. I'll try and keep it short. Me and Peter argue about this every year, but I think the biggest thing for me with this one is recognizing why these kids arrest, and they arrest on induction because of air trapping. You're putting air in that won't come out. It impairs the venous return coming back to the heart, and they arrest. And out of all the things in your pre-intubation brief, that's the biggest thing to mention. So remind me to bag this patient slowly. If the patient deteriorates, the first thing we need to do is disconnect them from the bagging circuit or the ventilator. And whether you do or don't decompress the chest, you need a way to get that air out of the lungs. You can either disconnect the tube and let it expire passively, which is Peter is advocating. I'm a pusher on the chest, and I've never had a kid arrest doing it, but we'll argue about this every year. And that's the big thing about intensive care. There's different ways of doing the same thing, and as long as you do them successfully, that's fine.
I wouldn't passively do it, Chris, either.
You don't?
I think if you're going to decompress it, you do it in the form of physio, because then you're treating the pathophysiology.
I think I would have to argue with you then, Peter, because I don't think you can leave a peri-arrest patient and say you're not going to disconnect them from the ventilator or the bagging circuit when you know they've got air trapping while you're waiting for physio to come in.
You can. Oh, I do my own physio, and maybe that's the difference.
Yeah, it might be, but
I think it's 20 to 6. Well, maybe agree to disagree on that one. I think we could be here for the next hour.
Yeah.
Don't let the physios let you hear you say.
I don't wait on. I don't know where you guys. Well, I don't wait on other people to come in to rescue a scenario.
Yeah, I rescue by manually decompressing. It works very well.
Yeah,
right. I gotta, as a chair, I gotta step in, and we're gonna move on. I think, just in the interest of time. Gail, thank you very much for that presentation. I'm now going to hand over to Costas, who's going to lead on this, the final section of today, which is our 2 abstract presentations. Really delighted. This is a new addition over the last sort of couple of emergency days. So looking forward to this. And Costas, over to you.
All right. So we opened the course to people to submit abstracts this year, as we did last year. We had quite a solid competition this year about interesting cases that were clinically challenging that presented in the emergency department and the PICU. And after a lot of deliberation, we concluded in 2. And the first one to present is Dr. Fiona Mendes, and I will let her share her screen next.
Hi, can I just check you can see my screen?
Yes, we can.
Okay, great. So hello everyone, I'm Fiona Mendes, an emergency medicine doctor with a subspecialty in pediatric emergency medicine. Thank you for the opportunity to present today. This case presentation was encountered earlier this year when working in the pediatric emergency department at Whipps Cross University Hospital, based in East London. A 15-year-old male presented to our pediatric emergency department with vomiting and generalized abdominal pain. His mother also worked at the hospital. He had reduced eating and drinking due to nausea. He had no fevers or diarrhea. He was passing urine, but this was reduced in volume and frequency, and he had no other urinary symptoms. There was no reason for travel, and no other contacts were unwell. He had initially told us that he didn't use any recreational drugs or alcohol, but he smoked occasionally, and he had been previously well. His mother was concerned that he was missing some school due to his symptoms, which were similar as this presentation, and they would occur every few months, but usually ease after resting at home. On examination, he was very anxious, appeared unwell, and was clinically dry with a resting tachycardia. Of note, his abdomen had superficial erythema from using hot water bottles. His abdomen was soft with mild generalized tenderness, and this was variable on re-examination. So initially, he was treated for viral gastroenteritis. Our differential diagnosis included an early acute appendicitis or mesenteric adenitis, but these seemed less likely. On review, however, he didn't tolerate his oral fluid challenge. Blood test showed an acute kidney injury, a raised lactate of 6, hypoglycemia and hypokalemia. His ECG had a sinus tachycardia. His urine analysis shows raised ketones in keeping with his dehydration. He was admitted to the children's ward for further management, and he had an abdominal ultrasound which showed no abnormality. He required intravenous fluids and intravenous ondansetron. His electrolyte abnormalities were corrected. His hypoglycemia was corrected with oral glucose and hydration, and his tachycardia settled with rehydration. As his nausea and vomiting eased, he was able to tolerate oral fluids and food, and his urine output was measured and increased. However, his pain was still poorly controlled with paracetamol, ibuprofen, and codeine. When his mother was called away, the pediatric team took this opportunity to perform a HEADS assessment, which is a psychosocial assessment assessing the physical, emotional, and social well-being of adolescents to create this holistic picture using structured questions. And it was then that he disclosed his long-term cannabis use. His use had gradually increased during the pandemic, lockdowns, to manage stress related to school. And he was very reluctant to disclose this in front of his mother. He had grave concerns that he would be in trouble, or that his mother would be in trouble with the law because he had hidden cannabis in his bedroom, or that she could lose her job at the hospital. And so he didn't want his parents to know about this, although it was later revealed that they had suspected that he was smoking cannabis. Cannabis would initially ease his nausea, and so he increased his smoking of cannabis every 2 to 3 days. And then he would develop this persistent vomiting, and where he was concerned that he would no longer be able to smoke cannabis. After a few days, the symptoms would then ease. He discovered unintentionally that using hot water bottles and hot showers could help ease some of his symptoms. So he was managed for suspected cannabinoid hyperemesis syndrome. This involves cyclical nausea, vomiting, and abdominal pain associated with prolonged cannabis use. Cannabinoids are compounds derived from the cannabis plant or as synthetic compounds. The pathophysiology of this diagnosis is unclear, but research has suggested several mechanisms. So for this case, Talkspace was consulted. His creatine kinase levels were checked retrospectively, and they were slightly raised, which were corrected with IV fluids. He had 2 separate urine toxicology screens performed, and they both were positive only for cannabinoids. His acute symptoms were managed with topical capsaicin cream, ondansetron, and oral rehydration, and his acute symptoms settled after he stopped using cannabis. He required a lot of support to understand the link between his cannabis use and the symptoms, and to discuss this with his mother. And he continues receiving support in the community for the psychosocial aspects of his care. Recent conferences from the Royal College of Emergency Medicine over the past few years have highlighted that cannabis use and the prevalence of cannabinoid hyperemesis syndrome have increased, associated with increased cannabis use during lockdown. During the pandemic lockdowns, there was increased online purchases of grow your own cannabis from seeds for home cultivation to ensure that there was a consistent supply of cannabis. There were lots of online resources and popular TV shows showing cooking with cannabis. And this may have led to adolescents to form the misconception that cannabis is harmless. During the lockdowns, party drugs or nightclub recreational drugs such as amphetamine, ecstasy, or MDMA, those drugs reduced, but the cannabis recreational drugs increased. And this was in keeping with the slogan of keep calm, stay at home, and smoke weed. So cannabinoid hyperemesis syndrome is a clinical diagnosis after excluding the medical and surgical pathological emergencies. The diagnosis requires a prolonged cannabis use history, and there are no specific investigations to confirm this diagnosis. However, this table shows the common characteristics of cannabinoid hyperemesis syndrome and the frequency in which they occur. It's important to note that it's unlikely that the definitive diagnosis of cannabinoid hyperemesis syndrome will be made in the acute setting or in the emergency department because of the diagnostic criteria required. However, having an awareness can help clinicians support and manage patients that present with these classical features. And they may unintentionally discover that hot baths and showers relieve some of their symptoms. The literature describes 3 phases of cannabinoid hyperemesis syndrome. The first is the prodromal or pre-emetic phase, where patients have nausea and mild abdominal pain, and they may believe that if they increase their cannabis use in this stage, because of its antiemetic properties, it will stop the symptoms. However, with increased use, this then pushes them into the hyperemetic phase, and this is when they're most likely to present to the emergency department or seek medical opinion, because they will have severe nausea and vomiting and severe abdominal pain, and they may have some of the complications which are serious and fatal, such as dehydration, acute kidney injury or renal failure, electrolyte abnormalities, or hypoglycemia. And then if they're too unwell to continue smoking cannabis, their symptoms may subside as they enter the recovery phase, and with treatment. When they enter the recovery phase, they may then feel that they are better enough to smoke cannabis again, or use cannabinoid-containing products, and then that pushes them back into the hyperemetic phase. So the most effective treatment is stopping cannabis completely to break that cycle. But because of this paradox of with cannabis having antiemetic properties, it's difficult for patients to make that connection that their symptoms are related to their cannabis use. It's also difficult for them to stop completely without psychosocial support and community-based support, because they need to address the underlying reasons that's causing them to use cannabis as well. So in the immediate management in the acute setting is usually rehydration, either with oral fluids first and then intravenous fluids if required, and antiemetics. If traditional antiemetics don't work, then it's recommended to try intramuscular haloperidol. And capsaicin cream, which contains a derivative from chili peppers, ideally the 0.1% solution, applied topically to the abdomen can help alleviate some of their symptoms. The Royal College of Emergency Medicine released recent guidelines on this, and it recognizes that it's an emerging and challenging diagnosis, and and as cannabis use increases, particularly in younger people, this is an emerging diagnosis too. It's important to encourage disclosure, though, and adolescents in particular may be really fearful of the legal consequences or getting into trouble. So in the emergency department, it's important to create a safe space and encourage them to disclose their cannabis use. So the key learning points from this case were teachable moments, recognizing that there's a connection between, for patients to make the connection between their cannabis use and their symptoms before any preventative measures can be instigated. The HEADS assessment in this case helped us uncover this diagnosis. Without this, this diagnosis could have easily been missed. And then patient-centered care, so thinking about alternative diagnoses and other treatment options when the presentation doesn't fit the diagnosis already made. These are my references, and I'd like to acknowledge the patient and their mother who were really keen to share this case, which we're grateful for. And I welcome any questions or comments. Thank you.
Thank you, Fiona. That was excellent. I'm just trying to see if there are any questions on YouTube. No, we're in the clear. There doesn't seem to be any questions. Okay, thank you very much.
Thank you.
So the next presentation is also quite a fascinating case. It will be presented by Dr. Mortaz Elashmawy.
Hello, everyone. Can you hear my voice okay?
Yeah.
Okay, I'm just gonna share my screen now and hopefully it works. Can you see my slides okay?
You can, yeah.
Oh, perfect. I'm cautious. Everyone has been here since 8:30 and I have only 10 minutes. So, so my name is Mortaz. I'm one of the pediatric registrars working at Edinburgh's PICU. I'm gonna take the following 10 minutes to present an interesting case for a child who's been struck by lightning. So I'm gonna try to, in the next 10 minutes, to try to raise the awareness of lightning strikes injury, and obviously try to give you a little bit of insight into how to assess cases in ED, and highlight some of the common injuries from lightning strikes. So I'm gonna start with a sort of a pre-alert of a 13-year-old who was struck by lightning on a playfield. He stopped breathing, but received a bystander CPR straight away, had an EED put on by the people around him and got one shock. So air ambulance was notified and attended straight away around 20 minutes of the incident. He was intubated on scene, received 1 dose of adrenaline, and received magnesium and calcium corrections. He had ROSC estimated around 30 minutes from the initial alert, and en route he was noted to be arrhythmogenic but had a stable blood pressure, cautious of stable. So you being an ED, on your initial assessment, so he's intubated on scene. He had a reduced air entry on the bases with brown aspirates from the ET tube. He had a very weak pedal pulses. GCS was 3 out of 15. Obviously, he was sedated. He had extensive bruising noted, mostly on the lower limbs. His initial observations, he had a temperature of 35.5 with a heart rate of 135 and blood pressure of 144 over 104 with a MAPS of 121 with resp rates of 16 and FiO2 of 60%. So on the bedside, your initial investigations would be getting a blood gas, I hope so. So a pH, so the blood gas had a pH of 7.1 and a CO2 of 6 with a good going base excess of -12 and a bicarb of 16.3, lactate of 2.5. And that was his ECG. I'm keeping my eye on the YouTube comments as well. Can you define one abnormality? Just one. Yes, we've got T inversion and a biphasic, yes. So we can see, I'm gonna try to get a laser pointer. Hopefully you can see it. So we can see a sort of pre-mature ventricular ectopics here, sort of a triple tri ones, and two sort of premature ventricular beats here as well. And there is lots of yes, we've got an ST elevation in V2 and V3, perfect. You can appreciate there is some interference on this ECG. There is another one as well. This more obvious. So we've got a, obviously if you look at the inferior leads and you've got an STV elevation, lead 2, lead 3, you've got an AVF, and you've got on V4, V5, V6, and V3 as well. So his initial bloods, full blood count was unremarkable, but you can see on his chemistry profile and cardiac profile, he's got a CK of 10,000, arising 1, and his initial troponins were more than the lab reference. I think the lab limits were above 25K. So what's happening? So with lightning strikes, you get a difference in the electrical potential between the clouds and the ground, and it's usually more than 30,000 volts. This generates a very good going currents that vary up to 100K, 100,000 amperes. And it is estimated that you've got 44 flashes that occur per second and 1.4 billion flashes in a year. 24,000 people are thought to die from lightning-related injuries. So you can probably tell how lucky or unlucky you are if you are on call on that day. So the basic understanding is you've got an extremely high voltage on a very short and extremely short duration, around 10 to 100 milliseconds. And if there is one takeaway to take away from this presentation is the electricity travels through the path of least resistance. So you've got nerves, then bloods, then muscle, then skin, then fat, then bone. And it helps you sort of decide what you will be looking for in a patient who's presenting in such presentation. So the one that you see in the movie is where the lightning strike hits the head. That's very rare. So this is what we call a direct strike. 50% of the children who's having lightning strikes, what happens is the lightning will travel through the ground and then to the victim, and then will strike on one of their feet. Obviously, we've got a side splash and contact injury. So contact injury would be if you essentially in direct contact with whatever object that got hit by lightning strike. And a side splash is essentially where you the current jumps to the victim, but not in physical contact. So taking the previous slide, so you will have a cardiorespiratory arrest. You can have a cardiorespiratory arrest. You can have all different types of arrhythmias, including asystole, VF. You've got lots of ST elevations and QT prolongation. You will have an ARDS and aspiration from a respiratory point of view. And you, from a neurological point of view, you can get immediate and delayed sort of insults. So cheronoparalysis is which it's a condition that would mimic the spinal cord injury, where because of vasospasm you've got a motor and sensory changes, which can cause cyanosis, pallor, and pulselessness, and it's mostly on the lower limbs compared to the upper limbs. But this tends to sort of resolve after some duration. But obviously you can get some things which are permanent, like an HIE and a progressive myelopathy as well. You can get cataracts as well. You can get optic nerve injury. Tympanic membrane rupture mostly resolves spontaneously with conservative management. Autorea, you can also suspect skull base fractures, and you can get permanent hearing loss. There is also a very famous Lechtenberg figures. I'm not sure if you've seen them, which is like a sort of a transient feathering patterns, which you get from a lightning strike, and full thickness contact burns and punctate burns. So you can see how the pattern of the bruises that can take shape on the lower limbs. So it's really important to highlight the cardiac effects when you get a lightning strike, and it's mainly to point on the vasospasm and vascular injury, for which it causes myocardial ischemia and infarction, as well as can potentiate to a sort of ventricular failure and myocardial stunning. But at the same time, you get the catecholamine surge as well because of the strike, which gives you more arrhythmias and also predisposes to myocardial stunning. So for our patient, he had an echo which on day 1 which showed severe impaired systolic function. He was started on melrinone, and that choice was mainly because of the function of the melrinone in sort of improving the inotropy, improving the heart contractility, at the same time giving a little bit of vasodilatation by relaxing the smooth muscles in the blood vessels. He was planned to have a cardiac MRI once he got into a stable position, and close monitoring of renal function to consider him to have any sort of filtration. He did have a repeat echo on day 3, which showed slightly improved function. On day 4, his paralysis was stopped and his feeds were started, and melrinone was titrated. And on day 5, he was stopped, melrinone was stopped, and sedation was stopped. He was extubated into air on day 6 from his presentation, and he was discharged from PICU for rehabilitation on day 8. He had a further serial ECGs. So on day 3, he had a slightly improved ECG in terms of the less sort of ectopics, but he still had some element of ST elevation. This was his ECG on day 5, which also continued to improve. And his chemistry before discharging from PICU showed that troponin came down to 5,500. He was discharged home 6 weeks after being stepped down. He did have some oral captopril for the management of his hypertension. He did regain his cognitive function and neurological status, and it was on an improving trajectory. And he used to play football, and he's now back to playing football again, which was really encouraging as well. Obviously, he's having continued neurology and cardiology follow-up. Thank you. I hope I didn't cross my 10 minutes.
Thank you, Martaz, for that very, very frightening presentation. Yeah, I'll now
for any questions.
To any questions? Can you stop sharing your screen, Martaz, so I can share the vote for the group?
Yes. Has that been stopped now?
Yeah, and I'm sharing my screen. Can you see my screen?
Yeah, we can see your screen.
Yeah, so please vote which of the 2 fabulous presentations you like the most. The winner gets a prize. Neck and neck.
I would have to say very exciting.
You think, Chris, let's go to 50 votes? Or I think are we peaked?
Yeah, I think that's okay. We can give it another 30 seconds or 50 votes, whatever. I think they're drying up the views this time of the day. I've gone out just while the votes are coming in. I'll maybe mention about the prizes if that's okay. So actually this year we do have 2 prizes. So a big thank you to our sponsors. Northern Hospital Supplies and Technopath have both supplied prizes. So I'll get in contact with both of you afterwards. And we've got 2 prizes to give out.
Oh, late surge. Okay, we've got 51 votes. I think lightning strike edges it. Well done, both of you. That was very close. Fascinating cases. Generally, what happens when I'm on call? Some weird stuff comes out the woodwork. Well done. So we'll be in touch about your prizes. And Chris, you have the honors of closing the day.
I think Ben was going to close actually, but if he's not there, I'm happy to.
No, I'm happy. Thanks, Costas, for chairing that last session, and thanks again to Fiona and Motaz for two interesting cases. And with that, Paediatric Emergencies 2024 comes to an end. I'd just like to start by thanking everybody who's joined us today. Hopefully you've enjoyed it. It's been educational. We really enjoy the fact you've interacted with us in terms of the questions through the chat and Slido. And as I say, hopefully it's been a good learning experience. I'd like to also thank all of the panel members here and also all of those who give talks today for the work that they put into that. A special thanks to Chris Flannigan for all of the work that goes on behind the scenes, setting this up, organising it, and on all of the Paediatric Emergencies work that he does. Don't forget, before you go to do your feedback, so that you can get your certificates of attendance. And as we said at the start of the day, although the course is free, if you find it interesting, you find it educational, we'd really encourage you to leave a small donation for our hospital charity Help in Hand. They've been very good to Paediatric Emergencies in terms of supporting us, and it's been lovely to give them something back. There is a link through the website, the Paediatric Emergencies website, so please do, and if everyone give even just a very small donation, it would make a big difference. So please do consider that. And with that, thank you again for joining us. Hopefully we'll see you at future Paediatric Emergency events. And with that, good evening and thank you.